delegates who have joined us offline as well as in online mode. We welcome you all to the 8th World Dental Sciences and Oral Health Conference and International Dentist Convention organized by CynoDent International and Indian Society of Dentistry in collaboration with Department of Periodontology and Implantology, Faculty of Dental Sciences, King George Medical University, Lucknow, and King George Society of Periodontology, KGSP. Theme of the conference is recent advancement and trends in dentistry moving towards a bright future. On 6th and 7th September, we had pre-conference courses. Today, we have started with our keynote lectures and scientific session. I would like to invite my co-host, Dr. Anam Siddiqui, to introduce our speakers.
The first speaker of the day is Dr. Piyush Shivhare sir. But before I invite sir to stage, I would like to give a brief introduction of sir. Piyush Shivhare sir has completed his BDS in the year 2011 and then he underwent specialty training in oral medicine and radiology and was awarded MDS in the year 2014 from Rajiv Gandhi University of Health Sciences. He has nearly 8 years of experience in teaching and he has worked in prestigious institutions in India, including Banaras Hindu University and All India Institute of Medical Sciences, Patna. He has undergone fellowship in TMD orofacial pain and dental sleep apnea from Roseman University, USA. He is the author of 7 textbooks, including Textbook of Oral Medicine and Radiology. He has also published more than 40 articles in several national and international journals, along with 7 textbooks and 3 copyrights. It's a pleasure to have you here with us today, sir. Welcome on stage, sir.
Good morning, everyone. So today we'll present. I'm going to present about a very common topic, and which is very common in a clinical scenario. That is going to be a muscle pain. So we'll start without time wasting. So orofacial pain, it is a general covering any pain which is felt in mouth, jaws and face, and very common clinical scenario. The patient suffers and patient refers from one clinic to another clinic, but still pain persists. So International Association of Study of Pain has defined pain as an unpleasant emotional experience. Obviously, pain cannot be a pleasant, which is associated with actual or potential tissue damage or describing such. This is a very common definition and every students know about that. The classification, we have already know that there is two types, axis 1 and axis 2. So axis 1 is there is a physical condition, axis 2 is psychological conditions. We all aware of this classification. Now what I am going to cover is the muscle pain. So because muscle pain, this is too complex, and most of the time pain refers or radiates from the muscle pain to the adjacent structures, and we concluded in a wrong diagnosis, we treated in a wrong way, and at the last patient will suffer. So the diagnosis part and the management part is very much important for the myalgic pain. So think about the scenario here. This is the video taken from the internet, and the person is saying that to increase the masseter hypertrophy or the beautifulness, he has taken a multiple chewing gums and he chew for multiple times a day for a month, and then he is showing that the result is very good. Now I am thinking maybe the masseteric hypertrophy will be there, but what about the sustained contractions and pain which is going to suffer the patient? So personally I don't think that it's a good advice to chew multiple times, because it's a physiological phenomena. After that, patient will come with the complaint that doctor, I am not able to chew, or feeling pain irrespective of no dental pathologies. We have taken radiographs, no radiological findings are there. Still patient is not able to yawn, patient is feeling tingling sensation, is not getting proper sleep, or restricted mouth opening, or multiple doctors has been referred, but still patient is suffer. Now what first diagnosis we take, okay, there is a there is an impacted tooth. Now because of the impacted tooth, we think that might be there will be a pain. But if impacted pain, many of us we have impacted tooth, but still we don't have any muscle pain. So an impacted tooth without having any clinical or radiological findings cannot cause a muscle pain. Then sometime what happens, sometime we directly jump to a muscle pain, and actually it is an odontogenic pain. Maybe there is a third molar decay or some other findings, but because we have attended a lecture, then we directly come to conclusion that yes, maybe it is a muscle pain. So it can be a both side misdiagnosis, and we have to take care for that. So it is an incomplete examination or wrong diagnosis. So what are the masticatory muscle disorders? So it is a complete chart given in favorite book occasion, and they have multiple types of myalgic pain. I will be covering one by one. So what are the etiological agents? So etiological agents, it can be divided into local factors or systemic factors, and this is the most important part before diagnosing the muscle pain, because if your diagnosis is correct, still if you are not able to treat the local factors or systemic factors, then obviously the treatment schedule is going to be failed. For example, a patient having a sustained stress and you are treating it with a muscle relaxant, it is not going to work. If there is some systemic issues like vitamin D deficiencies or a polycystic ovaries, if you give multiple treatments, you have given all these splints, you have done all the enameloplasties, everything great work you have done, but still you are not thinking about the systemic issues, obviously patient going to suffer. So there are multiple factors are there, like trauma, microtraumas, occlusal disharmonies. Like there are two school of thoughts. One says the occlusal disharmony doesn't have any role in temporomandibular joint. Another school of thought, they think that no, occlusal disharmony is an important aspect and it has to be treated. For me, I respect both. The patient should not suffer, he should get relaxed. Now, how stress is so important for muscular pain? Like whenever patient comes to you with the muscles pain or temporomandibular joint pain, first important thing is the history should be stress. Because stress, they have the immunomodulatory reactions also, and they have the effect on the muscles. They release catecholamines, and those causes sensitization of muscle spindles. They increase the tonicity of muscles. It can result into bruxism. They can be having prolonged sustained contractions, and then the last patient will have a pain. So you should ask about the history, whether there is any stress in the families or any financial issues. The patient should not hide, and you should not think that why we should ask the personal issues to the patient. If you ask personal problems, patient will get relaxed, and obviously the whatever treatment you are giving, it is going to work. So first is protective co-contraction. Now, what is protective co-contraction? It is the first response. Now, if you have done amalgam restoration, there is a high points, you haven't checked, patient first bites, and suddenly patient says, yes, patient having pain in muscles. Now, this is not the myofascial pain dysfunction syndrome. It is the protective co-contraction. Why? Because it is protective. Because of the high points, muscles is reacting over that. Now, what will be the features for that? The only features will be the muscle pain. That is also in function. When patient is biting again and again on the high points, patient is having pain. Otherwise, there will not be any specific other features. The treatment will be no specific treatment, only treat the etiological part. You have to remove the high points. Patient will get relaxed. Now, after some time, if you didn't relieve the high points, or patient have ignored that pain, it is going to convert into a local myalgia. It can be a sustained co-contractions, or it can be a separate pain. For example, after the inferior L1 nerve block, patient might have a medial pterygoid muscle pain with restricted mouth opening. So this is very common. We have given the block for extraction or the RCTs, and patient is complaining soon after the few days after the injections, patient have a trismus, or the next day of the injection, patient have a trismus. So this is because of the local myalgia. So the main feature here will be the muscle pain and the restricted mouth opening. Now, how to treat that? Some says you should restrict the mouth completely. Some says you should overstretch the muscles, do the active physiotherapies. For me, ask patient to restrict mouth opening up to the level of pain. Like, patient should not have too much pain for opening. How much ever he can, he should do it, and he should try with the passive physiotherapy stretching exercises. This should be with the cold spray. It can be with cold spray. Patient, there is a multiple physiological exercises are there, and that will relax the muscles. Soft diet should be increased. A night guard can be used. Stabilization appliances or NSAID. Muscle relaxant, personally for local myalgic pain, it have a very limited use, and more than a muscle relaxant, I feel physiotherapy works nicely. You should know the difference between a night guard and a stabilization appliance. Many of us always confuse with night guard with stabilization appliance. Night guard is the one which we actually use for bruxism, and stabilization appliance have a flat surface, and all the centric occlusions and guidance, canine guidance, everything is checked properly. There should not be any hindrance for the movement of temporomandibular joint. If you see the night guard, there is the markings of the tooth going to restrict the TMJ movement, so pain is going to increase. Our main motive is to increase a little intraocclusal distance, and there should not be any restrictive movement to the TMJ. Then only it is going to work. Next is myospasm. Myospasm is actually a CNS mediated prolonged muscle contractions, or it can be associated with systemic disorder like a tetanus. So there will be acute malocclusions, and there will be prolonged contractions of the muscles. Now, here features will be restricted mouth opening and acute malocclusions. And these features is these type of patients are not so common comparatively to the myofascial pain dysfunction syndrome or the sustained contractions. So it should be treated by first the systemic evaluation of the patient, and then passive stretching exercises. So this is okay. Now, dystonia. Many of the times patient comes with the prolonged uncontrolled muscle contractions. Patient says, I am not able to chew any food or even the banana also. Patient try to swallow the banana, want to chew it, but he is not able to. Like, there is a continuously there is a movement, uncontrolled movement, and patient is not able to swallow properly. So this is the uncontrolled. I have a video also. What is this contractions? If you see this video. Yeah. Okay, it have rotated automatically, no problem. But we can see we are not able to see oral cavity properly. There is a sustained contraction. Can you see the tongue movements? Uncontrollable tongue movement. It's more than that, I think. It have rotated automatically. Can you make out? Patient is contracting. Okay, more than that, I have one more. This one is, I think, it will be better. Can you see this one? This one. Sustained contractions, like it is uncontrollable. Now it's a child, yeah, very young age, and if such type of findings, if you are able to see, please do the MRI, check for the central findings. This should not be any pathological central findings. Can you see the muscle contraction? Continuously muscle contractions, and patient suffers a lot. Patient was admitted for about 2 to 3 months, and it has been treated by multiple doctors. But at the last, patient got relieved, and it was a huge. All the family suffers. Patient also suffered. So these are the cases, dystonia cases, which we should treat it with along with the neurologist, and even we can treat as a dentist. We can treat, but because it requires the treatment for a longer time, and you have to change multiple drugs and maybe a botox injections, it can be done. So multiple treatment is required. So please take consent with your neurologist also. There should not be any central pathologies. Now this is the one which is very common, and we see many patients with multiple pain trigger points in the muscles, and this is myofascial pain dysfunction syndrome. And it is a myofascial, it is not a myofascial. So we should not cover that, we should not confuse with the myofascial pain. So the most important is there is a trigger points, there is a taut bends, and that is very hypersensitive to palpation. Now how these trigger points came here? So we have to understand that. So there are different etiologies. The etiologies are same, and there can be a prolonged contractions or microtrauma, macrotrauma, occlusal disharmonies, poor nutrition. This is the case which I want to discuss. Is there was the patient of young patient around 19-20 years, female, and she have a muscle pain, and which was not getting relief with multiple treatment. All the treatment has been have been tried with multiple doctors. All the muscle relaxant, splint, everything. TENS therapy also, everything, but patient was not getting relief. So when I have seen the case first time, because it is a 19-year-old female, there was no specific other findings. I thought to evaluate the all the systemic issues, and I asked about the menstrual histories, and it was irregular. So I asked about the ultrasound, and we got a polycystic ovarian cyst, and we came to conclusion that it might be a etiological factor for the muscle pain. We have referred to gynecologist, and gynecologist was not ready to accept that the muscle pain can be because of the ovarian cyst. Now, why they didn't want to accept it, that is their issues, but there are literatures available which says that the alterations of hormonal imbalance in the ovarian cyst or dystrophies can cause fibromyalgic issues. And fibromyalgia is not as easy to treat like myofascial pain dysfunction syndrome, and patient suffers a lot in fibromyalgia. So we have to take care for such patients. We should not directly jump to conclusion that okay, muscle relaxation will work, and after that okay, we will do the splint, we will do enameloplasty, everything will do, and then the last patient is going to suffer. So please take care for such patients. Pathogenesis, we know about muscle contraction and muscle relaxation. We required ATP. Now, because of the sustained muscle contraction, this ATP is going to decrease, and because of that, the muscle relaxation will not be taking place, and that muscle fiber is going to be in sustained contracted phase, and that is called as trigger points. So 3 points you have to remember. One is ATP depletions, then formation of taut bends, and because of the taut bend, there will be release of inflammatory mediators and cause the pain. So we cannot discuss it in a very detail because of time limits. Okay, so this is a vicious cycle. One myofascial pain started, it can cause so much issues, and these issues again will cause myofascial pain. So we have to take care. If there is any arthritic pain, any discal issues, any prolonged co-contraction, these all can cause myofascial, and this myofascial pain again can cause the altered chewing patterns, and this vicious cycle will always taking place. So Leskin criteria, we have seen Leskin criteria in books also, and this is important to read. There will be pain, restricted mouth opening, clicking, tenderness. There will not be any radiological or specific pathological features. When we palpate the trigger point, patient will jump. So that is a specific feature. We should differentiate between trigger point and trigger zone. Trigger zone is mainly associated with trigeminal neuralgia. Because time limit, I have to go little fast. How to palpate trigger points? So we have to palpate bidigitally. Okay, first evaluate, because if we do only single finger, it is going to move. You might complain of tooth pain, for example, a third molar pain. Now you have evaluate the patient. There is no decayed tooth, there is no specific odontologic pathology, but still, because you are not able to diagnose it, you are saying patient that maybe a pocket is going pain, or we have to do RCTs or multiple treatment is done, still patient is suffering, pain is persisting. So please try to palpate the muscles also and check for the temporomandibular joint pain also. In such cases, there can be a referral pattern. Why this referral pattern are there? Because of the convergence theory, which says that the fibers from the branches of trigeminal nerve and the cervical branches, they converge to a area in the midbrain, and then that's why if it is a pain in the muscles area, for example temporal area, there can be a referral to a pain to a neck or the posterior teeth. So this one, if you provoke the pain onto the area of the main areas, so there the pain will going to refer onto the tooth. But if we palpate the tooth area, if we inject the tooth area, not palpate, if we inject the tooth area, still pain will be persist. So you can do a local blocks, you can give a block and try to see diagnostic block, that's called as diagnostic block. For example, in trigeminal diagnostic block is positive, but if try to give a local anesthetic block in this area or in the infiltration onto the tooth, the pain is not going to relieve. Muscle pain is not going to relieve. So what are the associated findings? It can be a tingling sensation, numbness. Patient may have a nausea, vomiting, fatigue, tensions, tinnitus. Tinnitus is most important feature if there is sternocleidomastoid pain, which we actually misdiagnose many times. We just palpate the masseter muscle, temporalis, and we miss to palpate sternocleidomastoid muscles. Sometimes patient says something is stuck onto the throat. Okay, so that features also is very common. So how to diagnose this case? Diagnosis is mainly associated with the clinical examination and associated findings. We should know about the soft end feel and hard end feel. Now, in case of MPDS or a myofascial pain, patient will able to open mouth of about 20 mm, 20 to 25 mm. After that, patient will say that I have a pain. But if you apply a pressure, patient will able to open mouth completely, but pain is there on the muscles. That is called a soft end feel. I repeat, patient is able to open mouth. But in case of hard end feel, patient will say that I am not able to open mouth even after the pressure, and patient have a pain more on the TMJ. So it can be in the discal pathologies. So you should able to differentiate soft end feel and hard end feel, very important aspect. All videos are getting reversed. This is the hard end feel. Again, this is going to reverse. Patient is complaining restricted mouth opening. Here also nearly 15-20 mouth opening is there. But now patient is saying that pain is still on the TMJs, and when we are applying pressure, not able to open mouth. Only this much mouth opening is there. So this is the hard end feel, and that can be a discal pathologies. Go for MRI and then check for the disc. Now this is another video where patient is only 15 mm. Okay. Now we are applying pressure. See, patient having showing pain and is not able to open mouth. Okay, so we should know the difference between the hard end feel and soft end feel. And we can have a biting tongue bite test also. We can ask patient to bite on the tongue blade. If it is a temporomandibular joint pain, it is going to relieve on the affected side, but if it is a muscle pain, it is going to have a increased pain intensity. Why it is so? Because when you are biting on the tongue blade, there is a contraction on the affected side, so muscle pain is going to increase. But if you see the temporomandibular joint area, there is the space is going to increase, discal space, so this pain is going to relieve. So, but what about the other side? Other side, unaffected side, there will be relaxation of the muscle. So, for example, if it is a pain on the right side, if you bite on the left side, muscle pain is going to relieve. But what about the joint pain? Joint pain is going to increase. So this one is very important aspect, and you should try for your pain with patient with muscles pain and temporomandibular joint pain. Then advanced diagnostics are there. So this is the one T scan, jaw trigger, vibration, and this is the like future of the dentistry, specifically those school of thought which they think that the occlusal disharmony have a specific role in temporomandibular joint pain. And it's a good investment, good learning things. You should go for neuromuscular dentistry also, because I respect both. So what about the treatment? Now treatment is passive physiotherapy can be done, sleep disturbance you have to check, elimination of trigger points, everything is important. Pharmacotherapy, I personally feel a very little role of pharmacotherapy in myofascial pain. Better to go for a physiotherapy or a trigger point injections and splints. The main motives of all our treatment modality is to relax trigger point, provide ATPs, or try to numb that area. So moist sheet application, they actually warm that area, which causes increased vasodilatations, and the last ATP can be provided. Now cold therapy, they actually numb that area, okay? Because of that, patient might have a little pain. Spray and stretch works very nicely. There are ethyl chloride spray or fluoromethane sprays are there. We can have a nearly 18 centimeter far away, we can have a spray and ask patient to stretch. The patient is not able to stretch, but you have to do a passive stretching exercises, and patient should not have any pain. Ultrasound therapies, again, this is going to give a local increase in temperature, which is going to do the vasodilatations and relief pain. Now, trigger point injection, I felt personally trigger point injection is very important and very successful. First, palpate the trigger point properly and that inject it either local anesthetic or a dextrose, okay, and this works very nicely. Okay. So we have to palpate the trigger points, mark it, and then give a local anesthetic or a dextrose injections onto the trigger point, because you are traumatizing the trigger point. So obviously, because of the mechanical trauma, there are going to be the relaxations of ATPs there, and that is going to be a relief. But make sure that you are injecting onto a trigger point correctly. Now this is got again rotated, no problem. But we are palpating the trigger points, we are marking it. Okay, check again and again. Be assured that, because we are not doing ultrasound guided here, we can do ultrasound guided, that is the best actually, but because it was not available, so we are doing it manually. So we are sure that the trigger point is correctly palpated. The patient will have a jump sign, that is a specific sign, and then clean that area. So now we will have things in mind, like where is the trigger point. Okay, so still that faint markings are there. Okay, we will able to inject on that area. Ask patient to chew tightly so that the muscles will be in the trigger point. The trigger point will be contracted, and then now how we will come to a conclusion that we have injected in a correct area. Whenever you inject or prick on the trigger point, patient will have a local twitch response. Suddenly patient say that now pain is increased. So that is specific sign, say that no, you are in a correct direction. If patient says no, I am not feeling any twitching or any pain, that means it is not a trigger point. Trigger point will always have a local twitch response. And then we have to do a fencing movement all around the trigger point and then inject it. Okay. So this was the, we didn't have a local spray that time, but we can have a local injection, local spray. Just 2 minutes. So here again we are palpating the trigger point. Can you see the eyes movement? Yes. This is the area where patient have a pain. Ultrasound guided is fantastic here, but we should have those facilities. And the problem is, if it is trapezius muscles, then it is good to do ultrasound guided. But masseter muscles or temporalis is not so big muscles comparatively to the back muscles. So ultrasound may have a little role in that. Now this is, we have marked it. Now we will keep the cotton so that the patient should contract it properly, and we have to protect the eyes and ears also, because I am applying cold spray here. In last case I didn't apply any cold spray, so it was okay, but here because I am going to apply the cold spray. Now what is the advantage of cold spray? If you have a cold spray along with the injections, patient will have a little muscle soreness. Otherwise, because of the injection, patient may have a soreness for next 2 to 3 days. So now I was saying about the intern, that how to spray that. Now we have applied the glasses. Then all around the trigger points for around 3 inches we have, or 18 centimeter, they have to inject, we have to spray that. So continuously spray should be there. Then check for the local twitch response, ask patient, and then inject around 1 ml of local anesthetics, or a dextrose, 15% dextrose also can be given, that is called as prolotherapy. So I'll go a little faster. So TENS therapies, TENS therapy also works very nicely because they work on gate control theories, and it is having a high frequency but low intensity electric currents. So it is going to stimulate A beta fibers that will automatically control the gate for A delta and C fibers that will relieve pain. It also releases certain endogenous opioids, okay, increase the vascularity, and they might have a placebo effect. So in muscles pain, because of the A delta and C fibers, there is a pain sensation, but because of the TENS therapy, A beta fibers is going to close the channels for A delta and C fibers, along with some pain inhibitory neurotransmitters like endorphins and enkephalins. So very common TENS therapies, we all aware with the TENS therapies. Now stabilization appliance can be given, and just it is not a night guard, or it's so easy to have a stabilization appliance. We should have a proper centric occlusion, centric, and then all the canine guidance, anterior guidance properly has to be made. Okay. Then low level laser therapies, because laser also provides different analgesic and biostimulation properties, so that can also be used here. So we have to first mark the trigger point, and then low, for excisions we give 2 watt, but here we give less than 0.5 watt. So we are providing low level energy here. We should not misuse it, otherwise low level laser therapy also can cause burning sensation in a local area. Now this is the most important things which you should differentiate with myofascial pain. Don't just palpate a single trigger points, palpate all the possible trigger points of the head and neck and other part of body to differentiate fibromyalgia. So because there are comorbidities of fibromyalgia like migraine, anxiety pain, irritable bowel syndrome, polycystic ovarian. See there polycystic ovarian, which I was discussing the initial part of the seminar, and hypothyroidism also. So they have tricyclic antidepressants, serotonin, anticonvulsants, they are there. So just 2-3 questions I'll do it, and then I'll end my seminar or presentation. So first is a 40-year-old salesman come with the complaint of masseter and temporalis pain, and then there is a tenderness on the right masseter, right temporalis, and then there was the amalgam restoration. 2 days before there was amalgam restoration. Okay. So what it will be? It will be a protective co-contractions. Next there is a 19-year-old female. There is a pain, and she has revealed that the pain have been present for 3 other occasions, 2, 6 and 8 months. She didn't have report any unnoticeable change in occlusions. And then 3 episodes there was associated with college examination. So obviously the stress is going to be a most important aspect. Okay, so it's a local myalgia secondary to increased emotional associated findings. But there was no restricted mouth opening. That's why we couldn't come to a conclusion on to a MPDS. Okay, another 38-old year male with limited mandibular opening and left side pain, and it begins shortly after a dental visit, during which he received anesthetic local injections. And on palpation there was the tenderness on left medial pterygoid. No other specific finding were present. So it can be a local myalgia because of the sustained prococontraction or post injection trauma. Then second last questions. This is the emergency basis complaining that could not bite on the tooth together. There is an open bite, and this is he reported that he could not open bite and seemed to be pulling the left. There is no history of any trauma, and examination have revealed there is acute malocclusions on the posterior side. There is no other associated findings. So it's acute myospasm. And the last is there is 43-year-old woman with the continuous dull aching pain on the left teeth. There is no associated odontogenic associated findings. Okay, and antibiotic everything has been given. Endodontic treatment has been done. Intraoral no clinical finding was there. Temporomandibular also there was clinically and radiologically there is no findings. Muscle, there were tenderness on the muscles. And when we gave INV local anesthetic blocking injections, the pain didn't get relief. That means there was no odontogenic as such issues. So this is a myofascial pain, and which was referring to the left masseter muscle, and that is also called as muscular toothache. So the last we conclude that myalgic pain is a very common clinical scenarios, and which is oftenly misdiagnosed. Patient suffers a lot. Okay, so please diagnose these cases properly, enhance your knowledge, and use all the advancement, learn all the advancement. And now dentistry, that is the theme. We have a recent advances and trend in dentistry. So personally, I request everyone to be enhance your knowledge in the recent trends. For example, the T-scan, everything, neuromuscular dentistry part I just told in the seminar part. Learn more about that, and but don't forget about the systemic evaluations as well, and work for the patients. Thank you.
Thank you, sir, for the informative lecture on pain and the associated criteria. It was a pleasure listening to you. Now it's time to invite the next speaker of the day. But before that, I would like to request all the delegates to kindly occupy the front row seats. Please come forward. All the delegates, please come forward. The next speaker of the day is Dr. Vinayak AM. A brief introduction of Sir is a national and international speaker with the subject expertise of lasers, local drug delivery, nanotechnology and regenerative periodontology with a 32 national and international publications. Sir is a fellow of International Congress of Oral Implantology, World Clinical Laser Institute USA, Laser India Academy, Academy of General Education Manipal, and Indian Society of Periodontology. Sir is presently working as PhD scholar at a renowned university in Mangaluru, Karnataka. It's a pleasure to have you here with us today, sir. We welcome you, sir, and eagerly wait to listen to your lecture. Please welcome, sir, with a round of applause.
Get up. You want me to come there and catch you guys and make you sit there? How many of you are interns or the doctors or any MDs amongst you guys? Interns? What about others like third years? Final years? Then MDs? First years. Okay, first years. I just wanted to get a brief that what I need to speak to you guys. Okay. Okay, today I'm going to speak regarding, can you just read what is there? Yeah, it is perioaesthetics via lasers. What do you know about perioaesthetics? Means what, first years. You know there is a department called periodontology. Yeah, for the gums. Anything else? Okay. Anything else periodontists will do from the perio department? What we do majorly like? Any idea? Any idea? Okay. Something to deal with gums. Yeah. For you and for your understanding, this periodontology is all about just knowing the gums. Like, is it like a oral pathology? We just read about the gums, or we do something else also for the gums? Actually, periodontology is a combination of everything. Like, we do study in the macroscopically also, and we do treat also. So it is a therapeutic orientation of the biology, that is biology of the periodontology. Like, what is this periodontology means? The tissue which is around the tooth. What are the major tissues you will be finding there? There are two hard tissues and two soft tissues. What about the hard tissue? Cementum, bone. What bone? Alveolar bone. And what about the other two soft tissues? You don't want to be involved? Come forward. Come forward. Yeah, what about the other two soft tissues? Yeah. Real means. And what is another soft tissue? What is there around the tooth which is soft? Pulp? Which is there around the tooth or inside the tooth? Yeah, gingiva. So now I got to know, like, this is what the perio knowledge, and we are going away for this, like, it is about lasers. You have any lasers? What is lasers? What I'm using this, can you see the pointer? Is it a laser? Yeah, this is also a laser with a different wavelength. With this laser, can I treat the patient? Why? Yeah, that is wavelengths. Wavelengths matters. Depending on the penetration, it goes different game. Like, okay, this is about me, which you already got to know. These are the contents we're going to cover. So it's a basic thing. What is laser means? What is LASER? It is already there. Can you just read it? It's been taught since you're +1, isn't it? Laser acronym. So it was meant to be in a physics, isn't it? If you all remember. Why? The origin of this laser has been started via Einstein once we come back to the history. So this was a timeline. The idea about the lasers has begun in 1917. So now the timeline has been come to 2003 and forwards to 2011 onwards. We got so many different types of lasers. So how does this laser work? As I already told, this pointed cannot be used for the therapeutic laser therapy or whatever the things from the lasers. So what made this laser beam for to be treated? It is about the four mechanisms there. Can you read? What is the first one? Yeah, this is the beam, like the exact beam which I am portraying over the wall. This beam is not going to do any of those actions which is already there in the picture there. So what are the things happening there after the beam hitting the tissue? What are the things you can see there? Yeah, there is absorption, there is scattering, there is transmission, and there is a reflection. Reflection is useless because this reflection is already happening there. Is it going to do anything? No. So what are the things we need to be considered here? How the reaction via absorption and how it will be via scattering and via transmission. Here the scattering also is useless phenomena. If the laser is scattering and it is not focused, so I'm not going to achieve what I'm going to expect in the tissue arena. So we'll just go through it, like what are the different things to be seen. Can you observe these two pictures? In picture A, it's a different tissue levels. You know the layers of the epithelium in first year? Or all those layers you remember? I don't want to go deep into that. Just observe here, like with the different wavelengths. Can you see there is a 445, that is 445 nanometer wavelength, then followed by 520 and 638. So different color wavelength is having a different depth of penetration. It is not penetrating at same level. The depth of penetration differs with the different set of wavelength, that is the intensity or the power of the laser. If you see, there is a different penetration is giving a different types of reactions as we earlier discussed. That is absorbance, reflection, scattering and transmission. Okay. As I already said, scattering and the reflection is not much of use in the laser biology. What is important is absorbance and the transmission, which you see that transmission is hitting almost to the connective tissue layer. Beneath that there is a fatty tissue layer. Okay. So does this laser burns all the tissue which is around the foci? Means I put a laser to the patient, it will burn everything. Sir is also shown few of the cases. Does it burn everywhere? There should be something phenomena, right? Why it is not doing that? Okay. It is because of, you should read. It is for you guys only. We are coming all the way to, speak few things. What is it? So I broke down this selective photothermolysis now. Can anyone do the honor to read that? You. Yeah, that is why it is selective, means it only attracts the chromophore but not the surrounding tissue. That means the main foci is entitled there. And what about the photo means? Yeah, photo is the light. What is thermo? Yeah, that is where the absorption reaction of the laser or the property is going to encounter. Then coming on to the lysis, there is a eat, destroys the target cells. That's how the laser is foci only upon the lesion, not the surrounding tissue. There are different types of lasers in periodontics. So basically like a high power lasers, that is carbon dioxide laser, then diode laser. And diode laser is the major laser what we're going to use, and it is also called a soft tissue laser. Then coming on to the non-surgical periodontal therapy, then surgical therapy, we have different set of lasers and the different set of indications and the, different types of procedures. I hope if people cannot understand that much, so I'm skipping those things. Just, we have a different set of lasers for different procedures. You need to remember the two types of lasers in a basic mode, that is hard tissue laser and the soft tissue laser. In perio only we need both, okay, depending on the functionality. But with the soft tissue laser, most of the things can be done in dentistry, okay. So there is a concept called photobiomodulation that you people should remember. Why the biomodulation? The word only suggests it is. It is bio means about cells, something about the cellularity or the cellular level. So what about the modulation? Yeah, there is a change. Something changed. Why it is going to be changed? What is laser? Not acronym. Like what is basically? What are sun rays? What is the main component about all this light? Start from P, not yeah, energy, photon. Like, be precise about that. Yeah, it's a photon. So depending what that photon is going to change in the cellularity, depending on the certain wavelengths, to obtain photobiomodulation. Yeah. So one thing you need to be remembered for the safety measures by using the laser. I will be showing you the videos and all like stuff later on. Just for the theoretical part, you just to be remembered. Majorly, the dental lasers generally fall into the class 4, that is hazards for the direct and the diffused vision in the addition of the fire hazard. So the precautions you need to be taken while performing the laser surgeries or the laser therapy. So this conclusion should be kept upon to be things to be going on for the next session. We are going to discuss few of the cases which we have already treated via laser. Is the laser in periodontal treatment is an effective treatment or a science fiction? Because the arena starts from the science, as I told you, like it's a physics adapted to the biology. Henceforth, we'll see how does it work. Can you see like what is wrong in this picture? Is this a normal type of size of the gingiva? Is it normal? The bulkiness? Is it normal? Is your gingiva looks like that? So there is enlargement in the gingiva. So what is this instrument? What we are using is called as choose gauge, which is already written. It is made up of by using the golden proportion. Remember, in DM you might have read about golden proportion. That is the same formula has been incorporated to enlight the device. What we have done is using the diode laser, we have done the laser gingivectomy. So we have removed the excess growth of the gingiva, and you can observe this one follow-up from this part to this part. Can you see how pristine the gingiva looks compared to this? Can you see the difference? Okay. Same thing only, same procedure with a different patient. Can you see the difference here in the 1-1 and 2-1 area? There is a lack of difference in the gingival margins. To make it aesthetics, we use the stent also to get the proper zenith formation. That's how we ended up. Okay, this is the 1-1 post-op. This is the pre-op. Can you see the difference? This one. You should observe this. Yeah. What about photothermolysis? Remember that word which we used? Okay. You read the chromophore. You remember? So chromophore is what? Chromo is what? Something colored. Phore means a molecule, like colored molecule. Here, what are you seeing here? What color is this? Yeah, black means what is black in biology? Yeah, what is that pigment called as? Starts from letter M. Melanin, yes. So here the gingiva is hypermelanin pigmented. So what we need is depigmentation procedure. It won't be aesthetic, right? If you smile and all, there's a blacky patch on the gingiva. You need to get away with that. So it's a simple procedure. We're going to do the laser depigmentation. How does it work? It's again selective photothermolysis. The more the pigmentation, the more the activation of the laser does, because it's the chromophore. And can you name any other chromophore like that? Melanin, which is something in red. Black is melanin. What about the red? Huh? What is there in the blood? What gives the blood a red color? Yes, hemoglobin is also one of the chromophore. Okay. So here's the one of the case. He was my third year student, BDS student. There was a neurolemoma for his tongue, on his tongue. This is the growth you can see there. So what we use is BioLase or Epicex. This is a soft tissue laser. We excise the lesion, then we had the H&E stain done, then immunohistochemical for the CD34 test. It was positive. If you remember Anthony A and B bodies in neurolemoma, those are the bodies which were like in a blackish coloration. Can you see there? Yeah. So coming on to the laser gingivectomy, sometimes see this perio is there in everywhere. Like there is a orthoperio, there is a endoperio, there is a prostoperio. Perio will be involving in all the other specialities in terms of giving the treatments with a collaborative way. And so this is one of the ortho-perio relationship. You can see there is a lot of gingival enlargement. It is there is a classification called Bokenkamp's classification. It is around like grade 3 classification. It is almost covering all the parts of the gingiva. That is marginal gingiva, attached gingiva, and the IDP. That is interdental papillae. So here also we have used this Picasso lasers. This is soft tissue laser. Then we did the gingivectomy. Can you see the charring here? There's a blackish thing. So this is 1 month post-op with followed with a brackets placement. So this is a part of prostoperio. Like here the crown cementation to be done. So we need what? Margins to be fitted properly, right? So for that preparation, we have used lasers here. Again, it's a diode laser. Can you see the difference of the visibility now with the pre-op and the immediate post-op? That is the margin you need, or else the impression won't fit in that, and your crown won't be possibly fitting in the area. This is for the abscess drainage. You know what is abscess, right, by this time? Interns? Yeah. Have you seen few of the abscess cases in the OPDs? Yeah. We can also treat where scalpel mode is always the gold standard one, but lasers are going to beat the scalpel, beating in the arena where we can do the minimally invasive approach. Sorry. Yeah. So can you see the probing depth? It's almost around like 12 mm deep the pocket is. And there is a pus and there is a pocket, that is a periodontal abscess. What about gingival abscess? There will be only pus formation, but there won't be any periodontal pocket. Then you will consider it as a gingival abscess. If it is a periodontal abscess, in the area of probing, you just insert the laser probe or the laser tip. You activate the laser, then immediate relieving of the pus will be there, and the healing will be faster. Double the mode of healing in terms of the normal conventional treatments. Then again another case for the gingivectomy. It's mid-ortho, like ortho cases going on. In between we are treating the gingival overgrowth. What about the frenum? You know what is frenum? What is it? Yeah. Means you have an idea, right? Like frenum or frenectomies. You might have read in your perio, even in prosto, even in oral surgery, pre-prosthetic surgery part. Okay. This is how we do a frenectomy via lasers. Because it is a wider frenum, so we had done the suturing also, followed by 1 month post-op. Can you see the difference for this 1 month post-op and with a pre-op? See? this muscular attachment here, and there is no attachment here. It's another frenum case. It's a very wide one compared to the last one, so we got another 4 sutures followed by prosthetic enhancement. Can you see how beautiful it is? Okay, what about operculum? Anybody knows what is operculum? Yeah, no, first years I cannot expect, but intense. Yeah, that's a, on which tooth you will be probably seeing that operculum? Third molars, yes. At your 23 and 22, you all will be suffering that toothache. Most probably because of the infected operculum. So we have a procedure called operculectomy. That means the removal of that operculum, the extra tissue which is overgrown the third molars. This is how we have done here. This is the pre-op and the post-op, 1 month post-op. Another case of this operculum. Yeah. These are the cases. I will show like how this lasers works in one shot. Just to lighten your mood. These videos are going to be fun. There is a technical glitch. Please bear with that.
doing something unholy. Another banger, baby, calm down, calm down. Yo, this your body, it puts in my heart for lockdown, oh lockdown. Yo, you sweet life, phantom, phantom. If I tell you say I love you, you know they for me, young girl, oh young girl. No, tell me no, 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 oh, 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 oh. Baby, gon' give me your lo, 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 oh, 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 oh. You got me like. Le corps est aussi beau que l'or, qu'une encore c'est clair pour une histoire d'amour. Ils vont encore dire que t'as qui me parle que d'amour, oh d'amour, mais c'est toi qui garde mon
The bird machine. Check. Check.
Yeah, that is for the day. Hope you all enjoyed the session. Have a good day. Yeah. Cautery and laser, see the functionality will be same depending on the usage. If you are using laser, see added benefit is the biomodulation as we discussed. Here the tissue will be enhanced with that energy because the photon itself is going to amplify your ATPs in the mitochondria. That much efficacy you will get in the lasers. The enhancement in the healing in terms of the proliferative rate. But what happens in the cautery is it just burns. Laser doesn't just burns, it also helps in the aiding of the healing. That is the only major difference. And if you use the cautery alone, you will end up with a bone damage. Like that is more of the chances. And the depth penetration of the cautery cannot be controlled. You cannot control. If laser is not activated for that set of procedures with different wavelength, the laser won't even start to pick up for the charring. Like that is a major difference. There is a control and there is added benefit of the healing. But for the few of the minor cases, a cautery can be also be useful in your setup, like depending on the regrowth of tissue after as compared to surgical. Yeah, it depends. Like what is the main reason for the growth of the tissue we need to be encountered. After the biopsy only we can decide whether it will be benign or the malignant, or if it is a fibroma, or any sharp cusps are there like for the growth. We need to end up with those all the commodities, then we need to encounter those. If we are clear with all those things, but still there is a growth, then we need to think of something else. Like the growth doesn't happen all over the night. Again, it is going to take at least 3 months if it is about to be papilloma or the fibroma also.
The surgery for aesthetic round lensing.
Yeah.
How do we fabricate that surgical stent?
That surgical stent actually we really did a jugaad, like that is not like 3D printed. You know about the Essex appliance, the post-orthodontic treatment we are going to give. What we did is that only. We manually constructed the stent by seeing the second quadrant, because our area of interest is the first quadrant to be get the zenith done accordingly to get the aesthetics. So we use the stent and we just cut it with a scalpel to get that level. So with that mode, we can also use. Yeah, biolaser. No, for that case, we use a Picasso. Both are soft tissue lasers only. One, everything is better. Lasers, any brand is lasers. Lasers cannot be changed because the science is not a fiction anymore. Yeah, thank you. Any more questions? I shall end up now. Thank you for patiently listening.
Thank you, sir, for the informative lecture on lasers and the associated criteria. It was a pleasure listening to you. Now it's time to invite the next speaker of the day, and that is Dr. Jasneet Singh Kalra, sir. A brief introduction of sir is, sir has got 11 years of dental practice experience in contemporary and implant dentistry. He is the key opinion leader to CSM implant and key opinion leader to Dentium implant. He has 4 years of teaching in experience in implant dentistry at various academies and CDE programs. He has graduated from Saraswati Dental College, Lucknow, and he is a postgraduate from ITS Dental College, Department of Prosthodontics, Greater Noida. He has done his PGC in implantology from Italy. Along with all this, he is successfully running multiple implant workshops at various cities in India. It's a pleasure to have you here today, sir, and I would like to welcome sir on stage. Please give a round of applause for sir.
A very good morning, everyone. I hope you guys have had good breakfast. And above all, we started lectures like 9:30 in the morning, and I can understand one day after the holiday, how does it feel? So my name is Dr. Jasneet Singh Kalra, and I'm going to talk about guided bone regeneration. So may I know in the audience, most of you are like PG students or undergraduate students, right? So I've already introduced yesterday in my pre-con course what exactly dental implants are. Today I'll go one step ahead and discuss how do we generate bone, how do we move bone, and what are the certain protocols wherein if we have deficient bone, what is that magic powder, what is that magic technique, in whatsoever manner we can have a good quantity and quality of bone which is surrounding our implant. By the end of the day, it is all about implant aesthetics rather than just placing implant inside the bone. So having said that, we'll start with the first case. So these kind of cases come regularly. I'm purely a good private practitioner. So I talk more clinically. So I'm not related to any academic college or something. So what I understand is my patient, right? So what I see in day-to-day practice, a patient coming to me with one missing. After seeing this kind of scenario, what do we plan nowadays? Earlier, almost 5-7 years back, we used to plan fixed dental prosthesis or a fixed partial denture. But now gone are those days. What we plan is dental implants. Seeing this case, I would say straight away, I would place one implant and would rehabilitate this. But what next? As soon as I open up a full thickness flap, giving a crestal incision, clavicular incision, or any kind of releasing incision, I would see your operation is done. You end up in buccal defect or any kind of fenestration into your buccal bone, something like this. So the option is whether you place implant or you do a graft, you wait for some time, or do a simultaneous implant placement or grafting, or cases like these. So earlier we used to think about placing implant every now and then, but now we do have cases of peri-implantitis or peri-implant mucositis, whereas the entire implant threads are exposed. And now since last a decade or so, what I've seen, implant placement has been so widely spread that now we see the failures in implant placement. Or cases like these wherein you see in the aesthetic zone, 1 or 2 thread of implant is exposed and it is completely anesthetic. Remember guys, one thing, the patient do not have any titanium deficiency. He's not coming to you for the treatment of titanium deficiency. The patient has a problem of missing tooth and he comes to you to get the replacement of hard tissue and soft tissue. We should first think in the terms of hard and soft tissue, and then we should think in the terms of whether to go for implants or to go for a fixed dental prosthesis. So I've seen a lot of ambitious clinicians thinking only about implants. So when you think only about implants, you see conditions like these. Because by the end of the day, what have we gained just by placing implant and giving a prosthesis like these? Or condition like this, after maybe few years, what we see, the entire threads of implants are exposed, and at the same time, just to match the zenith, we have given a pink porcelain to support our prosthesis. And cases like these, wherein you see a lot of plaque accumulation onto your implant cases. So you see a lot of defects, and then again, now as soon as you open up a flap, you see one bony wall defect, 2 bony ball defect, or even connection between the walls. So hardly what you see is there any interdental bone which is present. So how to take care of these cases? So guided bone regeneration is not an advanced treatment, it is not a new treatment. What we have seen, this is the first successful treatment was done in early 1990s. So this treatment has already been propagated, there is scientific data research and it is documented cases, and we have been getting results with it. So what is the main goal of my presentation today? I'll talk what are the rationale of socket grafting, what are the different types of sockets which we encounter in day-to-day practices, and how to determine a membrane, when to place membrane, whether to place a resorbable membrane or a non-resorbable membrane, when to do GBR, and I'll even provide you an introduction to GBR. So I'll just talk a little about myself. I've done my graduation from city of Nawabs, Lucknow itself. So I've done my BDS from Saraswati Dental College, Lucknow. I'm indebted to ITS Dental College, Greater Noida, which has inculcated whatever prosthetics I have today. That is why I'm standing before you and delivering the topic majorly on GBR with prosthetic. I'm a diplomat of World Congress of Oral Implantology, key opinion leader with CSM and Dentium implant companies. I've been trained extensively for heart and soft tissue by Geislick. I'm consultant to more than 50 dental clinics in and around NCR, and I'm owner of 2 premium dental clinics in South Delhi. Always believe something wonderful is about to happen. I completely agree. The lecture which I have chose in this conference is slightly above at par, I would say. But then just try to figure out. First, even in your first case of implant placement, you can encounter any kind of buccal defect. And if you encounter that buccal defect right on day one, I would not say it's a basic implant placement. So there's nothing like basic implant treatment and an advanced implant treatment. It has to be the combination of both, and you should be well versed with all the procedures. So what is socket grafting? As soon as we extract the tooth, we have the collapse of bone, and once we do the grafting into the socket area, that is known as socket grafting. A very simple approach. In this case, if you see, I've just extracted a 3/6, which is the first molar. Post that, I've placed collagen, which is composed of hydroxyapatite plus the collagen, and I've given 3 interrupted sutures. Onto the top, you can even give a figure of 8 or horizontal mattress suture. Wait for at least 3 to 4 months, let the bone grow and regenerate, and then proceed ahead and place your implant. So this is a general socket grafting case. Or what you can do is, you can take a magic powder, which is a bone graft, and place it inside the socket. Again, leave it for at least 3 to 4 months. Go ahead and place your implant. This is what a general socket grafting is. Why do we need this socket grafting? We all know, as per the rule, we need 1.5 to 2 mm bone buccally as well as palatally as well as lingually. But sometimes we don't get that. So once we do not get the bone, there's a lot of reduction of bone volume to reduce the need to additional bone grafting. So if you don't want to do any kind of bone grafting at the time of your implant placement, it's always good to socket graft your case to provide the aesthetic for final processes and to regenerate bone faster. So if you do first grafting and then place your implant, you get a good healthy bone, and you can place your implant in an accurate 3-dimensional position. So and how do we classify extraction sockets? So according to the classification given by Kim et al. So we classify as 4-wall defect, 3-wall defects, 2-wall and 1-wall. In 4-wall defect, you always have all the 4 walls surrounding, so you need not to use any kind of membrane. If we are doing in a case of 2-wall or 3-wall defect, we always need to build that area first with the graft, and onto the top we need any resorbable or a non-resorbable membrane to cover up our graft. So this is how the classifications looks like. So what are the 10 keys to successful aesthetic? First one is my aesthetic risk assessment. First and foremost, as soon as the patient walks into your clinic, you have to think about prosthetic. What is the gingival zenith? What is the biotype? Which tooth are we replacing? What is the shade of that tooth? And then you proceed ahead, which is the second one is tomographic planning or CT grafting or CT planning. So CBCT is found to be a gold standard if we are going with single implant placement or multiple implant placement. Whereas if we go for full mouth rehab, it's always good to have OPG first, then a clinician can plan to get a CBCT done. Post that, you have to know what is minimally traumatic extraction. Now, gone are those days we use a forceps and give a buccal and lingual rotation to remove the tooth. We just have to use either a periotomes or you can use luxator to luxate the tooth and remove the tooth. So your minimally atraumatic tooth extraction is the criteria today. 3D implant placement, we cannot escape this particular fact. We have to place implant exactly into this 3D position. Narrower versus wide, sometimes for an emergence profile, we have to place narrower implants rather than wider implant. Bone gap, bone graft, then facial gingival grafting. Nowadays is not only about bone and bone. It's even about soft tissue. That is why perio plays a major role in soft tissue grafting. So we harvest the CT graft from the palate and then we place it onto our bone graft and we get a proper profile of the patient. Custom impression coping technique, if you have to go with advanced prosthetic treatment, therein we have to plan for any kind of customization because the stock abutment are the cylindrical abutment. So we should not give most of the time into the aesthetic zone a crown onto the stock abutments. It's always better to do a customization in your abutment. Give a custom abutment. It can be titanium based, it can be zirconia based, it can be any PEEK material. And then go ahead and place your prosthesis on the top of this. And final restoration, most of the time, should be a screw retained prosthesis. Because we all know we are giving a cement retained prosthesis has given us a perimucositis and periimplantitis cases. So try to place your implant as per the bone, as per the prosthetics. You can give a good screw retained crown. So coming to my first case, just meet my patient Nitesh. Now, patient came to me with ailing 2-1. So if you see, this is my crown, which is 2-1. So how did we started this case? Yeah. So this is after the smile of my patient. Hardly you can see which is my crown, which is the natural tooth. So this was the condition patient walks into my clinic. 2-1 ailing, already got 2 or 3 times root canal done, re-root canal done. And after that, it has been failing again and again. We went ahead and get a CT graft, we got a CBCT done, and we had ample amount of palatal bone. So what I planned in this region, in this case, was a socket shield grafting. So what do we do in this socket shield? We basically split the tooth into 2 halves, the palatal as well as the buccal half. Palatal root we remove completely, and we still the buccal segment of the root is intact. Once that is intact, and this is how the palatal segments come off, and then I start my osteotomy preparation. My osteotomy is majorly palatally. Once I place my osteotomy, after that I went ahead and placed my implant. After the implant placement, you should always prepare your shield. So whatever buccal shield or buccal root you have of the tooth, you should prep the entire shield at least 1 to 2 mm subgingivally to get a proper emergence profile. Once this is done, then you proceed and give your prosthesis, but the final results what you get in these cases is something like this, wherein you have a beautiful soft tissue as well as hard tissue. In these cases, if you just change your treatment planning little bit, you need not to think a lot about bone grafting in these cases. So this is how a socket shield grafting ends it. And then there's a difference between a ridge preservation and ridge augmentation. What is the secret of growing bone? It's strategic planning. We have to plan our case accordingly. Till the time we haven't planned our case, we cannot give a perfect results. So what are the factors in bone grafting? So basically, first we have to see, as I've already discussed about extraction sockets, which kind of extraction socket is it? Secondly, what are the materials and type of graft? We have a lot of graft material nowadays. You will see people, people coming into your clinic and talking about a lot of graft material. It can be a synthetic material, it can be a xenograft, a allograft, anything. So you have to plan out accordingly. And what technique are you planning in your guided bone regeneration? So what are the sources of bone graft? Generally we know the gold standard is autograft, but autograft has got a resorption rate is very, very fast. So we have to think before getting just an autograft. Secondly, allograft, which is FDB and a DFDBs. Then we have xenograft, which could be a bovine origin, coralline origin, or a porcine origin. And finally, we have alloplast or synthetic materials. So this is a slide will tell you entirely about bone graft. What are basically from where do you get all these grafts from? And the keys to predictable socket grafting or any kind of grafting, it depends on these 4S, which is my surface, stability, space maintenance, and suturing. So if you know what is this pass principle, accordingly you can plan your GBI techniques and you will get a stable result out of it. So basic socket grafting, extraction of tooth. First case, I'll start case by case. Extraction of your extraction should be completely atraumatic. Once the extraction is done, I've applied Osteon 3 collagen, which is a combination of hydroxyapatite and type 2 collagen, and we waited for at least 3 to 4 months before placing our implant. And then you can give any kind of sutures. It could be figure of 8, horizontal mattress, 3 or 4 interrupted sutures, and then you do your grafting. After 8 weeks, I get soft tissue coverage as well as hard tissue coverage. So how much time should we wait before our implant placement? So as per studies also, it should be minimum 10 to 12 weeks before the placement after the placement of graft, then you can proceed ahead and place your implants. Another case, first the extraction was done. I've opened up a flap, atraumatic extraction. Post-extraction, I can see still it's a 4-wall defect. Hardly any bone is lost in this area. What we have used is again Osteon 3. This is healing after 10 weeks. Once this healing was done, this is the amount of bone which we get after 3 to 4 months. It's always good if you have a 4-wall defect, just fill in the area with any kind of collagen plus the bone graft, you get a bone like this. After this, we'll start with our osteodensification. This is for my implant placement. After my drilling protocol, these are my denser burrs. So I start with my basic implant kit. I go on to just taking the purchase at my implant site and then densify my site with the help of these, my denser burrs. And then this is post-healing, after 3 months of implant placement. A beautiful soft tissue as well as hard tissue. You will see there is hardly any kind of bone losses or soft tissue loss. And then this is after second stage surgery, and then the final processes. Now there was little bit of soft tissue defect which has been taken, which was covered after 4 to 5 months of my prosthesis placement. When to use membrane, that's very important. Any kind of defect which is apart from a 4-wall defect, that is a 3-wall, 2-wall or a 1-wall defect, we should be using a membrane. The simple concept is, if there is 1 wall which is completely missing or 2 wall missing, we have to cover our graft with the help of membrane. And if there is all the bony fragments or bony wall present into the area, we need not to use any kind of collagen or my non-resorbable membrane or a barrier, just place a graft. So in this case, again, I had a 4-wall defect. After all the 4 walls were intact, post-extraction, this was the scenario. So we just have to use a graft. We need not to use any kind of membrane on the top of this. Again, flattening my area, doing my osteodensification, placement of implant, and then the final suturing. So membrane should be chosen for each clinical case according to the desired biodegradation characteristics. So that means how much bone you have to grow into that area, accordingly you plan your membrane. If you want a lot of time for your bone, if you see you have a 2-wall defect or a 1-wall defect, it is always better to place a non-resorbable membrane. So the principle of so-called GBR was based on the ability of membrane to exclude epithelial and connective tissue. So what we need is a osseointegration or a bony or my osteogenesis to be taken care of. If my osteogenesis will be there, I'll always get a better bone for my implant placement. So this is how you can see how you can see histologically there is bone, and then you see a membrane on the top of this. Now in this case, there was a 3-wall defect. The buccal bone was completely exposed in this area. So what we did is first grafting. So what I generally prefer doing in my grafting cases are, first I harvest autograft from the patient site. It could be any donor site. Generally, I open up a white flap and I scrape my bone from there and place my autograft first. And then I place my xenograft, or it could be any kind of synthetic graft. If I'm placing xenograft, I wait at least for 6 to 8 months before placing before going for my second stage surgery. Similarly, in this case, after once we have done the extraction, we place the autograft, a mixture of auto and xeno, and here comes my membrane. And this is how we close the area with the help of my collagen membranes. And then final sutures. So the use of collagen membrane was introduced to overcome the limits of non-resorbable membrane. We know if we are using non-resorbable membrane, any kind of surgical dehiscence is there, and we have to take care of that also. Or nowadays, EPTFEs and DPTFE membranes are used. These are basically a more predictable membranes rather than using a non-resorbable membranes. The main disadvantage of this non-resorbable was high rate of wound dehiscence. So because of that, in most of my cases, we are using resorbable membranes. We need not to do any kind of second stage surgery wherein we have to remove the part of titanium from there. So again, a case wherein one tooth was missing. This was the CBCT scan. We can see as per the CBCT, there was hardly any buccal bone which was present. We went ahead and opened up the site, and this was my site. And then this was the buccal defect which we encountered in this area. Again, with the same law, first encroaching the area with the help of basic drills, and then osteodensifying the area. So once this osteodensification was done, this is my osteodensified site. Then placement of my implant. Once my implant was done, you can see 3 to 4 threads were exposed. So in this area, first we have harvested the bone from the adjacent site, scraped with the help of scraper, and then placed my autograft and my xenograft on the top of this. This is the mixture of both. What generally I use are the safe scrapers from Geisslich. So this is very easy to scrape the bone, and there are certain more materials by which you can take the autograft from the patient's side. Post that, this is the mixture of auto and Zeno, and then the membrane. Again, collagen membrane by Geisslich, which is a BioGuide. So at least in these cases, we wait for 6 to 8 months before proceeding ahead, or minimum 4 months before proceeding ahead from my prosthesis. So what are basic autograft harvesting units, what we can use nowadays? So there are 4 basically. You can use bone scrapers, which I've already shown you, then refined drills, by my piezo units, and by finally my bone rongers. So these are the scrapers. You have these metallic scrapers also, and you have these safe scrapers from Geisslich. Then you have refined drills. These are the drills for implant removal. These comes in different diameters, starting from 1.5 up to 4-5 millimeters. Whatever amount of bone you have to harvest, you use these drills to harvest the bone from the patient's side. And then my piezoelectric units. This is a minimally traumatic unit which I use to scrape the bone, as well as if you want to do any kind of ridge splits, these units are basically used for these cases. And then the bone rongers. So bone ronger is a typical instrument which we all have in our surgical units. So very easy to use. After extraction, just take a chunk of bone from the extraction site, and that you can crush with the help of bone mill and use it as your autografts. Again, a case wherein we can see this case, this was a C-shaped concavity, if you can see. We went ahead and did our guided surgery. We got a guide made for this case, and this was planned first with the initial punch only. Then we opened up the entire flap because we have to do a GBR in this case. Then osteodensification, placement of my implant. And after placement of implant, you can see the grayish hue of implant. So none of the thread was exposed, but still there was a very thin bone, approximately 0.2 to 0.5 mm of bone, which was present on the buccal side. So first thing what we did was decortication. So this is decortication. You can use any kind of round burrs, or even you can use the pilot drills to give certain these holes, which acts like a mechanical connection for your bone regeneration. So it is a part of GBR, a decortication, and then using a resorbable membrane. First you stabilize the membrane, place your autograft, place your combination of auto-Zeno or auto-alloplast or auto and allografts, and then you stabilize, and we should also grafter area. You should not be miser whenever you're using your grafting, right? Then closure, and this is my stabilizing sutures. Nowadays, I've started using membrane tacks also, wherein I feel sutures are not very feasible to place onto the top of my membrane. Then we use membrane tacks on the top of this. And this is post-healing. We started from there, we ended over here after 4 months. And then this is at second stage. So whatever there was C-shaped concavity at the soft tissue level also, we have covered it up just with the help of a good guided bone regeneration technique. So you can see the final result. You can hardly make out which is the crown, which is the natural tooth. These kinds of results are very predictable if you know the right way to do a guided bone regeneration technique, which membrane, which graft to be used in these areas. One more case of indirect sinus lifts, wherein if you can see vertical height was 5.3 mm. So we have placed implant of 8 mm, and this was my sinus floor. If my sinus membrane wasn't intact, it would have perforated and my graft would have dispersed. Now because of the intact membrane, you can see my graft has these kind of ballooning and hollowing. And post that, my implant placement, this is my NovaBone bone graft which I have used, and you can even use BioSpin or any kind of xenograft. This was post-implant placement into that area. So if you have to do a predictable implant placement with bone grafting, you need to know certain principles which has to be followed. So this was done with the help of Mitsa technique. And again, a case in my aesthetic zone. So in this case, it was internal resorption, extraction of tooth, and there was no interdental bone which was present. So in this case, now again, you have 2 options. First, to place implant, do a graft, or first you can do a graft, then you can proceed ahead and place your implant. So this was first I have extraction, done my grafting. We have waited for at least 18 weeks of healing. Post-healing, this is my bone which I got. So I got a decent amount of bone in zone 1, whereas in zone 2 still I have less bone. So this was a dual zone grafting, and it was done in my 2 stages. And then again, with the help of drills, I've started osteotomy, then using autograft to cover up my implant which was exposed. Post autograft, we have used autograft and xenograft again, and then with the help of collagen membrane, we have covered up the area. So principles remain same. So first it has to be implant placement, then it has to be autograft. So whatever threads are exposed, cover it up with the help of autograft, and then apply xenograft to have a contour grafting. And you have to use membrane in this area. Similarly, in this case, if you see the zenith, it looks more or less a very apt zenith. A smile line was a low smile line, so we can get away with the case. So post that, we have opened up a full thickness flap. Now there was a buccal defect, similarly what we have seen in the earlier cases. Now on this buccal defect, we started placing our we started drilling for our osteotomy site. And once the drilling was done, I always do osteodensification and then I place my implant. This is after my implant placement. I've used a BioGuide or a collagen membrane in this case. So first, before doing any kind of grafting, it is always better to use a collagen membrane and stabilize your collagen membrane. So this was the stabilization of my collagen membrane into my buccal flap. Once this was done, then in this tunneling area, we have placed a mixture of autograft and xenograft, and then we have closed everything. Coming on to my final case, again in aesthetic zone, 3-1 missing. So extraction was done. After this extraction, now we have option how many implant to be placed if we have 3-1 and 4-1 missing. And in lower, since we know these are the narrow tooth zone, it's always better to place one implant and give one cantilever. This is after my initial drill in my immediate implant placement, my osteodensification. Once this was done, you can see my implant placement, which was a 3D implant placement, and this was the exposure of my implant. Again, using the same principle, combination of auto and xeno, with the help of my biodegradable collagen membrane, we have covered the area completely, and this is how we have sutured the final site of it. So every ending is a new beginning. It's journey from breaking up to moving on. So we all are learning. It's always good to stick to your right principle and do a predictable dentistry and implant dentistry. So we run academy as well as we are even having our foundation course with this CynoDent. Volume, please. So we train upcoming youngsters for implant dentistry.
दिल्ली जो है ना दिल वालों की है, जहां दिल आया वही जगह बना लेते हैं हम.
Thank you so much for your patient hearing. If you want to connect with me, you can connect on social media. Thank you so much. Any question, any queries, you're most welcome.
I would like to thank sir for the lecture. Thank you sir for being amongst us. And now it's time for the inauguration ceremony. I would request you all to kindly wait for 5 to 10 minutes. We'll shortly begin with the inauguration ceremony. Thank you.
A very good morning to all of you present here. We'll be starting with the inauguration ceremony in 5 to 10 minutes. We are waiting for our chief guest. Kindly wait. Thank you. I would request you all to please occupy the front seats.
जाड्या पहा शुक्लां ब्रह्म विचारसार परमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम् या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना
Thank you so much, sir and ma'am. Now we request our organizing secretary and vice president of the Indian Society of Dentistry and CynoDent, Dr. Ashish Chandra sir, to address the gathering.
A very good morning to one and all present with us today. I, Dr. Ashish Chandra, extend my warm welcome to you at 8th World Dental Sciences and Oral Health Conference organized by CynoDent International and Indian Society of Dentistry in collaboration with Department of Periodontology, King George's Medical University. I heartily welcome the delegates on the dais, respected Honorable Pro Vice Chancellor, Professor Sonia Nityanand ma'am. I welcome you ma'am. Our Pro Vice Chancellor, Dr. Vineet Sharma sir, welcome sir. Our Dean Faculty of Dental Sciences, Dr. R.K. Patil sir. Our Head of Department of Periodontology, Dr. Nand Lal sir. Our Deputy Registrar, Dr. Pavitra Rastogi sir. Founder and CEO of CynoDent, Dr. Anmol Bagaria. I also welcome our respected dignitaries of the dais and all the delegates. CynoDent has served you selflessly for 7 glorious years. Now and today we are yet again at your service as we embark upon this beautiful 4 days of learning and sharing. We started with 2 days of extensive learning with pre-conference courses, which includes certified hands-on courses on facial aesthetic, lasers, implants, aligners, and many more. And today we officially inaugurate our conference, where we had from morning the scientific sessions and lectures by eminent speakers from all across the India and internationally. I welcome all the speakers, and not just that, to acknowledge and honor the stalwarts of dentistry, we have International Dentist Awards, recognizing and honoring dentists across the globe. So buckle up yourself, because there's a lot we have to teach and a lot you have to learn and upgrade your skills and knowledge. And I yet again, on behalf of Team CynoDent International, I commit to continue to serve you in the coming years as well. I wish you all a good time with us. Thank you.
Thank you so much, sir, for your kind words. I request our respected professor and president of the UP State Dental Council, Dr. Pavitra Rastogi, sir, to address the gathering.
First of all, a very good morning to everyone present here. Very, very respected dignitaries on the dais, Honorable Vice Chancellor, King George's Medical University, Madam Professor Sonia Nityanand ji, our Pro Vice Chancellor, Head of the Department, Orthopedics, Professor Vineet Sharma sir, our Dean Faculty of Dental Sciences, Professor R.K. Patil sir, my Head of the Department, Professor Nandlal Saab, Very dynamic Dr. Anmol Bagaria, President of Indian Society of Dentistry, and Vice President of Indian Society of Dentistry, Dr. Ashish Chandra. Too many dignitaries of the dais, my teachers, teacher of teachers, Professor Dr. D.N. Kapoor sir, Dr. J.N. Jaiswal sir, B.C. Rai Awardee, Professor Pradeep Tandon sir, Dean Faculty of Dental Sciences, Atal Bihari Vajpayee, Professor Shaleen Chandra sahab, Dr. J.N. Jaiswal sir, Dr. K.K. Gupta sir, my council members, Vice President Dr. Harshul, Dr. Sunil Chand Verma, different faculty members from different dental colleges, different head of the departments of my university, Professor R.K. Garg sir, Professor Anup Verma sahab, Professor Avinash, Professor Navneet sir, my medical superintendent dental, Dr. Neeraj Mishra, Dr. Kamleshwar, IDA President Dr. Ashish Khare, Lucknow branch. We all welcome you all, Madam Anuradha Nischal, Madam Dr. Shalini Gupta, Dr. Shalini Kaushal. Apart from the dental fraternity, we are obliged with the presence of few eminent personalities of the society who are present with us, who are motivating the oral health in different social gatherings and different social platforms. For this, I welcome Mr. and Mrs. T.P. Singh Sahab, who is present in the front row. Please welcome, we welcome you, sir. Very eminent activist and a very famous Rang Karmi, ex-director of Bharatiya Nate Akademi, Shri Kulshesh ji, and very social activist Shri Hari Jeevan ji. You are here with us. We are thankful to you. As we all know that today we are gathered here for this inauguration ceremony of the 8th World Dental Sciences. And as we all know that this is the era of evidence-based medicine and evidence-based dentistry, and also the era of minimal invasive dentistry and aesthetic dentistry. So for this, we as an oral health care provider, we know we are bound to provide the best treatment available for our patients. So we have to learn day by day, we have to increase our cognitive domain, our psychomotor skill, and affective domain also in all the fields. So that is why these continuing dental education programs are the need of the hour. We have to learn day by day for the betterment of our patients. As in this 4-day conclave, we inculcate all the aspects of dentistry. We inculcate different branches, how to use the different modes of laser in different treatment modalities, inhalational anesthesia, facial aesthetics, how we can change the smiles of the oral cavity. So we tried a lot in these workshops, which were earlier before 2 days, and now these 2 days we are going to organize the different sessions of the lecture series. And on behalf of the State Dental Council, I am pleased to announce that 24 CDE points are awarded for this 4-day conclave. And I am sure all the delegates who are from the different parts of India and also from the Southeast Asia, we welcome you all in King George's Medical University. This is the very huge historic campus of King George's Medical University, which is 180-year young university. So I welcome you all once again, and I wish to success to all of you. And I am sure that you will enjoy the stay of Lucknow in the coming days. Thank you so much. Thank you. Jai Hind, Jai KGMU.
Thank you so much, sir, for your constant support. Now we request Head of the Department, Periodontology, Professor Dr. Nand Lal, sir, to address the gathering.
A very good morning to all. Sitting on the dais, Professor Sonia Nityanand ji, our Honorable Vice Chancellor KGMU, Professor Vineet Sharma ji, Pro Vice Chancellor KGMU, Dr. R.K. Patil, Dean Faculty of Dental Sciences, Professor Pavitra Rastogi, President UP State Dental Council, Dr. Anmol Bagaria, President Indian Society of Dentistry and Organizing Chairperson, Dr. Ashish Chandra, Vice President of Indian Society of Dentistry and Organizing Secretary of this conference, and sitting up the dais, Head of the Department, former Head of the Departments, Professor D.N. Kapoor sir, Professor J.N. Jaiswal sir, faculty members, speaker, delegates, electronic and print media persons, I welcome you all from core of my heart in the 8th World Dental Sciences and Oral Health Conference, which is being organized by Indian Society of Dentistry in collaboration with Department of Periodontology, Faculty of Dental Sciences, KGMU Lucknow. This conference includes galaxy of huge number of national and international speakers from all the specialties of dentistry. This conference will provide a great opportunity to students, clinicians, and academicians to learn and explore the depth of knowledge about dentistry. I hope and welcome once again all the speakers and delegates in the city of Nawab, with hope that you will have a wonderful stay at Lucknow. I wish a great success for the conference. Thank you.
Thank you, sir, for your wonderful words. Now we request Dean, Faculty of Dental Sciences, KGMU, Professor Dr. R.K. Patil, sir, to address the gathering.
Good morning to all. Honorable Vice Chancellor, Professor Nityanand Madam, Honorable Pro Vice Chancellor, Professor Vinish Sharma sir, Professor Nandlal, Head of Department of Periodontology and Chief Advisor of the conference, Professor Pavitra Rastogi, Convener in the Chief of this conference, President UP State Dental Council, Dr. Anmol Bagaria, Organizing Chairman of the conference and Founder CEO, CynoDent International, Dr. Ashish Chandra, Organizing Secretary and Co-Director, CynoDent International, dignitaries of the dais, distinguished speakers all around the globe, colleagues, fellow dental professionals, and dear student. It gives me immense joy and pride to welcome you all to the grand inaugural function of International Dentist Convention and the 8th World Dental Science and Oral Health Conference. This prestigious event is brought to you by collaborative effort of CynoDent International, the Indian Society of Dentistry, the Department of Periodontology and Implantology, Faculty of Dental Sciences, King George Medical University, and Society of Periodontology at the historic King George Medical University, Lucknow. We are delighted to host you in the beautiful city of Lucknow, renowned for its rich history, Nawabi culture, and tehzeeb. Our journey through the world of dentistry has been no less extraordinary, from the early days of rudimentary tools and techniques to the modern era of precision dentistry. Our profession has evolved dramatically and drastically. Today, we are at the forefront of oral health care, contributing not only the beautiful smiles, but also the overall health and quality of life of our patients. The conference, with its theme, Recent Advancement and Trend in Dentistry Moving Towards a Bright Future, symbolizes commitment to progress and underscores the importance of innovation in technology, research, and clinical practice in shaping the future of dentistry. Over the next couple of days, we have a remarkable array of session and presentation of world-known speakers that promise to enrich our knowledge and inspire us to reach new heights in our profession. These experts in the field of dentistry from across the globe will share their insight and experiences. I hope you will actively participate and take full advantage of this unique platform for learning and networking. The CynoDent has a long-standing tradition of excellence, and this is the second consecutive year they are holding the event at KGMU Lucknow. And I have no doubt that this year too, event will exceed all expectation. Before I conclude, I would like to extend my warm wishes for a pleasant stay here in Lucknow. As you know, Lucknow is renowned for its mouth-watering dishes, and you won't want to miss from the delectable kebabs to the fragrant biryani and irresistible sweet. So take some time to enjoy the local cuisines and immerse yourself in the flavor of the city during your stay. My sincere thanks to organizer for inviting me for this ceremony. Have a great event. Thank you.
Thank you, sir, for your inspiring words. Now we request Pro Vice Chancellor, sir, Professor Vinit Sharma, sir, to address the gathering.
Thank you, Honorable Vice Chancellor, Professor Sonia Nityanand ji, Professor Patil, Dean Dental, Faculty of Dental Sciences, Professor Nandlal, Professor Pavitra Strogi, Dr. Anmol, and Dr. Ashish, my teachers of the dais, my senior colleagues, delegates, faculty members, ladies and gentlemen. It's a proud moment to be a part of this learning process by the Faculty of Dental Sciences. I've been observing that they do hold these fresh innovations and classes for the youngsters to learn, and learning is a constant process. It is evident by the very fact that Pavitra Rastogi mentioned that there were 24 credit points for this conference. 24 credit points for 4 days is a huge credit. And not only the dental sciences, but all the medical faculty, also the NMC of dental science, dental and NMC of medical also require these constant programs to be followed up. I congratulate the Department of Periodontology. I congratulate Dr. Anmol Bagaria, Dr. Ashish for holding this conference. I'm sure this will go a long way in the learning process of this university. Thank you.
Thank you so much, sir, for your wonderful words. Now we request our chief guest, Honorable Vice Chancellor, Ma'am, Professor Dr. Sonia Nityanand, Ma'am, to address the gathering, inspire all of us with the words of wisdom.
Thank you. Professor Vineet Sharma, the Pro Vice Chancellor, Professor Patil, the Dean of the Faculty of Dental Sciences, Professor Nanlal, who is the head of the department and the man behind this whole program, Professor Pavitra Rastogi, President of the UP Dental Council, Dr. Anmol Bagaria, President of the Indian Society of Dentistry, and Professor Ashish Chandra, the Vice President of the Indian Society of Dentistry. My teachers here, I can see Professor D.N. Kapoor here, I can see Professor Pradeep Tandon, and many other teachers, all the esteemed faculty members of dentistry, all the faculty members from other faculty members from King George's Medical University, the residents, the staff, and all the participants. A very warm welcome on the behalf of the King George's Medical University to this 8th Dental Sciences and Oral Health Conference, which has been organized by the Department of Periodontology, Faculty of Dental Sciences, KGMU, and the Indian Society of Dentistry in collaboration with the King George's Society of Periodontology. A very warm welcome to all of you and good wishes to have a very fruitful conference today. I have seen the glory of the dental college here. Dr. Vineet Sharma will support me, Dr. Pradeep Tandon, Dr. D.N. Kapoor. You know, I entered as a medical student in 1980. At that time it was King George's Medical College. It had a fantastic dental college headed by Dr. T.N. Chawla. I think it was the best in the country at that time, the largest and best in the country. And I would say through the years, I saw the new building come up in front of us. We've seen the new building come up and how it has expanded over the years. It had the tradition of providing quality dental education, excellent patient care, which I think has been carried forward over the years. So historically, this is one of the best dental schools in the country. I'm so happy that this conference has been organized today the theme being on lasers, smile designing, facial aesthetics, dental implants, and more. And what I understand is that the main focus will be on the advances in technology and in the future trends of oral dental therapy. So much has come up in the field of dentistry, like lasers, etc. So I'm sure all of you will tremendously gain by this workshop, and I hope some of the young minds here are ignited by imbibing the knowledge which is given today to even come up with greater innovations in technology and in oral dental treatment. I would like to compliment the Department of Periodontology for organizing this conference at such a large scale. Very heartening to see so many participants, and good luck to all of you. Thank you. Jai Hind.
थैंक यू मैम, थैंक यू फॉर योर काइंड वर्ड्स. हमारे ऋषियों ने कहा है जीवेम शरदा शतम, अर्थात कार्य करते हुए 100 वर्ष तक जीवित रहें. पर ऐसा करने के लिए हमें बहुत ही स्वस्थ जीवन शैली एवं संतुलित आचार विचार एवं व्यवहारों के साथ अपना जीवन व्यतीत करना होता है. तुलसीदास जी ने भी कहा है मुखिया मुख सो चाहिए, तो उन्होंने मुखिया की तुलना मुख से की है. तो जो एक सामाजिक चेतना है कि कैसे मुख स्वास्थ्य मीन्स ओरल हाइजीन इज़ हाउ मच इम्पॉर्टेंट फॉर दी कंप्लीट ओरल हेल्थ इज़ वेरी वेरी इंपॉर्टेंट. तो आज हमारे बीच में कुछ जो मोटिवेटर्स हैं ओरल हेल्थ के लिए, जिन्होंने हमें बहुत सी हेल्प की है, बहुत से डेंटल कैंप्स में हमारी सहायता की है, तो उनमें से कुछ एमिनेंट लोगों को हम मैडम आपसे रिक्वेस्ट करेंगे सम्मानित करने के लिए. सबसे पहले मैं आमंत्रित करना चाहूँगा मिसेस एंड मिस्टर टीपी सिंह जी. Please give them a big round of applause. हमारे बीच में हैं आदरणीय श्री सूर्य मोहन कुलश्रेष्ठ जी, जो भारतेंदु नाट्य अकादमी के अध्यक्ष रहे हैं. बहुत सारी मूवीज़ में उन्होंने काम किया है, बहुत सारे नाटकों में उन्होंने काम किया है, और इस भावना के साथ कि कैसे सामाजिक चेतना जागृत हो, आदरणीय श्री सूर्य मोहन कुलश्रेष्ठ जी. हमारे बीच में सामाजिक सेवी जिन्होंने ऐसा काम किया है कि जिनके बारे में कुछ भी कहना सूर्य को दिए दिखाने के जैसा होगा, आदरणीय श्री हरि जीवन जी.
Thank you, sir. It is now time to honor our dignitaries with a symbol of respect in order to remember this momentous occasion and to express gratitude for their valuable time. First, we would like to call upon Dr. R.K. Patil sir, Dr. Nand Lal sir, Dr. Pavitra Rastogi sir, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir to please present a memento to the Honorable Vice Chancellor ma'am, KGMU Professor Sonia Nityanand ma'am. Thank you so much, ma'am. Now I request our dignitaries to present a memento to Pro Vice Chancellor Professor Vinit Sharma, sir. Thank you, sir. Now we would like to present a memento to the Dean Faculty of Dental Sciences, KGMU, Professor R.K. Patil, sir. Thank you, sir. Now we would like to present a memento to the Head of the Department, Periodontology, Professor Dr. Nand Lal, sir. Thank you so much, sir. Now I would like to call upon our organizing chairperson and president of Indian Society of Dentistry and CynoDent, Dr. Anmol Bagaria ma'am, to deliver the vote of thanks.
Once again, good morning everyone. Warm greetings to one and all. I welcome you all to the inauguration ceremony of the 8th World Dental Sciences and Oral Health Conference and International Dentist Convention. Firstly, all thanks to God for blessing all of us with His choices blessing. I would like to thank my mom and dad for their constant support always, and my dearest Mamaji, and also respected Dr. D.N. Kapoor sir for his constant support. Thank you, sir. I would extend my heartfelt gratitude to all the dignitaries on the dais and off the dais and all our dear delegates who have graced the occasion of inauguration ceremony today. Eminent Chief Guest, Honorable Vice Chancellor Ma'am, Professor Dr. Sonia Nityanan Ma'am, thanks for giving us your valuable time and blessings. We are truly honored to have your gracious presence with us today. Thank you, ma'am. I wish to extend my sincere thanks to Honorable Pro Vice Chancellor Sir, Professor Vinit Sharma Sir, Dean Faculty of Dental Sciences, Professor R.K. Patil Sir, Head of Department of Periodontology, Professor Dr. Nandlal Sir, UPDCI President Dr. Pavitra Rastogi Sir, Dr. Ashish Chandra, for the tremendous support in making this event a grand success. I would also like to thank our patrons, advisory board members, head of all departments, faculty members of Faculty of Dental Sciences, and all the members of the organizing committee and all our academic partners for the tremendous support. I also thank all the speakers who have taken out their time from their busy schedule and made it here. A big thanks to all my dear delegates and students who have trusted us and joined us today. Thanks to all the speakers, clinicians, and academicians who have joined us to enhance their knowledge and skills. Sorry if I have missed any names, but I am highly thankful to each one of you. Thank you once again for being there with us and giving us your valuable time. I hope you will enjoy the learning experience with us. Have a happy day and a happy conference ahead. Thank you, everyone.
Thank you so much, ma'am. We request you all now to please rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I would like to thank all the dignitaries for gracing the inauguration ceremony. Delegates, we will be resuming the lecture shortly. Thank you.
Thank you everyone once again for being here for the inauguration ceremony. As the inauguration ceremony has come to an end, without further ado, it's time to once again start with the guest lectures. I would request all the delegates to kindly occupy the front row seats. Please come forward. I would like to call upon the next speaker for the day, and that is Dr. Malika Sethi ma'am. A brief introduction before ma'am comes on the stage and start with the lecture. Dr. Malika Sethi graduated from Rajiv Gandhi University of Health Sciences, RGUHS, Karnataka, and thereafter completed her post-graduation in the field of periodontics. She is a faculty, laser dentistry, Universidad del Gran Rosario, Argentina. She is also on the panel of the prestigious Asian Academy of Laser Therapy, AALT, Singapore, and key opinion leader for BioLace India Private Limited. She has been a distinction holder throughout her career. She has completed her mastership and diploma in laser dentistry by Society for Oral Laser Applications affiliated to University of Vienna. She has been an invited keynote speaker and conducted workshop on lasers at the International Symposium on Academic-Based Clinical Dentistry 2019 at Dhaka, Bangladesh. She has also been deliberated in the International Conference on Dental and Oral Health held in Dubai as a keynote speaker. Dr. Malika deliberates on lasers and topics related to periodontology and has been a guest speaker in prestigious conferences at various national conferences. It's a pleasure to have you here today, ma'am, and I would like to welcome ma'am on stage. Please welcome ma'am with a round of applause. Yes.
We would like to felicitate our academic partners for the conference. We are thankful for their constant support. First, we would like to invite respected Pro Vice Chancellor Sir, Nandlal Sir, Pavitra Sir to felicitate. We would also like to invite Dr. Anmol Ma'am and Dr. Ashish Sir. First, we would like to call our Chief Academic Partner, Subharti Dental College and Hospital, Meerut. The Chief Academic Partner, Subharti Dental College and Hospital, Meerut. Next, we would like to felicitate Babu Banarsi Das College of Dental Sciences, Lucknow. Next, we would like to call Bharatiya Vidyapeeth Dental College and Hospital, Navi Mumbai. Career Postgraduate Institute of Dental Sciences and Hospital, Lucknow. Next is Kotiwal Dental College and Research Center, Moradabad.
Many congratulations. Next one is Maharana Pratap Dental College, Maharana Pratap Group of Institution, Kanpur. Many congratulations, sir. The next one goes to Shri Guru Ram Das Institute of Dental Sciences and Research, Amritsar, Punjab. Anyone can come from Shri Guru Ram Das Dental College. The next one is Chandra Dental College and Hospital, Lucknow.
Next, we move on to the speaker felicitation. We would like to felicitate our academic partner, Babu Banarsi Das College of Dental Sciences, Lucknow. Next, we move on to the speaker's felicitation. We would like to felicitate Professor Dr. R.K. Patil, sir. Shri Guru Ramdas Institute of Dental Sciences and Research, Amritsar, Punjab. तैयार है? Next, we move on to the felicitation of our speakers. We would like to felicitate Dean Faculty of Dental Sciences, KGMU, Professor Dr. R.K. Patil, sir. Next, we would like to felicitate Professor Dr. Shaleen Chandra, sir. Dean Atal Bihari Vajpayee University. We would like to call Dr. Malika Sethi, ma'am. Continue this session. We would like to felicitate Dr. Malika Sethi, ma'am.
To invite Dr. Athri Rajgopal, sir. Many congratulations, sir. Now we would like to invite Dr. Jasnit Kalra, sir, on the stage. Now, next we would like to invite Dr. Raghu Dhanpal, sir, on the stage.
Dr. Raghu Dhanpal, sir, is an international speaker from Malaysia in the Department of Oral and Maxillofacial Pathology. Congratulations, sir.
Thank you, all the dignitaries. Now we would like to invite Dr. Malika Sethi, ma'am, to continue the session.
Hello. Hello. Well, good afternoon, ladies and gentlemen. It is a matter of great pride and proud privilege to be a part of the prestigious 8th World Dental Science and Oral Health Conference being held in this prestigious institution, King George's Medical University, Lucknow. Excuse me, it's not moving. Hello? It's not moving. Well, at the very outset, I would like to thank the organizers, especially Dr. Ashish and Dr. Anmol, for giving me this opportunity to be here today on this platform. And I'm fortunate to share the platform with a galaxy of eminent speakers. Well, we all know we are moving from steel age to laser age, and today I would be deliberating on the topic, laser tactic, bringing art to surgical periodontics. So when laser strikes the tissue, it can either be reflected, absorbed, scattered, or transmitted. As far as the absorption curves of different dental compounds by various wavelengths is concerned, if you look here, the shorter wavelengths, that is the wavelength which lies between 500 to 1000 nanometers, are readily absorbed in pigmented tissue and the blood elements. Whereas the longer wavelengths, they are more interactive with water and hydroxyapatite. Laser exerts different tissue effects. It can be photothermal, photochemical, photovaporylysis, and biostimulation. Well, ladies and gentlemen, the principal effect of laser is photothermal, that is conversion of light into heat. The diode and the ND-arc, they exert a hot tip effect. Now, what is this hot tip effect? Basically, the tissue is vaporized or coagulated by the overheated tip rather than the laser energy itself. And these are the different observed effects at different tissue temperatures. If you look here, at 37 to 50 degrees, hyperthermia takes place. 70 to 80 degrees, welding occurs. Well, this is again a Viva question. At more than 200, carbonization takes place, which is said to be detrimental to the tissue. Moving ahead, talking about lasers in surgical periodontics, well, I'll walk you through various clinical cases. Yesterday, we had a full one-day session where I spoke about lasers, conducted the workshop as well. So today I have just limited myself to about lasers in surgical periodontics. So what is the rationale for therapy? Why do we need to incorporate lasers in our practice? Firstly, it allows for root surface decontamination and detoxification. Secondly, there is targeted reduction in subgingival bacteria. Thirdly, suppression of inflammation. It allows for periodontal regeneration and biostimulation. Now talking about lasers for soft tissue surgery. This first case is a case of, well, before that, what is the effect of laser on soft tissue? So laser can cut, ablate, or reshape oral soft tissues. There is no bleeding, no scarring, and no sutures are required. You just need topical anesthesia. No injectable anesthesia is required. Secondly, it allows for greater patient comfort and safety when you compare it to electrosurgery. Also, there is decreased pulpal pain. Well, this first case is a case of drug-induced gingival enlargement. The patient was epileptic and was under anti-epileptic drugs for the last 10 years. So gingivectomy was planned by 3 different methods on the same day in 3 different areas. If you see here, external bevel gingivectomy with a scalpel, Electrosurgery is used here. Laser, 980 nanometer diode laser at 2.5 watt in contact continuous mode. The initial 7-day healing revealed that the scalpel wounds healed well, followed by laser and then by electrosurgery. Well, both laser and electrosurgery lead to lateral heat dissipation, but it is more with electrosurgery and less with laser. So for such cases of gingival enlargement, where both the components are present together, that is fibrotic and inflammatory, scalpel is still considered to be the gold standard. A case of frenectomy, I'm sure all of you can appreciate papillary attachment as classified by Plasek in the year 1974. So you can use a laser here. Well, a 940 nanometer diode laser in contact continuous mode was used. Just see, so the first incision is a vertical incision which helps in disruption of the mucosal continuity. Later, you give a horizontal deeper cut which separates the fibers and you end up having a rhomboidal shape of the frenectomy area. Can you see bleeding? No, absolutely bloodless field. And this is at 1 year after treatment. Moving ahead, hyperpigmented gingiva is a major aesthetic concern. Laser can be used for removal of superficial epithelial lining in short, light paint brush stroke in a horizontal fashion. So this case, the power was 0.8 watt. This is immediate post-operatively. This is at 6 months after treatment. Well, this case was also subjected to histological analysis, and this is the preoperative dense pigmentation. You can appreciate there. The pointer is not working. Hello? The pointer is not working. I'm not able to, this is not working. This pointer is not working. Ye. Pointer? हाँ, pointer work नहीं कर रहा. If you can change the pointer for me, that will be good. So this is a preoperative dense pigmentation with Mason photonar stain. You can appreciate this is the post-operative view at 6 months after treatment. तो slide changer कहाँ है? Slide changer इसमें दो थोड़ी होते हैं. वो वाला में प्रोजेक्टर पे चलता है, LED पे नहीं चलता ना वो. It's okay, रख लो आप. यहाँ रख दो. ऑन करने चल जाएगा. वो प्रोजेक्टर पे चलता है. So important takeaway points. Well, I just have 30 minutes for my presentation. So in between technical glitches are also there. So I am sure you will bear with it. Now, a few important takeaway points as far as periodontal wound healing following soft tissue surgery is concerned. Lasers, rightly said, are not employed for incision. Their target uses being excision and ablation. Now, if we have deeply penetrating lasers like the diode, they are very, very useful for lip and the tongue tissue. Why? Because they bleed readily. Whereas if you use diode for bone, tooth surface, you'll tend to damage the surface. So diodes are best for tissues which bleed, like the tongue and the lip. Talking about lasers for surgical pocket treatment, what is the rationale for therapy? Well, first, there can be challenges to complete debridement and disinfection of periodontal or peri-implant pockets owing to various anatomic complexities which are present. Secondly, the clinical attachment level and the pocket depth produced by initial therapy may be inadequate for optimum health. Therefore, you require surgical intervention. Well, this case is a case of laser-assisted flap surgery. Please remember, laser is always used as an adjunct. It is not used as a monotherapy. So this is a case of laser-assisted flap surgery. You can appreciate a mucoperiosteal flap which is raised. Now, how do we use laser and where do we exactly use laser for periodontal treatment? When you raise a flap, you can de-epithelize the undersurface of the flap, as you can appreciate there, where in this case, 20 seconds each tooth was lased at 1.5 watt. Now, what can you appreciate? This is the pre-lacing, and this is the post. This is the pre-lacing, this is the post-lacing effect, where a light brownish appearance is imparted to the tissue. Important points to remember: the tip should be kept at an angle of 45 degrees, horizontal overlapping strokes should be applied, and it exerts a GTR-like effect. Now, what is laser-assisted GTR? The epithelium can later be ablated every 7 to 10 days from the outer part of the pocket as well. That is, you have to ablate the outer epithelium as well, and you end up having a long-term stable connective tissue attachment without long junctional epithelium, as stated by Romanos in the year 2015. Now, lasers can also be used for regeneration, because small contact tips are available which can access deep intra-bony defects and furcation areas. And one such study, which is a landmark study, was conducted by Nevins in the year 2012, where the authors used Nd:Arg laser, 1064 nanometer laser, and they were pivotal in providing histologic evidence of periodontal regeneration. The authors concluded mean probing depth reduction was found to be around 5.4 millimeters, and there was considerable gain in the clinical attachment level after 9 months of follow-up. Now, lasers have also been used for osseous surgery, where you can harvest bone, can be used for implants as well. Well, this case is the case of bone graft harvesting. You can appreciate the preoperative OPG, where the mandibular symphyseal region is used as the donor site. Now, the first picture shows the recipient site in the frontal maxillary jaw, which has deficient bone and which precludes the placement of an immediate implant. Second picture shows a monocortical bone graft is harvested. Can you appreciate the precise cut of the area? So this is with the hard tissue laser. You can appreciate the precise cut, and thereafter is fixed on and secured with 2 titanium screws. So a hard tissue laser can be used to cut bone, for harvesting bone, as well as for preparation of osteotomy site. Now, very interesting, lasers can be used for crown lengthening as well. I'm sure all of you are aware of this. But I'm talking about laser-assisted flapless crown lengthening. That is, the decision-making on the use of lasers for crown lengthening is based on the osseous biotype. And if I'm using a hard tissue laser, it is ideally indicated for a medium gingival biotype case where the width of the osseous crest is 1 millimeter thick. If you have a thick biotype, what will happen? You'll end up having a trough or an intra-bony defect. Whereas if you have a thin biotype, you end up having overheating and an unpredictable healing response. Well, I'll show you a video where a case of laser-assisted flapless crown lengthening is demonstrated. Can I have the sound? Gummy smile, excessive gingival display. Thoda kam kar do, thoda kam karo. Excessive gingival display more than 3 millimeters. So the first step is sounding and marking the biologic width. I'm sure all of you know what is biologic width. That is the sum total of the connective tissue and the junctional epithelium. And ideally, it should be 3.04 millimeters. If you violate the biologic width, you end up having inflammation and loss of periodontal support. The second step, gingival ablation with a hard tissue laser. I'm using all tissue laser here, erbium chromium YSGG. So this is just doing gingivectomy, that is crown lengthening, the second step. So water coolant is very, very important with a hard tissue laser. In case if you're using a soft tissue laser, you need to use gauze dipped in saline. But I'm using a hard tissue laser here, which has air water coolant inbuilt. this is gingival ablation. The third step, subgingival osseous contouring is done immediately after gingival ablation with the same laser, all tissue laser. You just need to recontour the bone. So this is rightly what is called as flapless osseous laser crown lengthening. And just look at the immediate post-operative photograph of the patient. The patient was very, very happy. You can very well appreciate the difference. Gummy smile, and now the patient is in front of you. This is flapless osseous laser crown lengthening. I'll walk you through few cases with the soft tissue laser, Epic-X 940 nanometer diode laser. Now a very young chap who actually fractured his central incisor, a very, very simple case. Root canal was done for the patient. Models were made. Composite build-up had to be done. Of course, crown lengthening was done and restored with PFM crown. A full mouth rehab case. This is a pre-operative OPG. So I did crown lengthening for this patient. Intentional root canal was done for all mandibular anteriors. Well, this is how the patient looked when she initially reported. 940 nanometer diode laser at 1 watt in pulsed mode was used. Composite build-up was done for both the arches. And this is at 6 months full mouth rehab with PFM crowns. The patient was very, very happy with the treatment. Well, she was very, very cooperative also. 75-year-old female who reported from Gangaram Hospital, New Delhi. Important points to remember as far as laser for osseous surgery is concerned. Rotary instruments, they only cut the tissue they come in contact with. Lasers cut to an unknown depth away from the application tip. Second most important point is depth control is rarely an issue. Damage to the underlying tissues can be avoided by adjusting the angulation of the application tip. Thirdly, if you are using an erbium YAG laser, saline irrigation is very, very important because it allows for lubrication and there is no toxic substance production with the erbium YAG laser, unlike if you're using a carbon dioxide, you end up having toxic products which are liberated like cyanamides and cyanates. Lastly, laser is said to reduce noise, minimizes vibration, which is usually associated with your mechanical cutting devices. Another case of laser-assisted laterally positioned flap. Well, I guided a thesis also on this where we actually compared LPF, that is the lateral pedicle flap for gingival recession, and LALPF, that is laser-assisted laterally positioned flap. Well, this is the original article. A case of Miller's class 2 gingival recession done with 8110 nanometer diode laser at 3 watt. So the first incision is a vestibular incision around 5 millimeters from the depth of the recession defect. The second incision is an oblique incision, horizontal oblique incision, and this is positioned onto the recipient bed and sutured. Well, what does laser do here? This is the original article quoted by Yilmaz in the year 2014. So what does laser do here? I'm sure you can appreciate this is at 6 months after treatment. Laser helps to reduce edema and ecchymosis. It allows for a passive and relaxed flap, decreases your apical pull, allows for maximum augmentation of the gingiva, and very well coated, it stimulates growth factors as well. Lastly, talking about photobiomodulation. Initially, this term was known as low-level laser treatment. Nowadays, it is known as photobiomodulatory therapy. Since my presentation is limited only to periodontics, I would talk about LLLT in periodontology. Before that, what is LLLT? LLLT is basically it emits short wavelength, red or infrared light. They penetrate to a depth of 3 millimeters to 15 millimeters in both hard and soft tissues. Performance power range from between 50 to 500 milliwatt, and they lie in the electromagnetic spectrum between 630 to 980 nanometers, both in pulsed and continuous mode. A case of treatment of intra-bony defect with photobiomodulation. You can appreciate the defect depth measurement with a calibrated periodontal probe. Well, I used diode laser 0.5 watt. Now, I was talking about class 4 lasers. I was all this while talking about incision, excision, ablation. That is class 4 laser. This is class 3 laser or therapeutic effect. It will be at a lower power, that is 0.5 watt. It has non-heating effect. So 0.5 watt diode laser applied for 2 minutes, repeated after 5 minutes for 90 seconds. Allograft was placed thereafter, DFDBA followed by suturing. I talked about laser-assisted flap surgery where we de-epithelialized the undersurface of the flap. I'm sure you remember. The second area where laser can be used in flap surgery is for biostimulation. Now, once you close the flap and you suture it, you can biostimulate the area. What does biostimulation do? Biostimulation is a part of LLLT. It accelerates your healing, it increases ATP synthesis, it stimulates fibroblasts, allows for collagen formation, allows for osteoblast proliferation, and increases your bone formation. That is, it allows for regeneration of tissues. In this case, biostimulation was done immediately after suturing. You can recall the patient after 48 hours. You can recall the patient after 7 days, obviously, when you have to cut sutures, and you can do biostimulation. There will be no harm. It will accelerate your healing process. Now, just see the results. This is at 1 year follow-up of the patient. Good amount of bone, which is evident on the radiograph. A case of free gingival graft. We all know when we harvest free gingival graft from the palatal area, there is profuse bleeding which is happening. Now we have 0.5 watt. This case was done with a 940 nanometer diode laser in non-contact continuous mode, and the site was lased for 60 seconds. Now whenever you're using LLLT, non-contact mode is important. You do not have to touch the tissue. 0.5 watt is important. You can usually keep your seconds till 30 or 60 seconds. That is, you can laze the site for 60 seconds. And there was good hemostasis which was achieved in this patient. Important points to remember as far as photobiomodulatory treatment is concerned. It is a non-invasive treatment. It has non-heating effect. There are no true side effects of LLLT which have been reported. Instead, it allows for accelerated wound healing, regeneration, and there is immune enhancement. Ladies and gentlemen, important point, again, one more important point to remember out here is the effect of LLLT is most prominent in cells which have reduced redox potential. The effect on healthy cell is not reported. So once if you have reduced redox potential, there it will work better as compared to healthy cells. Talking about lasers in implants, why do we need to incorporate laser technology in implant dentistry? Well, these are few advantages. It increases hemostasis, reduces infection. There is minimal damage to the surrounding tissue. It reduces swelling. There is less pain, and very, very important is impressions can be made immediately after your second stage procedure, unlike if you use scalpel for uncovering of the implant. Now, out of all the lasers, Nd:YAG is a big no because it is said to result in porosity and melting of the area of the implant. Diode is a very good laser. It does not cause any damage to the implant surface. Erbium-YAG is also a very good laser. Well, both erbium-YAG and carbon dioxide, they are reflected away from the implant surface. This is an added advantage. Erbium-YAG laser also results in detoxification, bactericidal effect, allows for re-osseointegration as well. Now, if I talk about the carbon dioxide laser, the socket for gingival contouring. Now, for gingival contouring, if you use a laser, there will be minimal shrinkage of the gingiva and you can take impressions immediately. It can also be used for the treatment of peri-implantitis. All of us know it is due to bacterial ingress. You end up having loss of the bone. Can you appreciate the trough which is formed? So laser helps in decontamination, degranulation, allows for hemostasis and has a bactericidal effect. Well, the prevalence of peri-implantitis is reported to be present in about 47% of patients with implants. Another interesting case of treatment of peri-implantitis with laser, you can appreciate this is at 4 months after treatment. Can you appreciate the implant threads which are exposed from the buccal aspect? So degranulation done with a 980 nanometer diode laser at 1.5 watt in continuous mode. DM bone graft is placed, followed by suturing, and this is at 6 months post-operatively. A good amount of bone was evident on the radiograph. A case of uncovering of the implant with a soft tissue laser, a 980 nanometer diode laser at 1 watt was used here. Well, it is important to preserve the width of the attached gingiva around the implant, because attached gingiva serves as a barrier to exposure of the implant body due to recession over time. Well, ladies and gentlemen, I would like to end my presentation with this American Academy of Periodontology Best Evidence Consensus Statement, where 3 questions were addressed, quoted in the Journal of Periodontology in the year 2018. So the first question which was addressed was related to non-surgical therapy. The authors concluded that laser, when it is used as an adjunct, it offers similar or slightly better clinical outcomes compared with laser used as a monotherapy. So laser is seldom used as a monotherapy, it is always used as an adjunct to your mechanical therapy. Current evidence fails to demonstrate a long-term benefit, that is more than 48 months. And whenever you're using laser for non-surgical treatment, preferably it works well in moderate to deep pockets, which are more than 5 millimeters. The second question which was addressed was related to mucositis or peri-implantitis. The authors concluded no substantial clinical current evidence as far as its use for mucositis is concerned. Short-term benefits in the treatment of peri-implantitis as far as reduction in bleeding is concerned. Well, we all follow evidence-based dentistry, I'm sure. No evidence suggests long-term benefits. And the third question was related to APDT. Well, I've not talked about this because this is non-surgical part of periodontal treatment. So APDT provide improvements in residual probing depth, which are again more than 5 millimeter, and we have good amount of gain in clinical attachment level. Expert opinion also suggests that their use on healthy sites could cause harm rather than any good. Also, if lasers are not used according to proper protocol, you can damage your teeth, implant, or surrounding tissues. Well, these are the other applications of lasers. Lasers can be used in all aspects of dentistry. I talked about this yesterday. So lip depigmentation for TMJ disorders, mucocele, all oral medicine lesions, lichen planus, where you can use photobiomodulation. This is OSMF in ortho, prostho, pedo, ankyloglossia, tongue tie, in everything. Well, thank you so much, and this has been my journey. I have deliberated at various national and international platforms, starting with Delhi Dental Show in the year 2018. Well, this was the PG convention at Jaipur. I was there at Dentistry 2018, at ICD, IDC 2019. This was at IDA Faridabad. I was there in Lucknow in 2018-22, both for UP Dental Show. This was again consecutively at the Delhi Dental Show, New Delhi. This was at Agra. And this was recently at 40th MP State Dental Conference in January 2023 in Bhopal. This was again where I conducted a workshop at Mansarovar Dental College. And this was the recent one where I conducted a 5-day workshop on laser at Government Medical College, Chittagong, Bangladesh. Again, I was invited to the International Symposium at Dhaka, and this was at ITS Dental College. Well, this is my venture in the heart of Gurugram. Thank you so much. Thank you so much for having me here, and I would like to congratulate everybody, and especially the organizers, for conducting a wonderful conference. Thank you. You can contact me on social media. This is my email, where you can fire questions on laser. Thank you. Thank you once again.
Thank you, ma'am, for the informative lecture. It was a pleasure listening to you. Thank you once again. Now it's time to invite the next speaker of the day, and that is Dr. Atharya sir. A brief introduction of sir. Sir is trained in all aspects of oral and maxillofacial surgery, a fellowship in facial aesthetic medicine and aesthetic surgery, Germany. He has received training in facial cosmetology and facial aesthetic surgery from Korea. He is training in facial transgender surgery from Thailand. He has done a fellowship training in cleft and craniofacial surgery. He is a certified implantologist with a fellowship in oral implantology. Sir has conducted numerous CD programs in various medical and dental colleges all over India. He has been invited as a guest speaker at Japan for the 3rd International Congress of Facial Cosmetology and Trichology in the year 2018. Sir has trained numerous doctors in the field of aesthetics, surgery and implantology. Sir has been awarded for excellence in oral and maxillofacial surgery from International College of Dentists, and he has also been awarded for excellence in facial aesthetics, most preferred oral and maxillofacial surgeon of New Delhi, and Delhi Star Award for excellence in maxillofacial surgery, along with many others. It's a pleasure to have you here amongst us today, sir. Welcome on stage. Please give a round of applause for sir.
Thank you for the warm introduction. Thank you so much. And at the onset again, I would like to thank Team CynoDent, Dr. Ashish and Dr. Anmol for organizing this year after year and doing it with great success. I would like to acknowledge all the dignitaries sitting in the front row. Special thanks to Dr. Pavitra sir for organizing this in the most brilliant way possible. Now you all have a platform to learn from one lecture to another, from one's experience to another, and there's so much being shared. From moving on to a brilliant lecture on lasers that primarily you saw intraorally, we're going to move on to something that we can also use extraorally. I'm going to be talking about facial aesthetics. My routine practice is a maxillofacial practice. I practice in Delhi NCR, and I work with quite a few hospitals there, and I have 2 practices there in Delhi. Aesthetics is a very broad spectrum term. When we talk about aesthetics, I'm going to rush through with a lot of pictures so that you can actually visualize what aesthetics actually means. When you want to train, you need to train properly, and that takes time. So on your picture, I would basically want to say that the face is beautiful. Every face is beautiful. It's just that you need to recognize it in the right proportions, in the right manner. When we are young, we all have fat on the face, and fat is not bad. Okay, on the face, it is something that we require. When we lose fat and volume, and that is the time that we actually tend to age faster. So whenever you see that there is loss of volume from the mid-face and temples, you will start seeing all the soft tissue that actually is supported by that fat tends to collapse. And that is where the face starts looking round and malnourished. And you will see that the face starts becoming oval and kind of out of proportion. Those are the signs of aging. I see a lot of women in the crowd, and whenever I show this slide, I don't get a very good response. Yes, women age faster than men, and it's just because of one fact that men have a broader bony framework, and they can actually camouflage the aging process a little more. But the fact is, I don't really agree with this study because women have a good skincare routine. None of the males do. How many males have moisturized today? How many males have used sunscreen? I haven't, and I'm sure no one in this crowd has. So that is why the males actually tend to age much faster. The integrity of the face is in place because of retaining ligaments. We should not underestimate the power of retaining ligaments that are holding your skin and muscle with the bone. And whenever we age, it's not just the fat that you're losing the attachments. Never forget that there are bony attachments being lost. Never forget that the bone is also aging. So the soft tissue is only draping the hard tissue. And whenever you're losing soft tissue, never forget that the retaining ligaments holding your muscles in place are also losing attachments, and that's how we age. Day by day, minute by minute, second by second, we all age. To keep it in the right proportion, we just have to do the things that we are supposed to do in the right manner. Take care of your skin. Okay, so this fat, when you lose your fat in a youthful face, the temples and the mid-face are the secrets, and that is where the maximum amount of volume rests, and the least amount of volume in your lower third of your face. When you lose this, the proportion changes. So the maximum amount of accumulation is in your lower third of your face, and you lose all the proportions from your temples and your mid-face. That is how this works. Whenever we are aiming at any corrections, we have to know a lot of procedures. I'm not going to be talking about too much about surgical procedures, because if it was a surgical thing that I wanted to show you, it would have been all surgical. But I'll try and give you a brief about some of the surgical things that we do. You need to know about toxins, peels, dermal fillers, lasers, extraoral lasers, blood derivatives, microneedling. Till the time you don't have sound knowledge about all this, you cannot give the right results and the best results to your patients. I call it the poison that heals because it is a poison at the end of the day, but it is used in a freeze-dried form, and we call it botulinum toxin. The term Botox belongs to a brand, Allergan. Otherwise, it is always known as botulinum toxin. Multiple uses, multiple ways of using it. It comes as 50 and 100 units. You need to dilute it further. It comes as an empty vial. You need to dilute it. If it's a 100-unit vial, you need to dilute it with 2.5 ml of normal saline. And have you all seen the insulin syringes? You've not seen insulin syringes? You've seen, right? So it has 40 markings there. Every mark on the insulin syringe is 1 unit. And whenever we talk about the toxin, we all need to talk in units. Okay? So it basically works by stopping the acetylcholine from the neuromuscular receptors. So if the acetylcholine is not separated, is not released, the muscles will not contract. So the toxin is primarily used for dynamic wrinkles. There are 2 types of wrinkles on the face. Dynamic in function. Looking up, smiling, all those lines appearing are dynamic. Whatever is at rest is all static. So whenever it is static, it requires volume. So dermal fillers or fat. Whenever it is in function and you see those lines appearing, it is all an indication for botulinum toxin. We use it for a lot of other purposes as well. TMDs, we use it repeatedly. Siluria, we use it repeatedly. Hyperhidrosis, atypical facial pain, neuralgias, we use it for a lot of purposes. So the thing is, you see a lot of memes all around, right? It's not about creating an artificial face. It is about making a face or whatever areas we are dealing with making it look natural and beautiful at its own age. This is a simple case of a forehead toxin. If you see, this is what we mean by dynamic wrinkles. When the patient is actually making expressions, can you see the lines actually bothering the patient's face by making it look aged? And a simple shot of toxin in 14 days time shows results like these. It's not that the expressions have gone, it's just that it becomes finer and more refined. Another one, only thing with these globular complexes, you tend to put up, these are static, so you want to put in some filler there so that you can ease it out. And there's a shine and a glow that comes because it stops the release of sebum from the sweat glands, so there is a glow that comes. Hyperactive mentalis, again, you get a dimpled chin, straightforward 9 units into the hyperactive mentalis, and the dimpled chin disappears in 14 days' time. The flip side, Botox lasts for about 4 to 6 months' time. Have you all seen patients of gummy smiles? You've all seen, right? If I crack a joke, you'll be able to find one in the crowd. Everyone has it, right? You'll have some patients here who have gummy smiles who kind of restrict their smile. Why? Because they're conscious about it. What is the reason for a gummy smile? Excessive gingival show can be skeletal or dental. Skeletal, if it is because of vertical maxillary excess. If it is dental, mostly altered passive eruption. How many of us would want to, so in my career till now, I've done only 5 cases of orthognathic surgery, which turns out to be a bi-jaw surgery, because of excessive gingival show of about 9 millimeters or more. So very few people want to undergo the knife for a mucogingival or a orthognathic surgery for a gummy smile. So 5 units of toxin into a point known as the Yonce's point, and this is the result that you get in 14 days' time. You can reduce the gummy smile by almost 70%. This is known as, these are the 3 muscles which actually act here, and 1 centimeter lateral to the ala of the nose is a point known as the Yonce's point, and 5 units of toxin there can reduce your gummy smile. The 3 muscles in function here are the zygomaticus minor, the levator labia superioris, and the aleichinesi. So these 3 muscles are your elevators of your upper lip. Just a simple shot of toxin here reduces your gummy smile. This patient was on retainers, and if you see, she's ended her ortho journey, but this is the smile. So this case taught me a lot. I'm not going to get onto the story here, but it's a simple case where we injected 5 units of Botox, and in 14 days' time, I had to inject 4 units more. This case was done 11 years back. Okay, and what happened was she was very happy with the smile, but whenever she was pouting or eating or something, she would say food would drop out. Why was that? Because I over-relaxed the toxin, over-relaxed the elevators of the upper lip by giving 9 units in 28 days. So the ideal dose here, if you want to correct a gummy smile with the toxin, is just 5 units. This is a study, which is my study. If you want to go through it, you can do it. You can go through it. It's the largest case series and the largest study in the world, and I can proudly say so. Studied for the longest period of time. What we have evaluated is some amount of the neuromuscular shape memory stays after the 3rd shot of the toxin. So about 25-30% of the result stays. So the muscles tend to train itself in their own position. Or if you want, you can undergo, you can counsel the patients for a small mucogingival procedure. If you can see a patient of excessive gingival show with poor oral hygiene, a simple small mucogingival incision, vestibular incision, we're not going on to the attached gingiva, and a simple round of suturing and immediate post-op, and these results are going to stay. This is a minor surgical procedure. This is another one which you can actually do. 10 minutes is all it takes, 10 to 15 minutes. Again, it'll last, it's permanent. You don't require the toxin here. We use a lot of toxin for hyperhidrosis, for axillas, palms, soles, face, for the glow, because Botox stops the release of acetylcholine and also sebum, the secretions. We have used it for neuralgias, atypical facial pains. Before we do our neurectomies, we like to inject a toxin in the referred areas or the trigger points. Atypical facial pain, we get a lot of referrals from neurophysicians. Just like we do the frontal Botox, so frontal migraines, temporal migraines, occipital migraines, we use a lot of toxin here. TMDs, till date, I have a case series of 450 patients. And let me tell you, 85% of them were on continuous muscle relaxants and God knows what all for years and years. We've got brilliant results there. And the other 15% we had to take them up for surgery, either a discopexy or a condylectomy or an arthroscopy. But if I can actually deliver results, relieve the pain of a patient non-surgically, talking about is myofunctional pain dysfunction syndrome. These are the points that we routinely inject. These are the points that get affected by migraines and atypical facial pain, frontal, temporal, occipital, and even the scaliness. If you, MPDS or TMD pain will be referred to the shoulders as well. So toxin tends to be a good option for these patients. Coming on to dermal fillers are primarily HA based. So the other kind of filler that you can use for volumetric correction, these are static wrinkles, okay? Now we are talking about static wrinkles. So dermal fillers are primarily HA. The body itself has HA and polysaccharides, so you can use this for all kinds of volumetric corrections. No allergic reactions, absolutely, because the body itself has polysaccharides. It's just a byproduct of a sugar. So these are the commonest available brands in the market that you can use, and these are the techniques. I'm not going to go into the details, but these are the commonest techniques that we use to give results to our patients. These are the depth of placement. The only thing that you need to remember here is you don't need to place your filler too superficial. Otherwise, something known as the Tyndall's effect will come into play. This is how it will appear if you're in the epidermis rather than the reticular dermis or the subcute tissue. I always believe, see, this is not a shortcut process. Aesthetics is a good learning curve. There's a good learning curve here as well. This is how my fellows dissect the cadavers first. Then they train really hard. They train on the cadavers. Here my fellow is dissecting the facial nerve and facial artery and the facial vein, artery on the face. If you know the landmarks for this and how it functions, that's how it needs to be. You need to avoid the vessels when you're using fillers because they can actually cause vascular occlusion. Now I asked this question yesterday as well. We had a pre-conference there and we had some wonderful candidates there learning. And I always tell them, I always ask them, because why I ask them is, how old is she? Because, okay, except for those who were there yesterday, can anyone tell me how old is she? Take a guess. So basically, you guys guessed much better than what was put on the table yesterday. We had people saying 35 and 40 yesterday. So I told them never to guess again in their lives. So yes, she is 72, okay? Now what happens here is, she started early. If you start early with the toxins, fillers and all these skincare regimes, you age less. So the misconception is, start as late as you can. No, if you start early, you will look way ahead of your age because your skin actually needs it. If those fat planes are falling apart, why not get it done? So very little is required if you start early. Too much is required if you start late. And the results itself will be quite different. Now if you see, she was looking aged, corners of the mouth drooping down, and what I've done is I've actually lifted up her corners of her mouth, put in some fillers here, relaxed the depressor anguli oris with some toxin, filled in about 3 to 4 ml of fillers to give her a healthy and nourished and voluminous kind of an appearance which camouflages the sad looking face. In achieving this, I ended up with a complication, and complications I have tons of them to show, I proudly say it. And what is the complication here? The filler actually entered the vessel. This is a vascular occlusion. If not treated, it will end up with a necrosis. This portion of the skin will fall off, okay? And we have an antidote for it. What you need to do is you straight away need to inject that antidote into it and the vascularity will start coming. So the result that you saw here is after I dealt with the complication, okay? This is a simple mid-phase that you see. Before and after is immediate pre and post. So fillers will give immediate results, whereas the toxins will take 14 days to act. If you see this male, for a male pattern, you need to build it up horizontally. For a lady, you need to give a high cheekbone appearance. Imagine a guy walking around with a high cheekbone. How will it look? Absurd, right? So for a male, you need to give a horizontal approach, and that's what we do. So can you see a little bit of volume there? He has a little bit of cheek volume now. And here it's absolutely flat, right? And this is immediate pre and post in 15 minutes time. That's what you achieve with fillers or volumetric corrections. Same male didn't agree for a genioplasty. So if you see the nose to chin angle, it's deficient. And see it now. So 2.5 ml of fillers to augment the chin vertically and horizontally. Again, 15-20 minutes work. This lady had a broad face and she knew she had a broad face. This patient came in and told me, can I get temple fillers done? And I was at a loss of words because no patient actually tells you that. Why would she want to get temple fillers? Because her face was very broad. Okay? And on a broad face, when you actually camouflage and put volume on your temples and mid-face, the jawline looks narrow. So if you see, I've done her temples. Temples, you need to be a little careful. Beginners can't do it because there's a lot of vascularity there with the superficial temporal and the cervical branch of the superficial temporal. Once you get a little experience, it'll be child's play for you. So when we talk about temple volume, we also do something like this. Put in threads right to the temporalis. These are aggressive barbed threads, and we actually lift up the temples with this, and then we put in the volume there. If you see, I'm using these aggressive threads to lift up the tissue which is sagged down. There are different vectors for thread lifts that we use. These are known as small monothreads. These are going to help collagen induction tightening at a localized plane, but they're not aggressive. They are very gentle. These are again the same, but this is my own technique. I put in a lot of blood derivatives through these threads, tighten the jawline, if you can see in this case. These are the aggressive threads that I'm talking about. How do they work? You want to see more? I can show you. So they are long 100 mm barbed threads like Christmas tree. They are going to engage your superficial musculoaponeurotic system, go right to any vector on the face, and I can lift it up to any extent I want. Here I'm going right till the marionette, beyond the corner of the mouth. And when I pull, I can pull up the entire tissue there. And then I just tie the knot at a higher lateral and superolateral extent. And that's all I need to do. And the face gets lifted. All of you must be thinking, how painful would it be? Right? The patient hasn't blinked an eyelid, right? We anesthetize the patient nicely. So if you see, her main concern was the nasolabial fold, which I've corrected in, this is 1 day pre and post. These are all international patients. They come in for a very short duration and they fly off in a week, 10 days time. The same patient I'll show you later, she was so happy with it that she came back for a rhinoplasty after that. This is again my own technique. This is known as a triple vector facelift. So if I'm doing a surgical facelift, it's a surgical. If it's a non-surgical, it's a different approach. So I've taken one approach above the zygoma, one below, and one for the jawline, tightening the entire face laterally. Why would I do that? I tighten the submental area also, lessen the fat there. This is how we go through the mandibular plane. So I'm taking a small approach from the retromandibular approach, and I'm inserting multiple threads there. Why? Because there's too much of volume here. I want to tuck it laterally. Tighten the face, right? So I'm bypassing this area, going through the masseter, bypassing the facial artery. You know the facial artery is right in front of the masseter, right? It's known as the anesthetist artery. You can feel the pulsations here. So we bypass that, reach right till the marionette area. And now the interesting thing I want you to see is when I pull these threads, I want you to see how I can actually pull the tissue laterally. Can you see? So I lateralize it and then I tuck it in laterally. What will it do? It will tuck the face laterally. So it will make your face narrower. Look at her face. She had a round and drooping kind of a face, and now she has a jawline. Is there a difference? Good difference? And this is a result in 1 month, right? Under eye fillers are very routine that we do. This is the before after. This is just a camouflaging procedure. What I want you to see is the technique. When I do the under eyes, I can use fat or I can use fillers. And this is known as a fanning technique, and I will basically give back volume to the under eyes, which is lacking. And the fillers go in right till the medial canthus, but I'm not going to block my medial canthus, otherwise the tears will come through your nose, because you can't block your lacrimal duct, right? Easy. Why is it easy? Because anatomy is something that you need to know. And you can't do this without having sound knowledge of anatomy. Another one, let me show you. Same technique, same thing, let me show you the before and after. Immediate pre and post. You see the tear trough being hollow, dark circles, and this is the immediate post-op. 10 minutes is all it takes, and in 1 week's time you will get brilliant results there because it hydrates, it's hydrophilic, so it absorbs water. Another one, immediate pre and post. I'm not showing you pictures which are 1 week, 2 weeks apart. This is immediate pre and post. Lip fillers. Lip fillers are interesting. These days we have a lot of variations in lip fillers, right? So you just need to replicate the lip tissue as in how it is, okay? A simple case, the lips should look natural. It should replicate, it should look good, it should look voluminous, it should not look absurd, big and absurd, right? A lot of people ask for that, and it's okay to ask for that. Sometimes it's okay to respect the patient's perspectives, but it's the doctor's perspective in play. So if you think some very round, big lips are not going to look good, please go ahead and say no, okay? There's no harm, because this patient will go out with your work, and your name is at stake. This was a case that was sent for lip micropigmentation, and she wanted lighter lips, and that's what I gave her, with voluminous lips. This was a cleft case, so I operated twice, but this time I operated her for a scar revision, just like we do clefts. But for the lips I've just done, she had no anatomy at all for the lips, right? So I've created a lip for her with the help of fillers, so at least she can step out with confidence. This was a patient that was actually done by someone else, and if you see, the fillers were injected wrong. So the lip drooped out, so I had to surgically take out the lip fillers from there, because 1 month later, you can't inject the antidote, it will not work. And some common surgical procedures that all of you can do is, a lot of males have these bulky lips. Okay, these are simple lip reduction procedures that you can all do. It is cutting more of mucosal tissue, and don't compromise on any lip tissue, because no tissue in the body can actually replicate the lip tissue. So be very careful when you do procedures like this. So simple procedure, this is the dissection. If you want, I can show you the video. It's very simple. And protect your minor glands there, and this is the immediate post-op. Buccal fat reduction is again a very important part, integral part of aesthetic procedures. When you remove the buccal fat, you want to remove half of the buccal fat through a small incision into the vestibule. And when you take this out, what happens is bilaterally, okay? You don't need to over-compromise on this fat. And when we take out why isn't the screen coming? And why was it not told? Screen nahi aa raha. Excuse me. Hello? Screen nahi aa raha. What have you missed out? You missed out this. You saw this buccal fat start? No, you didn't start? Okay. उधर इलेक्ट्रिसिटी नहीं है, इधर कनेक्शन का प्रॉब्लम नहीं है. Okay, yeah, it's back. So buccal fat reductions are again something that we do very commonly. I will not take any more time, I'm going to rush through this. But a small incision through the vestibular plane, and we take out 3/4 of the fat there. Why would we do that? We want to reduce the bulk of the face, give it a contour. And bilaterally we would do that. I'm going to rush through that. And this is the immediate pre and post, if you see, before she left the country. We did some cork threads and some jawline fillers also. Can you see the roundness of the face reducing, and there's some contour there? That's how it works. This girl, I had actually suggested a surgical rhinoplasty, but there's something known as a non-surgical rhinoplasty, in which we put in some rhinoplasty threads, multiple threads, put in some fillers there, which is also known as liquid rhinoplasty these days, but that's not something that you should do. It's not a right procedure. Filler should only rest on the bridge. And in 4 months' time, if you see that the bridge actually becomes narrower, the saddling reduces, there is some tip projection that comes. Another one, she thought she had a very broad face on a narrow nose, so first we did the rhinoplasty threads, but then she was not happy, so I took some fat and I injected it onto the face and the nose. And if you see, this is what we did for her. Not just the nose, but we restructured her face as well. Fat is beautiful. And this is the same patient I want to come back to. She came back for a rhinoplasty and brought 3 more patients with her. She's Syrian, okay? You want to see what we did for her before she left? This is what we did for her. And this is the picture she sent when she went back to her country. Does she look good? This is a surgical rhinoplasty with some fat grafting. So coming on to facelifts, we do a lot of surgical facelifts as well. Obviously, you're all beginners, so you won't understand this, but on all the surgical platforms, we discuss a lot about surgical facelifts, pre-auricular, post-auricular incisions, putting the fat planes in the right, fat in the right order, which is collapsed, and excess tissue we just cut off. And this is a male facelift. If you see, we like to do a different approach for males than ladies, because women will have a superolateral approach, males will have a horizontal approach. If you have a patient like this, it cannot be sorted with non-surgical things, right? You will have to go in and do some surgical work there. You want to see what we did for her? This is how she looks. And this is a surgical submental liposuction with a facelift that we did for her. Do you see a difference there? You don't see a difference there? The incision is still there. My facelift incision is still there. And I've taken a small incision in the submental area, tucked in the platysma, surgically taken it out. You want to see how fat grafting is done, which is something that we do almost every second day. We take a small incision into the belly line and below the belt line, and we put a lot of tumors in there, and fat is good. Fat is the best filler that can actually be used. And after we've created a plane there, we harvest this fat, and we start collecting it at the other end of the cannula. This is exactly how liposuction is also done. So there's no rocket science there. Only thing, we attach an electronic motor there. And we are very careful about our visceral planes. We don't damage any organs there. And if you see the far end, I'll start getting the fat. And once I get the fat, the fat has started coming. Now I let the fat settle down. I take out all the extra oils and the fats from there. Then I use my filters. Then I get the fat ready. And then the easiest part of injecting the fillers onto the face, just like we inject a normal filler, we use fat for our injections. Under eyes, temples, mid-face. And that's how this patient looks. The main concern was he always thought he had a tired and a malnourished looking face. In 4 weeks' time, he sent this smiling picture of his. And that's what fat does. It only builds up. It starts getting more and more beautiful, whether it's a male or a female. Okay? Fat has stem cells, by the way. Stem cells, okay? Not just growth factors. So it actually builds up. This is a morphea syndrome. Morphea primarily affects most part of the bodies, but here in the face, we again did fat grafting for him. I'm going to rush through again. There are a lot of growth factors that we use routinely and the blood has a lot of secrets. I'm going to rush through this because there's not much time. PRP, how to make it, this and that. It has to be a 2-sprint process. We use a lot of PRF. We don't use any PRP. For the past 8-9 years, we don't use any PRP. PRP is obsolete for me. Simple cases of fractional lasers. We spoke about lasers. We have a lot of lasers in our kitty which we use. Subcisions, PRF, microneedling, and fractional lasers, pigmentation reductions. We use a lot of fillers made from your own blood, and that is a thing of the future. If you see hair, we do hair every day. I mean, whether it's a transplant or regrowth or rejuvenation, in just 3 sessions you will start seeing volume coming up. There's a whole protocol you need to follow. It's not just injectables. You need to go do a complete profile there to get this on track. Yes, running through this, it'll take time. The classifications. We use punches to do head. In 8 to 10 months time, 12 months time, you get the best results. This was a person who used to wear a patch. Now, patch caused the dermatitis. After removing the dermatitis, we went ahead and 3,500 grafts. Again, the patient's own hair, natural hair. There's nothing better than having your own hair rather than wearing a patch or trying to camouflage. 30-year-old, head full of hair in 10 months' time. And that's what we do routinely. Every weekend, we're doing a lot of transplants. We do a lot of transgender surgeries as well. We do a lot of facial feminization surgeries. And hair transplants, facial feminization, the transplant, female pattern transplants are very important to make a male look like a female. Okay? So not just the face, the scalp also, you need to deal with it differently. So giving a feminine or a female pattern of hair. We do a lot of beard transplants as well, which are very routine for us. And these are all transplanted hair on the beard that you see. This is a regenerative kind of a RF-based device, works very well for skin tightening. People who don't want to go in for toxins and fillers. These are some of the patients that I want you to see how it works. If this patient walks in, you can give her results like this, making it look natural, not artificial. And a combination of all these techniques have been done. Toxins, fillers, threads, blood derivatives, peels, lasers, all done together. It's not just one technique or two techniques. You have to use the best. So she's 63 and she wanted to look a beautiful 63, and that's how she looks now. Another one, combination. See, her concerns are different. So all these combinations brought together work differently. We gave her a high cheekbone with a well-defined kind of a face. This one was a tough one, I always say, because of reasons that you can see. So those long threads that you saw that I showed you, we did 56 of them. Small threads that we showed you, 100 of them, 100 units of Botox, 6 ml of fillers, 1 session of deoxycholic acid to let go of the submental area, and that's how she looks before she left the country. And that's how you can change people's faces. Know it, know your procedures right, know what you can use in your kitty to actually give results. Another one, pigmentation, and she wanted a good-looking, healthier face, and that's what we gave her. Again, a complete facial rejuvenation. You can change the faces completely. And that's what, again, a lot of things, but because of the paucity of time, I'm just going to say that the correct patient selection, correct treatment planning, if both are right, the risk of you going wrong is very minimal. You need to train well, you need to work hard, you need to go and read every day, find a new thing to read every day. You will be 365 things richer in a year. We do a lot of programs all across the country, multiple colleges. We are starting our own, CynoDent is starting with a fellowship also. If there's any question, these are my contact details. Please feel free to get in touch with me. I'll be more than happy to guide you or help you out in the best way possible. We don't have too much time on questions, but if you are, we can take it offline. Thank you for a patient listening, and thank you for understanding what we do. Thank you.
Thank you, sir, once again.
So, good afternoon, one and all. I'm Dr. B. Nitin Kumar. I'm basically from Hyderabad. I'm here to represent V Clear Aligners. So, this is an aligner company. You might be most probably coming through the recent trend, right? It is a trend in orthodontics basically. It is trend all over world as well as India nowadays. You might have most probably heard tooth C, right? So it directly delivers the aligners to the patient, which is unethical basically. So you need to broadly understand what aligners are basically in order to handle them, okay? So this is one of the thing that is recently happening or recent advances in orthodontics, okay? So the basic part is like most of the people over here are UGs, right? So the thing that you have to understand is there is something called in orthodontics known as braces, right? The majority of components or whatever the treatment that happens with the orthodontics is with the braces. Basically, it is a fixed appliance, right? So this is an alternate for that. It is not a replacement, okay? So aligners are something you might have most probably seen the plastic material or form of an Essex retainer that is most commonly used by the patients, right? So without any delay, I'll enter into the aligners, what basically aligners are. Yesterday we have conducted a course about the aligners as well as the attachment placement, okay? So this is a brief about that. I'll not go deep into the biomechanics part, okay? I'll just brief you about the aligners and how are they manufactured, basically, okay? So clear aligner therapy utilizes a series of custom-made aligners, okay? So these are custom-made aligners for an individual patient. They are separate for maxilla and mandible, okay? So you need to have separate number of aligners for maxilla and mandible. You cannot expect same number of aligners for both the arches, okay? So each aligner is incorporated with a certain amount of stretch or force, okay? So whenever you insert an aligner into patient's mouth, it tends to stretch back to its original position. Basically what you are doing is, you are inserting an aligner which has been stretched to a certain extent, and whenever you are inserting it into a patient's mouth, it is tending to stretch back to its original shape, okay? So this is where the tooth movement happens, okay? So there are two approaches basically. One is the shape molding effect and other one is the attachments, okay? Shape molding effect is basically the one concept where the aligner, the elasticity of aligner itself moves the teeth, okay? The other form of tooth movement that happens with the aligners is inserting an attachment onto the tooth surface, okay? So inserting an attachment on tooth surface is nothing but having a composite button incorporated on the labial aspect or else on the palatal aspect or lingual aspect or on the buccal aspect of the tooth, okay? So there are basically both two forms of attachment, that is the positive attachment as well as the negative attachment, okay? So positive attachment is the one which is given with the help of a composite, whereas the negative attachment is the one which is incorporated within the aligner itself, that is, it acts directly onto the aligner, it is incorporated within the aligner, so that these attachments help in enhancing the tooth movement, okay? So this is basically a newer concept. The aligner itself is a newer concept, so it is very difficult to understand unless you do a case or go through this, okay? So I'll just be briefing about you. If you have any doubt, personally you can contact us at a stall present outside this hall, okay? So it is a stall named after We Clear Aligners. You can approach there, okay? So what is the basic difference between a fixed appliance and an aligner, okay? Overall, the fixed appliance is way more superior when it is compared to the aligners, okay? There is nowhere matched in case of aligners when it is come to fixed appliance. You have tons of mechanics involved in fixed appliance, okay? Whereas in the aligners, the only part where they are superior is in term of aesthetics, okay? In only the aesthetic part, they are way more superior when it is compared to fixed appliance, okay? Because they are barely visible, they are convenient, there are no dietary restrictions. So all these are the only superiority when it is compared to the fixed appliance, okay? Whereas in fixed appliance, there are no restriction in treating the cases. Whereas in the aligners, you have several restrictions to do that, okay? The aligner treatable cases are only restricted to mild to moderate cases, okay? And the other form of difference between a fixed appliance and a clear aligners is the type of force that is being applied by the both different type of force, okay? So when it comes to fixed appliance, imagine there is an palatally placed or lingually placed lateral incisor, okay? So basically the concept happens with the fixed orthodontic appliances, you bond the back brackets on the labial aspect, right? So what happens is whichever the teeth is palatally or lingually positioned, whenever you engage an arch wire, initially the night-eye elastic wire, whichever you engage into the arch, into the bracket slot, it tends to pull out the teeth, right? So the type of movement that is happening or the type of force that is being applied by the fixed appliance is pull type of force, okay? Whereas you don't have any component attached in the aligner on the labial or buccal aspect, okay? So what it is doing is aligner basically applying the force from the palatal or lingual aspect, okay? So type of force that is being applied by the aligner is push type of force, okay? So the main difference when it comes to the fixed appliance and aligner is type of force. So these are few cases that can be easily treated with the aligners. that is generalized spacing or localized spacing such as diastema. Deep bite cases where you can intrude up to 2 to 3 mm of anterior intrusion, that is true intrusion, not the relative intrusion, okay? Relative intrusion with extrusion of posteriors is really difficult with the aligners. The only tooth movement that cannot be achieved with the aligners is extrusion, okay? It is very difficult, okay? Open bite cases where you have generalized spacing between the teeth so that you can relatively extrude the teeth, such kind of cases can be easily treated, okay? Crowding, which is minimal, which can be treated with incisor extraction or minimal space graining procedures such as interproximal reduction. Anything between mild to moderate crowding cases can be treated with the aligners, okay? The cases that are contraindicated or absolutely contraindicated are skeletal corrections, okay? Type B and type C cases, we have a concept in anchorage which is like ABC, okay? So depending upon the type of amount of mesial movement of molars or the posterior teeth and the anterior teeth, the anchorage is decided. So type A anchorage is where you have minimal posterior movement when it is compared to maximum anterior movement, okay? So type B and type C is where more than 50 or 50% of molar mesialization is required. Such kind of cases you need to avoid with the aligners, okay? Completely impacted teeth where you have complete impacted canines most commonly and the incisors secondary, okay? Such kind of cases where you cannot engage the aligner, it is better to avoid. Like I said, extrusion movement with only with the aligners is very difficult, and such kind of cases it is better to avoid. So what is the process that is being involved in the manufacture of aligners, okay? So first thing that happens in the aligner manufacturing is data acquisition, that is your impressions, okay? The most common trusted method in order to obtain the impression with the aligners in case of aligners is distal impressions, okay? So the intraoral scanning that has to be done in order to obtain the distal impression, that is free of cost all over India from our side, okay? So whatever the distal impression that is being recorded will be transferred to us in the production house, okay? So what we do is we 3D reconstruct the models, whatever the models that have been obtained from us, okay? Then the dental models are produced, onto that the aligners are manufactured. So what are the prior requisites that you need to consider before going for an intraoral scan, okay? If there are any scaling or oral prophylaxis that is required, you need to do them prior. Teeth fillings, fixing of crowns, impacted teeth, all these considerations are must before going for an intraoral scan, okay? Once the scanning is done and once the case is being approved by the concerned doctor, you cannot manipulate that at any stage. If any manipulation in between after approval of case, you have to go for a rescan again, and the number of aligners will definitely vary post that, okay? So the first thing that we do is intraoral scan because of its high accuracy and precision and also time saving, okay? So these are the raw STL files that will be obtained by us after the intraoral scanning is done, okay? So what we basically do is we upload them into a software, one of the software which can alter the tooth movement or one of the software which can do the tooth movement, okay? So these three software are most commonly used, okay? So we upload them in one of the softwares and we separate the hard tissue part from the soft tissue part so that only hard tissue can be moved, okay? You cannot alter the soft tissue portion in any aligner, okay? You're only manipulating the hard tissue part, okay? So after the separation of hard tissue from the soft tissue, this is the final model that you'll see, the right down model, okay? So this is where the separation happens. After that, whatever the desired movements are required, we give it in the software, okay? So whatever the direction the movement teeth has to be moved is done, and here the number of aligners will be calculated, okay? Like I said initially, there is certain amount of force being applied within the aligner, right? So there is certain amount of restriction for that. Actually in aligners we don't calculate the amount of force. It is the distance that is being calculated in the aligners. Distance in the sense how much amount of movement can happen with an individual aligner, okay? So that is restricted to 0.2 mm. Okay, based on this, the number of aligners will be calculated, okay? So based on the amount of tooth movement that has been done, the number of aligners will be calculated, and you cannot alter these number of aligners, okay? If you tend to alter these number of aligners, there might be excessive stretch of the aligner, which tends to break the aligner, or else when you seed them into the patient's mouth, there will be a little bit discomfort, okay? So once the models, the entire treatment plan is done, once the approval from the concerned doctor is done, we tend to produce the models, okay? So this is a type of rapid prototyping that is being done in the industry in order to produce the models, okay? So the most common technique will be stereolithography, okay? So what we do is, we have a large container where photosensitive polymer resin will be poured, onto which a laser light will be passed in order to cure the models. Okay, so final models that will be obtained by the company is being displayed. Okay, so every individual aligner will require individual model. If suppose you have 14 number of aligners for the upper and 14 for the lower, you have to produce 14 for the upper. The models will be produced 14 for the upper as well as the lower. Okay, onto that we individually press aligners. Okay, so each model will be thermoformed separately. Okay, so this is the final aligner that will be produced. Okay, so this is how the entire sequence of producing the aligners happens. Okay, so firstly we go with the intraoral scanning, then we go with the production of models or designing the treatment plan, and then we go with the production of models, then the aligner is formed. Okay, so this is basically about the aligners. Within the short given time, I have briefed you about the aligners and its manufacturing. Okay, and thank you from our side, and I thank CynoDent on giving the opportunity about explaining about our product as well as the aligners. Okay, thank you.
Thank you, sir, for the informative lecture. Now I would like to invite the next speaker for the day. She is Dr. Mariam Ali ma'am. A brief introduction about ma'am. She is the professor and HOD, Department of Prosthodontics and Crown and Bridge, CPDISH, Lucknow. Dr. Mariam Ali ma'am has done her graduation and post-graduation from GDC Nagpur in the year 1988 and 1991 respectively. She is currently working as professor and HOD Prosthodontics at Career Postgraduate Institute of Medical and Dental Sciences, Lucknow. She has conducted several pre-conference courses at national level and has a number of publications to her credit at both national and international level. It's a pleasure to have you amongst us, ma'am, and I would like to invite ma'am on stage. And the topic that ma'am is going to deliver the lecture is troubleshooting incomplete dentures. Please give a round of applause for ma'am. Also, the guest speakers have traveled a long way. So if there is anything you want to ask, or if there is any query related to the topic or the concerned department, then you are free to ask after the lecture has been done. I would like to request the delegates to please occupy the front row seats. Whosoever is here to attend the lectures, please come forward.
just see if it's working? Yes. Yeah. So, a very good morning to all the delegates who are here, especially the students. And I'm very grateful to the organizers of CynoDent International Dentist Convention for giving me this opportunity to talk today. Now, my topic is very different from what all the previous topics you've heard and from recent advancements and trends in dentistry moving towards. So you've heard a lot about implants, you've heard about a lot about lasers and guided bone regeneration, aligners and so on and so forth. But I think I was given to understand by the organizers that there were a lot of undergraduates and interns who would be attending this conference, and that is why I thought that we can never forget the basics. In a country like India, all patients, all completely edentulous patients will not be able to afford implant supported dentures. So this topic of mine is mostly towards giving an understanding of the different problems, post-insertion denture problems, and how can we troubleshoot these complaints. So I'm Dr. Mariam Ali, Professor and Head Career Dental College, and I'm pleased to be here with you. Now, complete denture, this is a patient who has been just delivered a set of complete dentures. Now, complete denture service can be a very rewarding as well as a very frustrating experience for all of us, I'm sure. And this is because the edentulous patient will have a lot of morphological, neuromuscular changes that take place, as well as medical and psychological problems that will compound the edentulous state of the patient, and that is why the patient comes to us with problems. So we have these are the contents of my presentation. Most of our patients, we have to understand, will be satisfied with their dentures, but there's still a small percentage of patients who will constantly come with problems, and we have to be basically patient to deal with these patients. So our patience is really tested at the time when these patients come to us with complaints. So what is the first approach we do? When the patient comes back to us at the recall and we see the patient, we in the waiting room, we generally make a face, and then what happens? We use when the patient is seated, we use the gunshot approach most of the time. What is the gunshot approach? When the patient says it's hurting me, you will take your handpiece and burr and you will start grinding it if it hurts. And if the patient says it's loose, what will you do? You will immediately say, I should reline the denture. So either you grind it or you reline it, thinking that you don't really understand why is it hurting or if it's loose. So try to understand what are the reasons for this. There are so many reasons that it could be there. So if we follow the principles of troubleshooting, we can avoid actually spoiling whatever we have done, whatever impression we're making. By grinding, we are actually loosening the denture even further. So we should always follow these principles. That means have the patient point to the problem, demonstrate the problem, ask them, see them on the chair, where is it hurting you, before you start taking the denture and grinding. Then you take a detailed history regarding the complaint. If he says it's hurting you, it's loose, take a history. Why, when, how does it start? In the morning, does it start later in the day, and does it progress more during the day? So you would be able to form a differential diagnosis. Then you yourself clinically examine the patient. Whatever complaint he is given, you yourself examine the patient, examine his ridges, examine the soft tissues, everything to see if there are ulcerations, erythema, redness. Then you establish a differential diagnosis. After examination, just you say it could be due to this, and plan your treatment accordingly. That this is first what I'm going to do. I think it's this problem, I'm going to treat it, and then I'm going to go on to the next and check it, and then the next. After that, always use pressure indicating paste when you are correcting anything. Don't touch your impression surface, don't touch your borders arbitrarily. Always use pressure indicating paste, anything. If you don't have a pressure indicating paste, you can very well use a light body silicone material, impression material, or you can use your zinc oxide with a plain brush, zinc oxide from your final impression material. Use a pressure indicating paste, find out where that is actually overextended or it's hurting, and have the patient rate the improvement after you have adjusted it. Ask them, is it okay? If it's not okay, again you can again redo it and again ask them whether it's improved or not. So We'll go to the factors which cause the post-insertion problems. Basically, McCord and Grant in 2000 listed 4 factors. Adverse intraoral anatomical factors. That is, these problems are there in the patient's mouth, which you have to understand. Clinical factors, during the making of the denture, any clinical faults that we have made. Technical factors, factors which happen, go in the lab, any problem during our laboratory steps, and patient adaptive factors. Whatever you have done, if you have made a very good denture for the patient, if your patient is having some adaptive problem, he is not going to adjust to the denture. So the anatomical factors which most commonly affect are atrophic or resorbed mandibular ridges. Most of us will see many patients come especially with the mandibular ridge which is resorbed, and we have so many problems with the resorbed mandibular ridge. So if it's a poor ridge case, we know for sure we are going to have more problems with this patient. Prominent myloid ridges, obviously when the ridge is resorbed, your myloid ridge becomes prominent. So at your diagnosis and treatment planning stage, palpate the myloid ridge and you see that it is prominent, then you know that you have to take care of it. I'll tell you later how to take care of it. Flabby ridges, severe undercuts buckle to the maxillary tuberosity, labial undercuts and undercuts in the tuberosity region. These also are going to cause problems. And knife-edged ridges. So all these anatomical factors, when you examine, you will find that these, you tell the patient in advance, see your ridge is resorbed, you have a knife-edged ridge, you have a flabby ridge, you're going to have some problems. So right from before the patient knows that he will have to come back for maybe a few more recalls than a patient having good ridges. So the next factor is clinical factors. Primary impression, final impression. You have not been careful about taking your final impression. Your jaw relation, you have made some mistake. You've inadequate diagnosis, treatment planning. You have not examined the patient. You have not seen that the patient has adverse anatomical factors. All these problems, or even a trial. Basically, a trial is your verification of your jaw relation. If you disregard at the trial that your jaw relation, your centric may be wrong, your vertical dimension is wrong, and you just go ahead and process the denture, you are bound to have problems later on. Then coming to the technical factors, so many problems will be there. Your master cast may be damaged. Your special trays may be faulty. They may be distorted. Your occlusal rims are not improperly made. And also the different problems in the processing of the dentures. All of you know there are a lot of problems like polymerization, shrinkage, and so on and so forth. So any laboratory problem, any clinical problem is bound to cause you to have your patient coming back to you. Patient adaptive factors, many patients, in spite of taking care at all steps, still they will complain of eating difficulties. They are not able to eat with the denture. Psychological problems, they say they don't look good, anesthetic, gag, they complain of gagging. So all these repeatedly, when you are not able to establish any cause or any factor, you know that this patient is having adaptive problems. So these patients need some psychological counseling to get them to understand the limitations of the denture and to adapt to them. Now coming to the post-insertion denture problems, most commonly patients come with 2 problems. The other problems are there, they come with looseness. I'm sure all of you would agree. Most of you would have made dentures in your undergraduate days and internship days. So looseness, the patient will say my denture is loose. Or the second, he'll complain of pain or discomfort associated with one of the surfaces of the denture. So these are the most common problems, looseness, discomfort or pain. And also you'll have some support problems, problems with retention, stability, as well as other difficulties. So when it comes to looseness of dentures, basically the looseness is due to 2 factors. One is the decreased retention forces and increased displacement forces. So when your displacement forces and retention forces are less, or the displacement forces increase, your denture is going to be loose. So what are the symptoms of a loose denture? Obviously, patient will say, I'm having problem when I'm speaking, my denture is coming out, and food is getting lodged below the denture, and also he may say, I have pain also because the denture is displaced. Loose dentures are, again, causes decreased retentive forces, increased displacing forces, and support problems. So what are these decreased retentive forces? Basically, lack of seal. All of you know peripheral seal, The seal which we establish by border molding inclusive of the posterior palatal seal. If you have not done a proper border molding, your borders are underextended, you are going to have a loose denture. Incorrect posterior palatal seal. So many mistakes can be made in recording the posterior palatal seal which completes the seal, as well as inelasticity of cheeks. Patients with submucous fibrosis, they will be having they will be having stiff mucosa. You will not be able to do the border molding properly. So in such case, you will not be able to establish a seal. The second is if there is air beneath the impression surface of the denture. Air means there is a poor adaptation of the denture. So denture will have poor fit. In cases where ridges have undercut areas, we will be blocking out the undercuts, or we have given excessive relief. Most of the time we excessively relieve the undercut area. So in such cases again there is a gap between the denture and the tissue. So this also will cause decreased retentive force. Also patients with xerostomia, patients having lack of salivary secretion, diabetic patients, very common diabetes, drugs, menopause, irradiation, all cause lack of salivary secretion. So saliva, as you know, is very important for the physical factor of retention, adhesion, cohesion, surface tension. So your patient is going to have a denture which is loose. Also poor neuromuscular control. An incorrect denture contour, you have thick polished surface of the denture, overextended. So all these, if in a patient with a motor neuron disorder or with an incorrect denture contour, he will never be able to get the neuromuscular control necessary to use his denture. So again on the opposite side, we have increased displacement forces. That means, so our denture can be loose because of underextended border, it can be loose because of overextended borders. When we have overextended denture borders, we are going to, again the denture will be loose. There will be a poor fit. When we do not make our dentures in the optimal position, like the neutral zone, all of you must be knowing what is the neutral zone, denture is not in the optimal position, our patient again is going to have a displaced, the tongue and the cheek and the lips will push the denture out. Occlusal problems also will cause increased displacement forces. Prematurities in contact, our maximum intercuspal position and a centric relation position is not coinciding. We have not given a balanced occlusion and we have given an incorrect plane of occlusion. So all these will cause increased displacement forces and our denture is going to be loose. So when we try to balance our increased displacement force and decreased retentive forces, try to balance it. So your denture, your patient, your denture is the patient will be able to use it with better stability and retention. Now when this is an underextended border, denture looseness due to underextension, okay, you see that lack of peripheral seal, border underextension in depth and width, or air beneath the impression surface. Due to a deficient impression, a master cast is damaged, a warped denture, we have over adjusted the impression surface, residual ridge resorption, undercut ridges and excessive relief. All these cause the denture to not be accurately fitting in the patient's mouth, and we will be having, this is all denture looseness. We have to be able to understand it's due to underextension. The next, short flange underextension, it looks like this. See the arrows are showing. When you put your pressure indicating paste, it is short of the vestibule. It is not, I mean, it's not touching the vestibule. And as soon as the lips and the cheeks move by speech, it is displaced and air breaks the peripheral seal. So the way you treat this is when you make out that your borders are not contacting the periphery and your pressure indicating paste which you placed at the border is just not being touched even by the lip movement. You have to again border mold, or you can add, I mean, I won't suggest you add cold cure, but you have to again border mold and at least the periphery of the denture. This patient needs a reline basically, especially at the borders. Now denture looseness due to border overextension. See, as I told you, even an underextended denture and an overextended denture. So what happens? You see there at the depth of the vestibule, there is ulceration in the sulcal region. So if your denture border is overextended, especially in the frenal area, you will have an ulceration. If buccal to the tuberosity, denture displacement of mouth opening or cheek soreness occurs, and thick buccal, labial and upper and lower labial flanges produce displacement. So if your denture borders are thick, if they are overextended, if the freni are not relieved, and if the buccal borders are also thick, there will be displacement on mouth opening or cheek soreness. So all these are due to overextended thick borders. The denture will be loose. Now this is how it looks, an overextended flange. When you apply your pressure indicating paste, there will be a burn through at the border. The denture will be retentive during eating and speaking, but as soon as there is muscular activity and the air seal is broken by the movement of the lip, it will tend to be displaced. So this is very important. You have to try to understand by doing the movement whether the border is, when it is overextended, then you will get a PRP burn through like this, and you know that your border is overextended. So you will adjust that and grind it and polish it. Now again, a deep post dam on the upper base can cause pain and ulceration and needs careful adjustment with pressure indicating paste. So when you have placed excessive thickness of green stick compound, modeling compound at the on the PPS area, this will cause this redness and inflammation. Also, in case of an underdamming, when there is no PPS, so our diagnosis is by placing border molding material, we place it at the posterior border, place it in and ask the patient to, when you get that seal, the posterior retention when you get, then you will be able to understand that you are the denture is underdammed, okay. So either a deep post dam or a lack of post dam will cause a looseness in the denture, which has to be corrected accordingly. Now a perpetually loose maxillary denture. A denture which is loose, the reason is that there are heavy anterior interferences which can cause loosening posteriorly. So what happens when there is resorption of the ridges, there is a heavy, your overjet to novabite is less, constantly the anterior teeth will touch and will cause movement of the denture. This causes the tuberosity to grow into the space, and a midline, there will be a space developing below under the midline of the denture. So this is how in cross section a denture will look if there is constant anterior interferences. This is because of an inadequate overjet and overbite due to resorption of the dentures or improper arrangement of the teeth. Now tilting or jiggling of the denture can be caused when occlusal contacts are not centered on the ridge, and we place our mandibular molars on the inclined portion of the ridge, we also will tend to have a loose denture. If the lower incisors are placed too far labially, the denture gets displaced lingually as the inclined ridge provides no resistance to the orbicularis muscle. So if we have a lower anterior placed far labially, orbicularis muscle, our lip, whenever it functions, it will push the denture. If the patient has a poorish, the denture which will be pushed backwards. Also, as I told you, occlusal problems. Check centric occlusion coincides with centriculation using articulating paper. The denture who is loose, occlusion can also be the problem. We tend to neglect occlusion. We think it could be due to so many other factors, but occlusion can be the problem. Your denture, you may not have corrected the occlusion. So check centric occlusion coincides with centriculation using articulating paper and reduce the prematurities, giving even stable contacts on both sides. This will reduce the looseness of the denture. Also, if the denture periphery terminates over bony structures of the hard palate, if it's short, if it terminates in the zygoma or the external oblique ridge, or it ends below the retromolar pad, we do not get any seal. So if this causes discomfort to the patient, eventual resorption, and again this will have the symptom of a loose denture. So as a rule, denture periphery should always terminate on peripheral soft tissues, and these are the retromolar pad, the vestibular tissues or the tissues of the vestibule, vibrating line, and the hamular notches. So always your denture borders should end on the soft tissue and not on the hard tissues. Your pterygomandibular raphe, which begins from the hamulus of the medial pterygoid plate, and it ends on the mandible, on the distal-lingual portion of the mandible. So it is very tight in some patients. This also, if we have a pterygomandibular raphe which is very prominent in these patients, the maxillary denture can be dislodged. So again, use pressure indicating paste. In case you notice the terimanic patient, he complains, denture is dislodging when the mouth is opened wide. Most common cause is the pterygomandibular raphe. Again, you place pressure indicating paste and you get that marking of the raphe and relieve it accordingly. Now, that was all about looseness. Coming to the second most common problem, that is discomfort or pain associated with the different surfaces of the denture. Basically, all of you know that our denture is categorized into impression surface, occlusal surface and polished surface. And we may have discomfort also associated with a lot of systemic conditions. So first we'll take the problems related to the polished surface of the denture, the palate, and all these surfaces, the buccal, the labial surface, lingual surfaces, these are all the polished surfaces of the denture. So problems related to that, looseness. Now patient complains that when he is moving his mandible side to side, denture is dislodging. So the coronoid interference, the coronoid process can come close to the distobuccal border of the maxillary denture, and this is when you give a very thick, wax up a thick buccal flange of your denture. So the denture, maxillary denture will get dislodged. Again, use pressure indicating paste to reduce it. Don't do arbitrary displacement. If you see a thick border and the patient complains of dislodgement, you go ahead and adjust that. Now, in the mandibular denture, a thick lingual flange will impinge on the bulge into the tongue space, and the patient will have the complaint whenever he's speaking, whenever he's swallowing or talking or eating, the tongue is lifting the denture, the loose denture. So this is because of an excessively thick surface of the denture. Now, these problems generally they start in the morning, and the patient has discomfort when he is not chewing and often not progressive during the day. So any problem which is there related to the impression surface, this will not be progressive throughout the day. See, whenever the patient says it increases, most probably it is due to the occlusion. So in this case, when the patient says that it's hurting him at the start of wearing the denture, so our problem is related to the impression surface of the denture. So most commonly, discrete pearls or sharp ridges of acrylic on the fitting surface from an inadequate laboratory finishing, which can be located by passing your finger. Always use an ungloved finger on the impression surface of your denture before you deliver it to the patient, so that no acrylic ridges or nodules are there from laboratory finishing. So your patient will not come with this complaint, but if you have not bothered, he will come with these discrete painful areas. So always use disclosing materials to ease that. Now, painful pressure area, pain on insertion and removal. Most commonly, as I told you, in the buccal tuberosity area, lateral to the tuberosity, undercuts may be present on one side, unilateral or bilateral, or labial undercuts will be there. So you may have relieved it, but you have inadequately may have relieved it. So patient will have problem in placing and removal, he will complain of pain. So obviously, you will realize that you have not inadequately relieved the undercuts. Also, there could be painful pressure areas resulting from any faulty impressions, damage to a working cast or master cast, warpage of the denture base, any retained root, lack of relief for a freni, non-displaceable mucosa over bony prominences like torus. The thin mucosa is very thin, so the patient will complain of pain. So all these problems related to the impression surface, painful pressure areas, you have to examine and you have to use pressure indicating paste and relieve accordingly. Now this is pressure indicating paste. You have to use this paste. You see here, the flange is overextended. You mark it, use pressure indicating paste, you get that burn through, and then you relieve accordingly, mark it and relieve it. This is the correct way of applying pressure indicating paste. With a stiff brush, you have to apply it. As I told you, if it's not available with you, you can very well use the zinc oxide paste of your zinc oxide eugenol impression material, or you could even use a light body silicone material in a thin layer to find out where it is actually impinging. So you relieve the areas, pressure spots with an acrylic burr, repeat this until the denture fully seats. Prominent mylohyoid ridges seen in poor ridge cases, again another cause of problem. So, in such a case, during a diagnosis and treatment planning, when we see the patient has prominent mylohyoid ridge, we palpate it, we will make a special tray with a double spacer. In case we have not corrected it, we have not taken an impression with a double spacer, and we find that the patient, during the packing stage, you give a lead foil relief over the mylohyoid ridge. This is commonly not done by students, and most of the time patient complains of pain with the prominent mylohyoid ridge after the denture delivery. So, it is more difficult to relieve it after that, because after that the denture, your flange may become very thin. So, it is always better that if you have not taken care in the final impression, you always during your laboratory packing, you have to give a double relief to the mylohyoid ridge. Retromylohyoid overextension, another very common problem with students. You have to know what should be the extension of your denture, posterior extension. From the retromolar pad straight down, depending on your your throat form, patient with an overextended flange will complain of a sore throat, the difficulty in swallowing, and the denture moves during swallowing. So, you know that your lingual flange, very commonly this is the shape of the lingual flange, and when it is overextended, you don't know till where to relieve it, the patient will complain of the denture coming out and also pain during swallowing or sore throat. Soft tissue undercuts. If there is severe undercut, the flange cannot be placed to the depth of the vestibule, otherwise the denture will not seat and ulceration will occur. So, when you know there are undercuts, and when you during the time of your denture delivery also subsequently relieve the undercut with pressure indicating paste, you have to first block out, and then if still the patient has problem in placing and removal, with pressure indicating paste you adjust it so that it will be placed to the depth of the vestibule. Again, check for hamellar notch impingement, same thing, just like the pterygomandibular raphe, hamellar notch at the distal end of the maxillary denture is a bony landmark. And if your maxillary denture is overextended and impinges on the hamellar notch, in that case the patient also will complain of pain in that region. So, again you can use pressure indicating paste and you can adjust clear the hamellar notch. The labial frenum should be thin and deep. It should not be broad and it should be with rounded internal and external angles. This is the relief for the labial frenum. Buccal frenum relief can be slightly wider, but in any case the internal external angle should be rounded. We have to use sandpaper after adjustment. Sometimes patient complains of generalized pain over the denture supporting area, and this could be due to underextended denture brace and inadequate freeway space. Remember, a high vertical dimension, patient will complain of generalized pain over the denture supporting area. So, you could have to suspect your differential diagnosis will be either the entire denture border is underextended, that is why it is it is just sinking towards the tissues, it is not getting support from the peripheral tissues, or our freeway space is less. Now we have seen about the problems related to the occlusal the polished surface and the impression surface. Coming to the occlusal surface, this is the most important, and generally we tend to neglect it. We are more happy take to adjust our impression surface or polished surfaces, but this is very important and it is the most overlooked problem. Very often it is not possible to do the correction of occlusal problems in the mouth. So, it is always better to do a step called as laboratory remounting, which most of our students, they neglect this step. Laboratory, put your dentures back on your articulator, get the prematurities, adjust the contact, because in the mouth with saliva and it's not easy to see the markings, it's not easy to adjust. So, it's always better to use the articulator to correct occlusal problems. Now, when the patient has occlusal problems, the symptoms of discomfort occur during function. That means, what happens? The denture patient will tend to bring his mandible in front and contact with his anterior teeth, and this will cause soreness in the anterior hard palate and the anterior ridge areas. Pain labial or lingual to the lower anterior ridge. Always the problem is with the slopes of the ridge. When the discomfort area is on the slopes of the ridge, that time the patient you can suspect occlusion may be the problem. He will complain of delayed gagging, soreness, his muscles of mastication become fatigued, excessive salivation, discomfort during chewing. All these are symptoms of occlusal problems. Now, take the history of the patient, very important. When you place the denture and you press in the first molar area, there is no pain. That means the denture base is not at fault. This is the main thing. And only he will give the history. Pain is during chewing, gets worse with chewing and gets worse throughout the day. Whenever he is giving this history, it means that occlusion is the problem, and he may feel the need to remove the denture later in the day. And in this case, sore spots are visible on the slopes of the ridge. So I told you two things. The sore spots will be on the slopes of the ridge, will not be on the crest of the ridge, and the patient will give the history that initially when he placed the denture, no problem. During the day, the problem starts, and then in the end, after a couple of hours, he feels the need to remove his denture. So these are all indicators that occlusion is the problem. So on a clinical examination, ask him to show where, by biting, where the pain occurs. You will see most probably occlusal contacts are not centered on the ridge, and there will be tilting forces because the contacts are not on the ridge, tilting forces causing displacement and ulceration on the slopes of the ridge. And if the patient has xerostomia or is malnourished or has poor adaptability, these problems are compounded. So this is the examination which you will see. So how do you correct that? You correct it by doing a selective grinding if it's a slight error, but if the error is more severe, then you do a patient remount by taking a centricillation bite with the dentures and correct the occlusion through equilibration on the articulator. You may take a face bow also, but not necessary. So our clinical remount procedure means we will remount our dentures with taking a centricillation record. You can use alu wax or any interclusal material and make remount cast and mount it on the articulator and remove the premature contacts on the articulator. Also, try to prevent occlusal problems. Place your teeth on the center of the ridge, try to place them on the center of the ridge. There should be no contact over the inclines of the denture. Make sure that your dentures are not touching posteriorly, and place your teeth on the center of the ridge. Avoid setting the teeth in the tongue space. If you tend to place your teeth too much toward the tongue space, your tongue is crowded. So this again, when the tongue will function, it will push the denture out of place. Then most of you are familiar, I will not repeat, excessive video. This is how the patient looks. Too many teeth in the mouth, less freeway space, he has muscle problems, joint problems, clicking sounds, his aesthetics are not good, difficulty in swallowing. So all these excessive video, if you have given an excessive video and you missed it out at the trial stage, then and you have delivered the denture to the patient will come to you with a generalized soreness after a few days. And he will say, I am not able to speak and I am having a constant pain when I am placing my denture. So when you examine and you check his VDR and video, there should be at least 3 millimeter freeway space. All of you must be knowing video VDR. So 3 millimeter freeway space should be there. So if you can correct, if the vertical is raised by 1.5 millimeter, you can make a correction in the mouth. But beyond 1.5 millimeter, you cannot correct a increased video. So you have to remake the dentures for the patient. Obviously, if you grind off 1.5 millimeters of your artificial teeth, there's going to be nothing left for the patient to eat with. So you have to remake dentures if your error is more than 1.5 millimeter. Similarly, in a decreased video, all of you are also familiar with this, overclosure. The patient's nose and lip, you can realize that something is wrong, your video is less. So again, examine VDR, video, and what you can do here to correct, do a reline for the patient. So again, remember this, 1.5 millimeter you can correct by relining, but if it is more, then you will not be able to correct that. Now I'll just rush through here. Yeah, no, thank you. Now we'll run through only the problems related to the systemic diseases. So patient can have lot of these systemic diseases, and if you have not taken the history related to comfort or retention of the denture, diabetic patient, he is going to may have xerostomia, okay, and of course patients with ectodermal dysplasia, Sjogren's syndrome, neoplasm, vesicobular disease and Paget's disease. All these patients' systemic problems are going to have problems with comfort and retention, And those related to coordination, like patients with stroke, Bell's palsy, Parkinson's, or muscle or neurological disorders, we can also expect them to have multiple complaints. So this is a patient with herpetic form ulcers, viral disease. We have to distinguish that from caused by the denture if it's intraorally, a beefy red tongue due to vitamin B12 folate deficiency with xerostomia. These patients also, patient will not be able to wear his denture comfortably if he is having any type of systemic disease. These are the oral manifestations of diabetes mellitus. A patient with diabetes and who's not controlling his blood sugar will never be able to adapt to his new dentures. Drug-induced xerostomia, in case there is less salivary secretion, patient take his history. If he's on drugs, any of these drugs which are mentioned here, they can cause xerostomia, so the patient will not be able to use his dentures. So you can advise artificial saliva, frequent sipping of water, sugar-free lozenges or salivary reservoirs to prevent this problem. Burning mouth syndrome, this is a condition where there is the generally postmenopausal females. Patients with burning mouth syndrome will come to you and tell they're not able to wear the dentures. So you have to just diagnose this condition if you cannot find any cause of the denture, and then you have to refer them for medical treatment, correct any denture factors if possible, advise multivitamin. Allergy is very, very rare to polymethyl methacrylate. In case the patient has an allergy, you can very well use another material like polycarbonate bases or non-nickel containing framework alloys or repaste the dentures, but this allergy to PMMA is quite rare. Patients with denture stomatitis again will have complaints about wearing the dentures. This is generally due to Candida albicans infection. The patient will complain of generalized pain over the denture bearing area, bright red plaques will be seen. So your patient who has denture stomatitis, if he has complaints, you have to follow this protocol of treatment. That means you have to clean the denture, and you have to advise also ultrasonic cleaning, soaking in 2% sodium hypochlorite, oral fluconazole and topical nystatin ointment will take care of this problem. Now patients also may have a lot of support problems associated with retention and stability from these conditions. That means fibrous or flabby ridges, poor ridges or tori. These problems will create, if your patient has these problems, he is going to have some complaint or the other. So in that case, like patient having a poor ridge case, you have to change give him, do a specialized impression technique for a patient with a flabby ridge. Okay, you have to give him an increased vertical, use 0-degree teeth, give him lingualized occlusion. So treat it in that way so that he has minimum problems. Patients with flabby ridges, again, use another technique where you don't put pressure on that flabby tissue. Also patients with tori, accordingly you have to surgically correct or manage. Other difficulties like noise during speaking, eating, speech problems, eating difficulties, altered taste sensation, gagging, there are innumerable other complaints, but these are the minor complaints. The major complaints of the patient, as I told you, will be looseness and pain or discomfort and problems related to occlusion. So these problems, as they are, since it's not, we have a limit for time, so I'll not be able to go into detail how to manage a patient who's complaining about gagging or speech problems and all. Accordingly, you have to treat the patient. So to conclude, it is evident that most problems arising with complete dentures are due to a combination of one or more causes, and the patient should be dealt with empathically or with patience. And there are many ways in which dentures can be improved, and dentists should be able to assess the quality of a denture in terms of aesthetics, retention, stability, support, occlusion, video and extension. Hence, a protocol encompassing time-bound redressal of the post-insertion problems can have a positive outcome on the rehabilitative effort by the prosthodontist. So, thank you for a patient listening, and if any student would like to put forward any questions, I hope that by this presentation you would be able to try to understand a little more about the common complaints of the patient, try to understand, try to do the proper diagnosis and treatment planning before you just start, grinding away to the denture and further destroying it. Thank you.
Thank you, ma'am, for the informative lecture on troubleshooting incomplete dentures.
drive.
Ma'am, I'm giving.
Yeah. Yeah, thank you so much. हेलो सर, कैसे हैं? ठीक है. एक्चुअली मुझे ये पता है चला कि यूजी और
I would take this opportunity to invite the next speaker of the day, and that is Dr. Raghu Dhanapal sir. About sir, sir has completed his master's degree from Ragas Dental College, Chennai. During his master's, he developed an interest in molecular techniques due to his exposure to genomic studies in pre-cancer and cancer in Indian Institute of Science. He has delivered guest lectures in various workshops in national and international forums, and he has conducted workshops on lymphocyte culture, immunohistochemistry and polymerase chain reaction technique. He has been actively involved in academics for more than 15 years. He was also a professor and head at Rajas Dental College and Hospital, and as well as postgraduate guide to various postgraduate students. In the years of his academic experience, he signed out biopsy reports correlating the clinical molecular characteristics with the histopathologic features. He is also a recognized PhD guide in oral pathology and microbiology of the Tamil Nadu government, Dr. MGR Medical University. He is currently working in AIMST University, Faculty of Dentistry, Malaysia, as the teaching standards are based on the UK and Australian boards. Today sir is going to deliver a lecture on case-based learning in oral pathology. I would like to welcome sir on stage and request him to acquaint us with the knowledge. Welcome sir. Please give a round of applause for sir.
Am I audible now? Yeah. Okay. So I'm Dr. Raghu, a faculty in oral pathology in AIMS University. My area of emphasis will be on case-based learning. That is, since it's predominantly a crowd of undergraduates, and I was told that probably a little bit of faculty will also be there, I presume that I would start with the aspect of case-based learning. So now the question is, what is case-based learning and how is it different from any case presentation that we normally see? Here in case-based learning, you normally tend to learn about the basics, or you learn the clinical description about the case in a few days ahead of the case discussion, and then finally you go on to the case discussion in case-based learning, which is about a 2-day session. So what I'll do is, since there are undergraduates in this crowd, I will make my presentation into 3 main aspects. So I will be concentrating on what is case-based learning, and then I will go about to explain certain cases wherein you can understand the importance of pathology. And then the last part, I will also emphasize on the various teaching modalities that we normally follow in Malaysia. So there are various new innovative teaching methods that you can also learn from this particular lecture. So to start with, as I said, case-based learning is basically a guided learning procedure where the faculty guides the students, and it tends to be in different phases. There is a pre-session phase wherein you have the initial learning process of the entire basics and also the content related to the case. Then followed by that, over the next, that is over the weekend probably, that's on a Friday, you will have a case scenario and you will have small groups of students. So it is basically a student-centric learning or a small group-based discussion. And you will have one faculty member who will help you out with the learning of the case. And finally, after this, you will go back home, and then what you're going to do is you're going to have a home-based learning, and then finally you will have a presentation. So this is how it basically is normally dealt in any case-based learning. So but there are different methods to it. As you can see, it could be just from a preclinical aspect, or it could be as at a clinical level. So we can start with the basics, then go on to the clinical application, or we could probably start with the clinical aspects, that is, in the group, each individual will describe each aspect of the case, that is history by one person, and then followed by the clinical features by another student, and then the description of the pathology by another individual. Thank you. Okay, so as I said, the concepts are what knowledge you have learned, you're going to apply it in your clinical case-based learning. So any basic knowledge will be initially instilled into the student's mind, and after that, that can be either by seminars or probably even your role plays or any method by which we normally train the students, and then finally they have the case discussion. So this is how it is commonly done, and as I said, there are three phases to it. So it is basically a student-centric learning wherein you are in student groups, and there is also a faculty member or a staff member who will assist you in this learning process. So what I'll do is, I will just tell you on what aspects you can normally do it, that is the data-based learning, that is the history, or the clinical image will be put up and the student will describe on how the case presentation is. Finally, the results with regards to the histopathology. So for the benefit of the students in this particular crowd, what I've done is I've picked up few cases, and what I've done is I've emphasized on the importance of the pathological aspect. So when you look at this particular case, this was a 40-year-old female, and she had a non-healing ulcer. And what is very characteristic about this patient was she was not a diabetic, or nor did she have any habit history. And this patient was provisionally diagnosed as a granulomatous ulcer based on the presentation clinically. I have not gone into those details. And what was important was, after taking a biopsy, what is very characteristic is when you see this particular image, you know that this is the normal histology where you have the epithelium separated from the connective tissue, right? But here you can see that there seems to be an invasion of the epithelium into the connective tissue. So though it looked like a simple case, but it was actually a case of a squamous cell carcinoma. So when we, as pathologists, when we normally look at any case, we normally look at a lower magnification for a particular pattern. Then we hypothesize on what the cell type is, whether it's epithelioid, whether there are clear cells in that area. And when it is clear cells, we will have to categorize it again. That is based on an algorithm, that is whether it's non-neoplastic or neoplastic. So non-neoplastic can be just an artifact, probably just a degeneration that we see, or it could be a mucous cell or mucoepidermoid carcinoma for all the fact. So all these parameters have to be taken into consideration. And as I said, it was finally diagnosed as a moderately differentiated squamous cell carcinoma, and this lesion was also refractory. So when you say refractory, it doesn't respond to any treatment. So in such cases, we always have to think about an underlying cause. So here, the most important parameter was, it is a case of a squamous cell carcinoma. So any systemic factor or any malignancy can be refractory to any treatment. So this is one take-home message, and another few examples of how do you follow up on taking up a biopsy. So this was a pretty wide lesion that we had. Okay, so you can see this. I'm sorry. Okay, I'm not sure if the pointer is visible. So the lesions tend to extend from almost the commissure to the posterior aspect of the buccal mucosa. So in such scenarios, you have to pick up the right site. Here in the anterior biopsy, it was just a dysplasia, that is just a premalignancy. Whereas on the posterior aspect, it turned out to be a squamous cell carcinoma. So the biopsy location is very important. And how do we basically come to a conclusion on where you're going to pick up the biopsy? You can use these diagnostic adjuncts. You can use toluidine blue. Okay, so all of you know that toluidine blue has a very characteristic function, that it is a vital stain. It normally binds to areas where you have excessive amount of DNA. So in cancer, there is excessive amount of DNA, and toluidine blue normally tends to bind to that particular site. So that can be highlighted with the toluidine blue, and you can pick up that area for your biopsy. And one more thing, once you've done the biopsy, how do you transport it to the pathologist? Normally when you do a biopsy, the tissue is very soft and friable. Okay? But once you fix it, it becomes very hard. Right? So when you take a biopsy, never put it in a narrow neck container like your LA bottle. So what will happen is, it will be soft initially, it will just pass through the opening of the bottle. But once it hardens, then it becomes very difficult for you to pick up the biopsy specimen from the bottle. You will have to break the bottle. So ideally use a bottle which has a wide opening. So this is one more thing that you have to remember as a clinician when you send your biopsy tissues. And also formalin, how much do you use? It is all said by the American Society for Pathologists that it should be 10 times the volume. So the biopsy specimen should be immersed in 10 times the volume of the formalin. Okay? And the next thing that you can also do is, you can ink or you can give different color notations to different sides of your biopsy, so that the pathologist knows where to section and look for invasion. Okay, so coming to the next case. So you've done a biopsy. I've told you how you transport the biopsy, but you have to be cautious. There are instances when the clinician normally tends to divide the biopsy bit and send it to 2 different laboratories. So that is something you should never do, because in this particular case, what we had was a patient with a swelling extending from the posterior area to the anterior aspect, and there was also an impacted tooth. So we had initially thought of an AOT, since you can see that the radiolucency extends over to the root surface. If it was only the CEJ, probably what you would think of, a dentigerous cyst, right? So any cystic lesion restricted to the DEJ, you would think of a dentigerous cyst. But here, since it extends onto the root surface, we thought of a AOT. But when we looked at the biopsy initial specimen that we got, since the clinician had divided it into 2 bits, the initial incisional biopsy showed us just flakes of keratin. Okay? So these flakes of keratin were actually very confusing, whether it was just a superficial biopsy or whether it was just the keratin from the surface. But when we told the clinician about it, they did explore the entire area, give us a bigger chunk of tissue. And what was very evident was the characteristics of an OKC. So this is something that you always have to keep in mind. If you're taking a biopsy chunk, make sure you send it to only one lab. Okay? So I've told you the importance, where to pick up the biopsy, right? Based on using of toluidine blue or any other adjuncts. Then how to transport the biopsy specimen in a wide bodied, open container with almost 10 times the amount of formalin. And when you get the biopsy specimen, make sure you send it to only one lab. Okay? So that is also another take-home message that you have to keep in your mind. Okay? So now that you've known that how you basically have to do this, there are certain instances where you might have white lesions which are very characteristic, you think of a diagnosis, okay? But sometimes you can have certain superadded infections on them, okay? So this particular case where I want to show you was a refractory case of a lichen planus where the patient had multiple recurrences. There was a phase of symptoms and then there was a phase of asymptoms. So when they took a biopsy of this particular case, it was a typical of lichen planus. What you have, the subepithelial band of inflammatory infiltrate, and also the reti-rich pattern and the basal cell degeneration. But in addition to this, what is very characteristic is, in cases of lichen planus, you can have superadded candidal infection. So these candidal infection can actually turn the symptomatic appearance. It can be completely asymptomatic, but once you have candidal infection, the patient can have a symptomatic phase of lichen planus. So this is based on as you can see here, you can see the hyphae which are pointed by the yellow arrows, okay? And as I said, based on a meta-analysis by Alberto, he states that it is candidiasis which causes the symptoms to increase. And when you subside the candidiasis, probably by using a statin treatment, your symptoms of lichen planus can also subside. So this is another take-home message. So in certain scenarios, you can use special stains. The pathologist can use them to identify the fungal infection. Okay? And the last case that I would discuss is basically based on a patient with a bony swelling, and histopathologically it had features of proliferative cells with vascularity in the stroma, and we actually thought of probably ameloblastic fibroma. But later on, what was very characteristic was it was having features of both your Brown's tumor. All of you know what Brown's tumor is, right? Caused by hyperparathyroidism. So here in this particular condition, in addition to that, we also had these giant cells. And in such cases, you have to make sure that you always look for the parathermone levels, your calcium levels, and then sign out these reports. So based on that, because it was negative for elevated calcium levels and parathermone levels, we finally signed it out as a central giant cell granuloma. Okay? So in addition to your regular biopsy that you send to the pathologist, you can ask for special stains to see for candidal infection, and also you can probably do adjuvant biochemical tests. Okay? So this part, I will just keep it very brief. So as I said, the teaching methodology has been evolved, and what we normally do is we have different methodologies of teaching. One basic thing that you have to remember is, in CBL, always give them the student the knowledge first, followed by making the class more entertaining. So what we do is we have quizzes, we have role plays, and we also have certain discussions among the students. And then finally, we have the clinical case-based learning system. Okay? So that's how it is. So we have certain methodologies, as I said, spaced learning. When you say spaced learning, it means that between classes, the entire class is divided into multiple sections. Okay? And for 15 minutes, probably you will teach the student about the theoretical aspect. Then you will have a quiz session in between. Then finally, it will be followed by, again, another part of the lecture. So that's known as the spaced learning. And what is, based on certain literature, it is seen that when you have such learning procedures, the short-term memory of the students increase. And also you can do something known as a flipped classroom. So what, as a faculty, we do is, we record our lectures, we send it to the student before the previous day. So they can go through the class, and then finally what they do is, in the classroom, they have a discussion. It will be group discussions that they normally have. So that is known as flip. So the class has already been taken at a home, that is the learning process is done at home, and in the class it is more of an assignment or a discussion that happens.
So that's known as flipped classroom. So all these methods basically help in increasing the attentiveness of the student and also helps them gain better knowledge. So this is what I said about the quizzes. You have different online platforms, and as I said, it increases the critical thinking. And one most important aspect of dentistry and any field of education is soft skills. So what do we mean by soft skills? It is your leadership quality, your communication skills, and all this is basically emphasized in your case-based learning or your PBLs. It is given very specific emphasis. So during the evaluation, we also evaluate the soft skills of the student. So all that is taken into consideration, and then finally we grade the students. So that is one important thing. And basically research projects also can help in the critical thinking. And evaluation, self-evaluation is also an important aspect. They will self-evaluate their questions that they've answered. So that also plays a very important role. And finally, now to the digital era, artificial intelligence and also virtual reality, wherein we've used, they can be a use of the pathology being analyzed by a virtual reality. That is, you can 3D models will be constructed and they can be visualized. And finally, to look at the effectiveness, there were certain studies, as I mentioned. This is based on an online game platform that was basically done in a university in the US, where they've used a particular app and they've looked at the student to patient relationship. It was seen that after using such games and innovative methods of learning, they had a better empathy. That is, they had a better contact with the patient. And in addition, as I said, what I mentioned earlier about the flipped classroom and the space classrooms, it is mentioned that it is a need of the hour that you have to have both the aspects. That is, both your short-term memory and the long-term memory is based on both your traditional learning and also the flipped class learning or the space learning. Okay, so to conclude, to the changing environment of our students' needs as faculty members and also probably the students who are going to be the future faculty later on, you need to have innovative ways of teaching and improvise on your teaching method for the betterment for the students. So with that, I would end my talk. I would like to thank the organizing committee and especially my teachers, my students, and I would like to mention Dr. Ashish, who was my student, who, as it is always said, you relearn from your students. And we've learned from our students based on what they question and how we try to teach them. So teaching is a better way of learning. So with these few words, I would like to end my presentation and thank you all for your patient listening.
Thank you so much, sir. Now I would like to invite Dr. Jay Shankar Pillai sir for your presentation.
Okay, fine. Yeah, you have to introduce her.
Actually, she's so that's why.
Okay, no problem. A very good afternoon, everyone. So I hope all of you had a good lunch. There's no one to introduce me, so I'll just give a brief introduction about myself. So I'm Dr. Jay Shankar Pillai. I'm working in oral pathology department of GDC Ahmedabad. I'm basically a forensic odontologist, graduated from Mahatma Gandhi Dental College, Pondicherry in the year 1997. Since then, I'm working in GDC Ahmedabad as a faculty. I've done my master's in forensic odontology and also my fellowship in forensic odontology. Handled nearly more than 500 medico-legal cases of age estimation, skeletal remains identification, human identification, bite mark analysis. So these are some of the few cases we handle. So actually, I'm an odd person here in this clinical-oriented platform where people talk about the various clinical aspects of dentistry. So I actually am an odd person in the sense my patients are not going to give me history. My patients are dead. So I have to deal with dead persons. To know who that actual person is, the identity of the person. So how to establish that identity through dentistry, through dental means is my domain. So when Dr. Ashish contacted me and said that, sir, you should deliver a lecture on forensic odontology in this platform, I was a little hesitant to, to accept that invitation because, people are students and clinical oriented, and so then I thought it's an upcoming branch. Considering the number of colleges, number of institutes opening up of new forensic odontology departments, considering the number of organizations conducting CDs in forensic odontology, then I said, okay, let me use this platform also to make an awareness, to generate an awareness about this budding branch of dentistry. So this is why I am here. So I accepted the invitation, and so I am selected the topic as the dental evidence in medico-legal cases. How from the dentistry we can generate those evidences, especially in medico-legal cases. At the same time, considering the public or the attendance here, it's a BDS undergraduate dominated gathering here. So it's not a forensic odontology public. So I thought I will discuss only the basics and how some of the cases where we handled using those dental evidences. So that is what the content of my presentation will be. Before that, I am proud to say that I represent this part of the country, coming from Gujarat, working in GDCH Ahmedabad. Very few colleges in India having both NABH and NAAC plus accreditation in the first go, and that too with a CGPA of more than 3.4. So I represent this college. We also have a department of forensic odontology and dental anthropology, because that is my subject of interest. So we have separate unit of forensic odontology and dental anthropology in our institute. So the content of my presentation today is I'll be elaborating about what evidence means, what are some legal terminologies which as a citizen of India, as a basic person of India, we should know about certain legal terminologies. Then about the dental evidence types, what type of dental evidences you can get in a crime scene, and of course a description about the crime scene and some cases. So this I have divided my presentation according to this content. So first one is evidence. So we all think that the word evidence means it's a material evidence. It's according to the law, it's not like that. Even an oral testimony is an evidence. When we are called as an expert in the court of law, that itself is coming as an evidence. So when you see all statements made by a witness in the court of law, so in the movies and all you would have seen that, there will be a witness box and there will be a session on examination and cross-examination. I still remember that incident when I was called for the first time by the court as an expert witness. I was standing in the witness box, and the film Damini only came to my mind. How the hero was able to pick that that witness box, that only I just remembered that. So it's not like that in every cases we are going into that witness box. Sometimes our report itself is a witness. So that report is what we deal as a medico-legal reports. The age what we estimate, or the sex based on the tooth what we identify, and what we write as a report itself is a witness. So we can classify witness also as a direct witness, or we can also call it as a circumstantial witness or an evidence. Direct evidence or a circumstantial evidence. I don't want to go in much depth of that, because as a medical expert, forensic expert, the evidence what we deal in the court of law is only a corroborative evidence. There are very few cases or instances where our dental evidence may be the main one, very few. But in other cases, if you see, even in the Nirbhaya's case, the bite mark evidence was a corroborative evidence which linked the perpetrator with the victim. So that is all about the evidence is. Now, why evidence? According to the medico-legal perspective, we require evidence because for these two reasons. One is, we should know whether the person who has died is a right person or not. Is he the same person which the parents or with the nearest of the kin claims? So identification is the first priority here. Then identifying the perpetrator of the crime. Bite mark itself is an example. Okay, a robber, thief enters a house and just he carries away whatever he wants, and he feels hungry, he opens a fridge, took an apple, made a bite, kept it on the table. So he has left one is evidence, that bite mark evidence. That is called as Locard's principle, what we deal with. Now when we have that identification of the victim as well as the perpetrator of the crime, so we can enter into the third one. That means we can link those two people to that particular crime or to that victim and accused relationship. So that is from a medico-legal context. But under legal context it is different. What the law states, in Hindi, ajar nirdosh. I mean, it is said no that the perpetrators of crime can escape the punishment, but an innocent should not be punished. That is what our law states. So that is the main reason why under the legal context we deal with evidences. So these are few terminologies which we all know, we have come across. We have various sections under the IPC which was established in 1860. The Criminal Procedure Code, that again which deals with the punishment and the way the police handles the cases. So it is all governed by that CRPC, not IPC. Then the inquest, whenever there is a dead body and the police need to have this inquest ready, because that only will help us in identifying the victim under CRPC 174 section. So the inquest has to be done. And as an evidence, if I have collected the evidence, I want to present it in the court of law, so I will be under the Indian Evidence Act of 1872. So that also we should understand. There are various sections under the Indian Evidence Act. One such is the expert witness. So we as a medico-legal experts or even any dentist, because what our Indian law states that BDS degree is enough to be a expert witness in the dental related cases. BDS degree is the minimum qualification which the court asks, but having an additional degree or a certificate or a training in forensic odontology or in forensics may substantially increase the value of your testimony. So that is why new courses are coming. But ideally under expert witness section 45 of the Indian Evidence Act, all dentists are expert witness. Then cross-examination. This is very interesting. Those who have really went to court as expert witness would have experienced this, because when we go as a government employee, as a government expert, I represent the state. Okay, so any perpetrator of the crime, he would also approach some lawyer so that to have a defense, isn't it? So when we represent for the government, that is for the police, so the perpetrator of the crime want to escape from the punishment, so he will have his own lawyer. So when we go to the court and we stand in the witness box, we are subjected to first is the examination. So that our lawyer, that means the government lawyer, will ask, public prosecutor. Then we are subjected to the cross-examination by the defendant lawyer. So that is very, very important, how to handle those questions. Sometimes they are very funny questions are asked. So we have to deal, we have to control all our emotions, anger, everything, and answer them. Because sometimes they ask very funny questions. They say that you have not done BDS. See, when I have not done BDS, then how the government recruited me for a faculty post? See, they want to divert this thing. So that is why such funny questions are asked during cross-examination. So we have to face such things also. Now, so when we are dealing with such things in forensics, so that has in fact given a new domain as a forensic odontology, where the three important legs of forensic odontology, that means the examination of the evidence, the evaluation of the evidence, and the presentation of the evidence. So if we or any person who is very good in having these three skills can be a very successful forensic dentist or an examiner. So that itself is the definition of forensic odontology according to FDI. What FDI states for forensic odontology is, it is that branch of dentistry which in the interest of justice deals with proper handling, examination of the dental evidence with proper evaluation and presentation of the findings. So this three is already given in the definition. So we talk about dental evidence now. Now why we have to deal with dental evidence? Because first thing, as I said already, it helps in human identification, and we all know why teeth are so much important, because we are dealing with the hardest structure in our body, which can withstand any type of robust insults, any type of thermal insults. It can survive for several years. I mean, the DNA can be preserved. So from that one single tooth, lot of informations can be obtained. So these are the main backbones for reasons for why teeth are important. And another very important thing is the dentition arrangement is very unique, like our fingerprints. Though there are some debates going on, like what if I get my orthodontically corrected? So will that be similar? So there are still debates and research needs to be developed on this lacunae. So these are the two reasons why we need. One is, as I said already, for human identification, and second one is to link the perpetrator with the accused. So that is why we are here. So the evidence can be classified as anyone, like a biological evidence, that means the tooth itself. From that we get a DNA, so biological element. We deal with the physical, like for example, the color, the mineralization status, then the pattern, that means the bite mark. So these are the three categories of evidences. But types, when we talk of the types of dental evidences, so we have a single tooth or a fragment of tooth could be an evidence. A skeletal remains with a few teeth or, all teeth. Then dentures. So what information we can get from that denture? One solid information we can get to narrow down our search. See, it's been fabricated by a quack. So that means that will highlight the financial, socio-economic status of that person who is wearing this denture. So that will narrow down the search of a missing person. So that information we can get. Also from restoration, charred teeth. The teeth can survive even 1800 degree Fahrenheit. So bite marks, DNA evidence, and also some individual characteristics. So these are types of evidence we look for. And crime scene investigation, as I said, it can be any, Okay. So crime scene investigation, usually the dentist or the forensic odontologist are not involved, because the first team to go there is the forensic mobile team or the investigating officer or the first responders. Usually in our Indian scenario, the dentists are not called. Forensic dentists are there, but even then they are not called at the crime scene investigation. So what they do is they just collect all the evidences at the crime scene and then transport that relevant thing to a dentist. So this is what happening in our country now. So there are few cases I can give as examples, like where vital evidences were missed because dentists were not involved in the crime scene investigation. So dental evidence, of course, we have to handle it. Along with that, sketching, photography, proper handling, packaging, and also transport. This is the main, the way how we have to handle the dental evidences. Now the ultimate goal, why we have to do this evidence, why we need to identify the person, because it's not like a dead body is there. There are three types of dead bodies. One is type 1, type 2, type 3. Type 1 is like when the visual examination can be done based on, features like identity from the face. That body will not be decomposed, fresh body. Type 2 is a body which is decomposed or burnt or charred, where the identity is not possible. Identification is not possible. And the third one is skeletonized remains. So these are the three types of bodies which are handled. So in the crime scene itself, it is for us to decide whether it's a human teeth or a non-human teeth. And also about the minimum number of individuals. For example, if there is a mass burial, so from the teeth, because during mass burial, if it is not properly buried, due to scavenging activities of the animals, scavengers, they come and eat the flesh and the bodies get scattered. So when we collect the teeth, it is always possible. Of course, it is possible from the bone also. Like we can decide how many number of individuals are there. Like for example, I can say if there are 3 upper right canine in one crime scene, 3 upper right canine, permanent. So that itself shows that there were 3 persons who were buried. So that from that we can come to a conclusion and we generate the biological profile. Now why biological profile? What are the parameters we require for a biological profile? The first 3 are very important and dentistry contributes much for those things. The age, the sex, the ethnicity and race. Now the age and sex, I would always prefer that sex will be the first, because if you can identify a person as a male or female, you are 50% through. So identification of the sex is more important first. Then comes the age. So based on that, we can narrow down the search, because the police might be searching for a person of 50 years old. Whereas in that mandible or the skull, whatever we got, there are mixed dentition. So you see, now we can narrow down the search and say, we can give a clue to the police that this particular body is of this age range. So you try to search for those missing people who are in this age category only. So that is one pattern. Then ethnicity and race, which is the main domain of dental anthropology. Here from the teeth, it is possible to, determine or to identify the race of a particular person or the ethnic origin of a particular person. There are certain non-metric traits which are available, which are not much studied in our Indian context in a larger scale. There are publications on a smaller scale, but on a larger scale, there is still a lacunae. So these 3, dentistry contributes more. Aging, I don't want to enter in detail in this domain, because this alone can be a 2-day workshop, dental age estimation. So I am just giving a rough outline that for age estimation, what parameters we require is dental mineralization status, tooth eruption, regressive changes, and the tooth resorption. So these parameters are used for aging. So they are considered as one of the evidence. Then for sex identification, we use metric and non-metric parameters. It has already been proved that using the metric parameters, we can correctly classify the sex to nearly 58 to 94% of the cases based on several studies. Okay, and those studies were often on a smaller scale, but we need to do a multicentric and a larger scale. So this is possible. Not only the metric, even the non-metric traits, which is not coming there. So even the non-metric traits, like for example, one particular trait I will tell, the distal canine accessory ridge. So the first year students who are sitting there, when you have carved the maxillary canine or the mandibular canine, you would have given the mesial slope and the distal slope of the crown, all those things. But in the lingual aspect, there is a ridge called as accessory ridge, distal canine accessory ridge. So that has got some sexual dimorphism. They are more common in males. So that particular traits can be studied in detail. Just see this video, you can understand how in one particular case we did age and sex identification. Video running. इसके बाद, इसके पहले नहीं होगा, ठीक है. So it's a mandible, like from that particular mandible which was sent to us from the forensic medicine department, what all methods we did, to first determine whether it is a male or a female. We used both the metric as well as non-metric methods, and also we did the age estimation, and we found out that that particular mandible belonged to a 25-year-old girl, female. Later on, when the case was solved and finalized, then we came to know that it was a female of 26 years old. So just 1 year age difference, we could give. So third part, that is ethnicity, as already I have told. Why these pictures are not coming? I don't know what is the problem. Anyhow, for ethnicity, I was telling about the various non-metric traits. So one such trait which is also considered as a trait of Asians. We all are Asians. Trait of Asians, that is the shoveling trait. So again, first years when you are carving the central incisor, in the lingual aspect you will be giving the marginal ridges. How many are first years here? Where first years? So all of you are PGs or what? Second years. Okay, so during your first year period, you would have carved the central incisor tooth, maxillary. So your teachers would have told you to make that marginal ridge and the fossa, isn't it? So I used to tell my students, you remember McDonald's ki yum. You know, when you are looking at the lingual surface of the central incisor, you know, when it resembles like McDonald's yum, the logo. So that two things are the ridges, the marginal ridge. Depending on the thickness of the ridge, we call that as a shoveling. So this is a trait of Mongoloid race, the Chinese, the Northeast. Okay, so those traits are very common for the Northeast Asians. But nowadays what is happening because of, intermingling and, globalization, I can say intercaste, interreligion, interlinguistic, inter-country marriages, this trait is slightly disappearing. So I don't know why I'm not able to show, but this is, the photograph was there. Is फोटोस नहीं आ रहा है, एक भी फोटोस का उस पर ट्राई करो ना, उस पर वो आया ना, अडाप्टर आया ना, नया अडाप्टर दिया ना, उस पर ट्राई करो, बिकॉज दे आर इम्पोर्टेंट एक्चुअली. एक्सक्यूज मी. So these are few cases which are, how dental evidence helped us in identifying the cases. इसके पहले किया था ना, किसी का वर्क हुआ था ना. What? नहीं हुआ. ठीक है, स्पीकर देखते हैं. Sorry for this technical glitch, it happens, always. So there were some images there actually, how personal habits also can help us in narrowing down the search. Like in third year oral pathology, students might be learning about the various modifications which happen in the teeth because of personal habits, because of occupational. So from the teeth also it is possible to elucidate the occupation of a person. For example, I can say those who are working in bakeries, where they are exposed to that sugar vapors. So their teeth, especially the anterior, will show more of caries. So that particular evidence, even a simple example is the tailor having the habit of putting the bobby pin, so that incisal notching is one typical identification mark. नहीं दिख रहे. हाँ? ये सब में आ रहा था. It's not supporting this. Anyhow, so there were other different cases where, for example, a hanging case. It's a very difficult question, a very common question for the investigating officers to know whether it is a case of hanging, suicidal hanging, or a person was strangulated and then hanged. And another important one such question is drowning. Whether a person died because of drowning, or he was murdered somewhere else and then his body was put into the water body. So this type of questions, dentistry can answer. The answer to those questions is the pink tooth. The pink tooth phenomena, I am not talking about the pink tooth of memory, which is of internal resorption. But when such strangulation cases or drowning cases are there, because when a person fell into the water body, he was alive. He would have been struggling to escape the drowning. So, because of that increase in the intrapulpal pressure which happens during that time, there is autolysis which takes place, and the hemoglobins try to infiltrate into the dentinal tubules. Especially, it will be very common to see such pink tooth phenomena in the cervical area of the anteriors, because we all know that the thickness of enamel is very thin at the cervical area. So, especially in the cervical area, there will be some pinkish discoloration in the teeth. So, that means it confirms that because of drowning, he died. Because if he was murdered outside and then put into the water body, the pink tooth phenomena is not there, is not going to be there. That is one such evidence. Another thing is suicidal. When a person is committing suicide, because of that pressure, or his tongue slips and comes out, and there will be the bite impingement into the soft tissue of the tongue. The tongue imprints will be there. But if he is strangulated and then hanged, that particular phenomena will not be seen. So these are some few examples I can quote as dental evidence. And one very important case we dealt in charred victim. Very interesting case. There was a factory and which employees night shift were there, and there was a fire accident, and some 7 people were charred to death in Ahmedabad. So at around 11:30 in the night, I reached the spot, and after taking permissions from the investigating officers, and I was told to go to the autopsy room, postmortem room. So night at around 1:30 we went to the postmortem room, and there were 7 bodies totally completely charred. There was a huge crowd outside because the nearest of the kin, the relatives, they were all waiting outside to claim the body, Now, when each and every body, when I examined, I was not very keen to, note the finest details of all the bodies, because you can understand the situation. Now, when I came out, I made an announcement to the public present over there. I just said, any one of your relatives, that any one of them have underwent dental treatment. If anyone having such history, please come forward. Then out of those 7, 2 of their relatives came front. They said, my wife had one ceramic treatment, crown in the piche wale dant, like that they said. And another person came and told, my sister was undergoing root canal treatment few weeks back, but her treatment was not complete. Then I said, if you can send me a smiley photo or any photograph of her taken recently. See, this is very important. I am very sorry I cannot show those photos, but this is a case I try to narrate at least. So he said, yeah, we can get one photo where his sister was smiling. Photograph was taken from some other hard copy photo and it was sent to me through WhatsApp. Now what I found in that teeth was, one was intact, upper central was intact, right. But 2-1 was having some class 3 fracture, release class 3 fracture, and it was also somewhat discolored. So that is one particular hint which gave me that this madam was undergoing treatment for that particular tooth, and that was root canal treated. So, immediately I went back again into that postmortem table and I saw all the bodies. Especially I wanted to see the upper 2 central incisor. Very interestingly, in one of the bodies, I found one central incisor. Of course, the body was burning at around 800 to 900 degree Fahrenheit. When the body is burning at that temperature, what usually happens is the crown gets detached from the root. This is what happens when you subject the tooth to high temperatures. The detachment of the crown from the root. See, that has made my work easier also, no? What happened is, in one of the central incisor, I took a photograph, first of all. And one of the central incisors, the pulpal area was less. In another central incisor, the pulpal area, the circumference of the pulp. I hope you could understand. Why? Because both were central incisors, both were developing at the same age, so both their pulp should be of the same size, isn't it? The cross section I am talking about. But in one of the central incisor, it was wider. That itself is a hint here, because she was having root canal treatment in that tooth. So we could, within 3 hours of the incident, we identified that body. There was another body where she was having ceramic crown. Based on the history given by her husband, we tried to locate upper 6, right 6 having a ceramic crown. So one of the bodies had one ceramic crown. So 2 bodies we could identify positively. But the situation here is the police or the investigating officers rely more on DNA, not on teeth. So DNA samples were taken from the body. DNA samples were taken from their relatives or their nearest of the kin, and that was sent to investigations. So it took nearly 12 days for the DNA report to come, but within 3 hours, positive identification was done based on tooth alone. Now you must be asking, sir, then you could have proceeded, because what Interpol says is, you all know what is Interpol? Yes or no? International Police Organization, Interpol. So what they have given a guidelines for disaster victim identification, that we should rely on 3 primary parameters for identification. The 3 primary parameters are, one is fingerprint, the third is DNA, the second is dental. The Interpol has given the guidelines, but in burnt case we cannot get the fingerprint, so it is not possible. So in a burnt case, more reliability should be given on dental apparatus. So that is what we wanted to highlight in this case. So another case under section 302, all these images I have already told. This is a bite mark case, section 375, rape. So one case of the victim was beaten by the assailant. It was a gang rape, section 357D, gang rape. So 4 people were there and 1 bite impression was there in the right cheek. So we got the accused, we took the impression, we got the victim, took the impression of the bite mark, Then using some manual and digital method, we proved that one of the accused, one of the assailants was the beater. So we have given that report also there. So that bite mark is a evidence here. And in child abuse case, madam is there, she has done a lot of work on child abuse, organized workshops, conferences also on child abuse. So child abuse cases, we all think of sexual abuse or bite mark like that. But very important in child abuse cases, frenal tear. Usually the child, if they don't like, the parents don't like, they just pull the child like this. So it's very common to see frenal tear in such child abused cases. So as a dentist, as a forensic odontologist, we also should look into the intraoral features of child abuse cases. So that's what I wanted to highlight. Sometimes smothering, they just press their, put all their pressure on the upper lip. So that smothering cases also will leave some indentations in the upper lip intraorally. Okay, so that also is a dental evidence which we can examine. In grievous hurt, there is a fight between two people. One person got hurt and his tooth got fractured. Now this case comes to the court. So the judge has to decide whether it is a case of hurt or grievous hurt, because the quantum of punishment varies. If it is simple hurt, the punishment is meager, it's very simple. But if it is a grievous hurt case, then the quantum of punishment is more. So who will decide that? No, they rely on us, dentists. What the grievous hurt condition says is a tooth fracture or dislocated fracture or dislocated from the bone. If because of the act of that fighting, if it has happened, that means it is a grievous hurt. So there is one such evidence here. Very important as a oral pathologist, they are here. We all teach about neonatal line for our first BDS in the histology. As one of the slides, we teach neonatal line in enamel. But it has got forensic implication, especially as a dental evidence when it is a case of feticide or homicide. Feticide, before birth, the child dies and delivered later on, or sometimes after delivery, the parents, if it is an unwanted child, it's very common now happening. So they, murder that baby. So they rely on the neonatal line. So here the neonatal line is a evidence. So like that, lip prints also one such evidence. Rugae patterns also we can link, especially in burns cases, because of the positioning of the body at the time of burning. The palatal rugae are well preserved. So trying to get that palatal rugae impression, and if it's a denture wearer, so it will be easy to correlate. So, yeah. Now when we get such dental evidences, so what we do? That evidence is subjected to several analyses. We do macroscopic analysis, metric analysis, radiographic, histology, all type of analysis are done, and to prove that the dental evidence plays a role. But one thing is important is the confidence level in the dental investigation depends on the physical condition of the evidence. That is why in bite mark case there is still a debate whether bite marks are reliable evidences or not. Because a severe bite mark will not show that clear-cut dental imprints. At the same time, a simple bite mark where there is no such indentation at all will not show as such evidences. So there is a severity index scale which is there in bite marks, which every forensic odontologist need to follow that. Now you will ask, sir, we have this evidence, but are they going to, the court is going to accept that evidence? Yes, we have to follow certain standards. That standard we call it as Daubert standard. This alone can be a 1-hour lecture for the forensic odontology students, but in a nutshell, I will tell that whatever methods we apply in forensic odontology, whether it is an age estimation case or a sex identification case or any human identification case, we should follow that standards. The method what we are going to use or using should have been tested, should have been done under a large population size, should have been done under the local formula should be available. And it should have a relevance in the scientific community. So that is why that particular method should have been published in a peer reviewed, highly indexed journal. So these are the requirements for Daubert standard. I'm sorry for all these things. This is the last slide. I'm really sorry for the non-visualization of the images. All these images are gone. I don't know why. I wanted to present from my thing, but this is also not supporting. Anyhow, so I think I wanted to give a broad outline about how we can use dental evidences in medico-legal cases. So these are my contact details, and I thank my Dean, Dr. Girish Parmar sir, for giving us the room and developing a department for forensic odontology. He is also my PhD co-guide, and Dr. Padma Shri, Dr. J.M. Vyas sir, the Vice Chancellor of National Forensic Science University under Ministry of Home Affairs, Government of India, is my PhD guide. I sincerely acknowledge them. The organizers of this conference, the management faculty of KGMU, all the students and the participants for their patient listening. These are my contact details. If anyone has some query, you can post it over here. Thank you very much.
I'm going to say now. Thank you, sir, for the informative lecture. So this was Dr. Jayasankar P. Pillai, sir. And a brief introduction of sir is he has graduated BDS from Mahatma Gandhi Postgraduate Institute of Dental Science, Pondicherry in 1997. He is working as a faculty of Government Dental College and Hospital, Ahmedabad. He teaches dental anatomy, oral histology, oral pathology and forensic odontology to the dental students. As an academician and a dental researcher, he is involved in several training and research activities for more than 26 years in the Government Dental College and Hospital, Ahmedabad. He has underwent fellowship training in forensic odontology from the Indian Board of Forensic Odontology, IBFO, in 2018. He has completed master's degree in forensic odontology with gold medal from Gujarat Forensic Sciences University, GFSU, in Gandhinagar. He is currently a PhD scholar at National Forensic Sciences University, NFSU, Gandhinagar. He has appeared as expert witness in age estimation cases under POCSO Act 2012 in Sessions Court in Gujarat. He has published several original research articles in journals like Forensic Science International Reports, Medico Legal Journal, Egyptian Journal of Forensic Science, Indian Journal of Dental Research, etc. Along with all this, he is a member of Indian Society for Dental Research, ISDR, International Association of Dental Research, IADR, Indian Association of Forensic Odontology, IAFO, and there are very many credits under his name, but for now, we are very grateful to you, sir, that you took the lecture, and thank you for the lecture once again, sir. Now, before moving on to the next speaker, I would like to invite Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir on stage to felicitate the guest lectures. I would request ma'am and sir to please felicitate. I would request Dr. Puran Chand sir to come on stage and felicitate along with ma'am and sir. We would like to felicitate Dr. Jayasankar P. Pillai sir first. Please give a round of applause for sir. He has just taken the lecture and it was a very informative lecture. Thank you once again, sir. Next, I would like to call Dr. Mariam Ali ma'am, who has covered the topic troubleshooting in complete denture. Please give a round of applause for ma'am. Next, I would like to call upon Dr. Vinayak sir. Next, I would like to call upon stage Dr. Sumit Goyal sir. He is yet to give the lecture, but we would like to felicitate you, sir. Next, I would like to call upon Dr. Puran Chand sir, who is already present on the stage. So I would like to request Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to felicitate Puran Chand sir. Sir is the next speaker for the day. Next is Dr. Vinayak sir. Dr. Vinayak AM sir. He has conducted and given the lecture on lasers. Next, I would like to call upon Dr. Shalini Gupta ma'am. Next, I would like to call upon Dr. Nagaraju sir. Next, I would like to call upon Dr. Abhinav sir. Next, I would like to call upon Dr. Rajni ma'am. Ma'am, please come on the stage for the felicitation. Along with ma'am, I would like to call upon Dr. Naveen sir as well. Okay, so that was all for the felicitation ceremony. Thank you, sir and ma'am. Now, let us continue with the guest lectures. We have amongst us the next speaker of the day, and that is Dr. Puran Chand sir. A brief introduction about sir. He is a professor and head, Department of Prosthodontics, Faculty of Dental Sciences of King George's Medical University, Lucknow. He has graduated from King George's Medical College in 1989 and completed MDS in Prosthodontics and Crown and Bridge by the same institute. He has been selected by Public Service Commission for the Provincial Medical Services, and after 11 years of successful service in rural and remote areas of UP, he has conducted so many oral health checkup camps for school, organized training programs for health professionals and field workers for oral hygiene and oral health environment. Dr. Puran Chand sir has joined as a teaching faculty in King George's Medical University since the year 2005. He is a life member of numerous academic societies such as Indian Prosthodontic Societies, Indian Society of Prosthodontic Restorative Periodontics, Academy of Oral Implantology, Indian Society of Dental Research and Indian Dental Association, and along with all this, he is a member of editorial board of many national journals and awarded fellowship of International College of Dentists in 2011 along with other. I would like to invite sir on stage and we eagerly wait for the lecture, sir. Please give a round of applause for sir.
Everyone, my topic is different from the dentistry. Effective management of obstructive sleep apnea, a prosthodontic approach. My presentation will start with the blessing of my parents and my teacher, Professor N. K. Agrawal. My presentation contents is a part first, introduction to OSA, sign and symptom. Part 2, diagnosis and risk factor of OSA. Part 3, management of OSA. And part 4, the efficacy of dental appliances. So, these are the topics covered in this lecture. The sleep is the golden chain that ties health and our bodies together. That is why the sleep is a necessary physiological need of the body, and any disturbances in the physiological need of the sleep will affect our whole life. The sleep is a periodic state of the rest for the mind and the body, in which the eye usually closes and consciousness is completely or partially lost, so that there is a decrease in the bodily movement and the responsiveness of the external stimuli. So, there is a slight difference between sleep, unconsciousness, shock or death. In sleep, the individual can awake with the stimuli, but in the shock there is no response of the stimuli, and this is the basic difference. The sleep disorder, usually so many types of the sleep disorder: insomnia, sleep apnea, restless leg syndrome, sleep paralysis, narcolepsy. Before the going to obstructive sleep apnea, we have to introduce some terminology which is used in this lecture. Ki apnea is a complete cessation of airflow for at least 10 seconds. Snoring is a raspy, noisy sound produced by the vibration of the soft tissue lining the air passage as the lungs work to pull air through obstructive airways. There is a obstruction in the upper airways, that the mucosa or lining of the airways vibrate and create a sound. Hypnea, cessation of 50% or more airflow at least 10 seconds. Our hypnea index is the number of episodes in 1 hour. So, this is the basic terminology. Then what is the sleep apnea? As you know, the sleep apnea is a disorder characterized by a reduction or pause of breathing during the sleep. Usually occur during sleep, and sleep disturbed due to inadequate breathing and poor oxygen level in the body. The sleep apnea is basically reduction of the breathing process. Due to this, there will be decrease the oxygen saturation in the brain, lead to the hypoxia, and due to hypoxia there is a frequent arousal during the sleep. You can say here normal breathing there is a clear airways, but in the obstructive sleep apnea there is a no clearance, that is there is a blockage of the airways. Snoring. Every snorer is not a sleep apneic, but every sleep apneic will be snorer. So, that is why the snorer is there is narrowing of the airways. Here there is, you can see there is narrowing of the airways, but in the OSA there is a complete blockage of the airways. Then you can classify the obstructive sleep apnea or sleep apnea according to the origin. How to this apnea is developed. So, according to origin of obstructive sleep apnea, there is a effort of the muscles for the respiration, but due to some obstruction there is a no complete breathing. Central sleep apnea, there is no effort of the muscles due to higher center or central nervous system, and mixed, there is a mixed of both central and obstructive also. You can classify according to the severity. Severity is based on the number of episode occur in the 1 hour. 1 घंटे में कितने एपिसोड हो रहे हैं, यानी कितने बार आपकी सांस रुक रही है, उस पर डिपेंड करता है. दैट्स डिपेंड ऑन द सिवियरिटी. कि नॉर्मली 0 to 5 number of episode considered to be a normal. 5 to 10 or 15 is a mild OSA, and 15 to 30 is the moderate OSA, and above 30 that is a severe. Again classification according to Mallam-Patti classification, that is based on the oral examination. In oral examination, you see here there is a clear visibility of the tongue, this opening, hard palate, soft palate, bulla and pillar. In class, this here there is a bulla is touching to the tongue. In this there is narrowing of the airways, bulla totally disappear, and there is no opening, there is no airway. So these are the on the basis of the classification oral examination. Coming to the symptom, how to diagnose, what will be the symptom of the patient, how do you diagnose that these symptoms are related to the obstructive sleep apnea. So it can be divided into two parts, daytime and night time. अब रात में यदि पेशेंट को क्या प्रॉब्लम होगी, दैट इज द लाउड परसिस्टेंस स्नोरिंग. पेशेंट तो नहीं बताएगा, लेकिन पेशेंट के स्लीपिंग पार्टनर को कंप्लेन होगी कि पेशेंट इज ए स्नोरर, लाउड स्नोरिंग. पॉसेज ऑफ ब्रीदिंग, रात में सांस रुकने के वजह से घबरा कर उठ जाना. द पॉसेज ऑफ द ब्रीथ एंड अराउजल. Choking of gasping of air. Due to this choking, patient will be feel suffocation. Restlessness. Due to frequent arousal, patient will feel restlessness and frequent visit to bathroom. Daytime symptom, early morning headache. Patient will complain the early morning headache, dryness of the mouth, poor concentration, irritability. Due to lack of the sleep, due to restlessness, patient feel irritable and feeling sleep during the routine activities. बैठे बैठे सो जाना, टीवी देखते सो जाना, काम करते सो जाना, ड्राइविंग करते हुए सो जाना, ये that will be lead to danger to the life. अब what are this is not a infectious disease और neither an infectious disease nor the deficiency disease. ऐसा नहीं है कि विटामिन की कमी या किसी मिनरल्स की कमी से हो रहा है, ऐसा भी नहीं है कि ये किसी वायरल बैक्टीरिया या फंगस इन्फेक्शन रहते हैं. व्हाट आर द कंट्रीब्यूटिंग फैक्टर? कि सम इज अ एनाटॉमिकल फैक्टर. स्मॉल साइज मैंडिबल, रिट्रोग्नेथिया, टू लार्ज और टू लॉन्ग टंग यानी माइक्रोग्लेसिया, long soft palate or bulla, कि there is a loosening of the soft palate, tonsillitis, enlarged adenoids, muscle weakness due to old age or disease, and nasal deformity. These are the common contributing factors which lead to the obstructive sleep apnea. Behavior factors like obesity causing deposition of fat in pharyngeal wall, and smoking there increase causes the inflammation in the upper airways, and other factors like alcohol consumption, CNS depressant, sedative, allergic, asthma, cold or sinus infection. These are the contributing factors which increase the severity of the obstructive sleep apnea. तो अब उन चीज़ों को we are again can explain कि enlarged tongue, nasal obstruction, DNS or nasal polyp, nasal cavity, enlarged tonsil, tonsillitis, upper airways tumor, enlarged soft palate, laryngopharynx, hypopharynx, floppy epiglottis, obesity and jaw malformation. अब what are the risk factor? कि in cases of these cases are the increases the risk factor of the obstructive sleep apnea. Obesity is the one and major cause of the obstructive sleep apnea. Increasing age, male gender, anatomic abnormalities of upper airways, family history, alcohol or sedative use, smoking and associated condition. These are the risk factor which increases the severity of the obstructive sleep apnea. After the sign and symptom, coming to the diagnosis. How to diagnose? No, how to, if you are ignoring the obstructive sleep apnea, कि इतना होने के बावजूद भी आप, because this is not a acute problem, there is no pain, there is no inflammation, there is no bleeding, the patient usually ignore करता है. If you are ignoring these symptoms, then what will be? Mainly problem is a memory problem and inability to think correctly. Start तो होगा यहाँ से snoring. Snoring will be not affect your only your life, but your sleeping partner also. जो साथ में सोने वाला है वो ज़्यादा इफेक्टिव होगा इन कंपेरिजन टू आप. तो स्नोरिंग डिप्रेशन क्यों होगा? इफ यू आर स्लीपिंग इन द डे टाइम इन वर्किंग प्लेस, that will affect your personality, and you are trying to awake but you are not able to perform your duty. That will lead to the depression. Hormonal disruption due to hypoxia, the its effect on the hormonal release. Memory problem, if there is a no proper sleep, there will be no rest, the memory will be affected. Sorry. Increased insulin resistance, if patient is a diabetic, there will be increased the insulin resistance, ultimately affect the cardiac problem also. The stroke, cardiac problem, high blood pressure, and increased risk of cardiac arrest, and one thing is a life threatening, the increased traffic and workplace accident. Major cause of the death is the roadside accident. The clinical sequences is the sleep apnea, sleep fragmentation and hypoxia, hypercapnia, excessive daytime sleepiness, cardiovascular complication and morbidity and mortality. These are the cycle. अब कार्डियोवास्कुलर इफेक्ट क्या हो सकता है? देयर इज ए सिस्टमिक हाइपरटेंशन, cardiac arrhythmia, cardiovascular diseases, myocardial ischemia, congestive heart failure, and cerebrovascular diseases. These are the consequences. This is the due to hypoxia of the brain. Hypothalamus इफेक्ट करता है और आपको ये hypoxia and hypercapnia that will lead to increase the disturb the hormonal balances. रोड साइड एक्सीडेंट, दुनिया में जितने भी रोड साइड एक्सीडेंट होते हैं, सेकेंड कॉज इज द स्लीप डिप्रेशन, यानी गाड़ी चलाते समय सो जाना, और उसमें सबसे ज़्यादा फैक्टर है आपका OSA. फर्स्ट है अभी भी अल्कोहलिक कंजम्पशन, दारू पीकर गाड़ी चलाना. दूसरे नंबर पर आता है कि आपका स्लीप एपनिक होना, कि ड्राइव करते जब कांस्टेंट आप स्टीयरिंग एंड क्लच गियर आप चेंज नहीं कर रहे हो, एकाएक आपको स्लीप आती, याद नहीं रहता, हम सो गए हैं और गाड़ी जाके कहीं ना कहीं भिड़ जाती है. So this is the cause of the death. Again, consequence of physiological pathophysiology, sleep, loss of airway tone, ear obstruction, hypoxia, hypercapnia, acidosis, arousal, और यहाँ से आपका जा रहा है कार्डियक के लिए कि दिस इज लीड टू द arrhythmia, systemic hypertension, chronic hypercapnia, pulmonary hypertension, core pulmonary, and arousal, hypersomnolence and impaired cognition, increased airway tone and patent airways. So these are the pathophysiology. अब यदि डे टाइम स्लीपनेस है तो क्या प्रॉब्लम आएगी? ठीक है, सोना सबको अच्छा लगता है, बट इंक्रीज द मोटर व्हीकल क्रैशेस, इंक्रीज द वर्क रिलेटेड एक्सीडेंट, पुअर जॉब परफॉर्मेंस, दैट विल लीड टू डिप्रेशन, फैमिली डिस्कॉर्ड एंड डिक्रीज क्वालिटी ऑफ लाइफ. कि फैमिली डिस्कॉर्ड, धीरे धीरे आपकी हैबिट को देखते हुए आपको किनारे करते जाते हैं लोग, कह रहे तो सोता रहता है, इसको मत बुलाओ, इसको मत काम दो. तो इस वजह से भी एक फैमिली है. दूसरी, आपके परफॉर्मेंस यदि पुअर होगा तो अगेन यू आर विल affect your personality and public attraction, and these all will affect your decreased quality of life. Again come to diagnose. There are two ways of diagnosis, objective, subjective. Objective में basically this is based on the questionnaire की history taking. History taking, there is a three scale, three questionnaire, upper syphilis scale, Burnley questionnaire, stop bank questionnaire. These are the screening test. And subjective physical examination, polysomnography, imaging, MRI, cephalometry, fiber optic endoscopy. अब हिस्ट्री में क्या लेंगे हम? इन द हिस्ट्री देयर इज लाउड स्नोरिंग, नॉक्टर्नल गैस्पिंग, ऑटोमोबाइल वर्क रिलेटेड इंसिडेंट, पर्सनैलिटी चेंजेस और कॉग्निटिव प्रॉब्लम, risk factor, excessive daytime sleepiness. These are the common problem or should be asked in the history. These are the Epworth sleepiness scale, questionnaire, sitting and reading, watching TV कि क्या अभी पढ़ते समय सो जाते हैं, watching TV देखते हुए सो जाते हैं. There is a responses according to number and that total score will give the information. Berlin questionnaire, there is 3 categories. One category, do you snore? Yes or no? Do you know? Don't know. आप जानते हैं कि नहीं जानते हैं? If you snore, अब कितने loudly होता है? How often you snore? So these are the questionnaire available in the net also. You can download. I can use the further diagnosis. Stop bank. This shows the severity of the case. And examination, if the neck circumference is more than 17, that will be prone to the obstruction apnea. In case of the female, more than 16 inches, if the patient is hypertensive and obvious upper wedge abnormality, and BMI, if the BMI is more than 27, and other polysomnography is a gold standard of the diagnostic tools. In this polysomnography, we are record the oxygen saturation, daytime arousal, nighttime sleeping arousal, hypoxia, apnea and hypoxia index. So these are the diagnostic tools. Lateral cephalography, you can measure the opening of the airways. Electro-optic endoscopy. So these are the basic concept for the diagnosis. Coming to the management of OSA, कि how to manage the case. आपने हिस्ट्री ले ली, एग्जामिनेशन कर ली है, इन्वेस्टिगेशन करा लिया, पता चल गया कि पेशेंट इज द स्लीप एपनिक, ऑब्स्ट्रक्टिव स्लीप एपनिक. वी आर डीलिंग ओनली ऑब्स्ट्रक्टिव स्लीप एपनिया इन डेंटल प्रैक्टिस, नॉट ए सेंट्रल. ऑब्स्ट्रक्टिव स्लीप एपनिया भी हमें माइल्ड टू मॉडरेट should be considered first, not in the severe cases. So this can be divided into 3-4 parts: risk counseling, behavior modification, medical surgical treatment, and dental appliances. So coming to the risk counseling क्यों करना चाहिए? Why the risk counseling is important? Because patient should be aware about the risk factor of the disease. कि आपको बताना होगा कि आप ये if you are a obstructive sleep apneic patient, you should not drive the motor car or any vehicle, because this is the related to your life. Second, job related hazards. If the patient is a job with the mechanical operation, कोई मशीन चलाता है, कोई गाड़ी, कोई ऐसी हैवी मशीन ऑपरेट करता है जिसमें लाइफ को डेंजर हो सकता है. थर्ड वन इज जजमेंटल इम्पेयरमेंट. ऐसे लोग डिसीजन लेने में कंफ्यूज रहते हैं, वो अच्छे डिसीजन नहीं ले सकते हैं, तो उनको ऐसे जगह पर भी उनको जॉब में नहीं रखना है जहाँ को उनको एक डिसीजन मेकिंग प्रॉब्लम होती हो. तो ये रिस्क काउंसलिंग करने की है. यू हैव टू अवेयर अबाउट दिस. अगेन कम टू बिहेवियर. यदि नॉर्मल टू मॉडरेट है, माइल्ड है, तो नॉर्मल टू माइल्ड में आप यू कैन ट्रीट द पेशेंट विद द काउंसलिंग एंड द बिहेवियर मॉडिफिकेशन. बिहेवियर मॉडिफिकेशन क्या है कि मोस्ट ऑफ द कॉमन पेशेंट इज द ओबीज. यदि उनकी वेट ज़्यादा है तो काउंसिल द लूज वेट, अवॉइड अल्कोहल एंड सेडेटिव, अवॉइड स्लीप deprivation, stop smoking, avoid sleep pills or other sedative, elevate the head weight your 4 inches, avoid supine position. ये तो चीज़ें हैं, लेकिन ये दोनों आपको जो लास्ट के 2 हैं ये ज़्यादा इम्पॉर्टेंट है कि यू हैव टू रेज द हेड ऑफ द पेशेंट बिकॉज द डायफ्राम यू विल प्रेस बाय द एब्डोमिनल वॉल. तो उसको काउंटर करने के लिए 4 इंचेज हेड को एलिवेट कर दें। सेकेंड इज दे शुड नॉट स्लीप विद द सुपाइन पोजीशन, सीधे नहीं सोएंगे, सीधे सोने से प्रेशर ज़्यादा पड़ेगा, तो उसको कहते हैं स्लीप ऑन द वन साइड। वन साइड यानी एक करवट लेके सोएंगे तो वह प्रॉब्लम कम होगी। अब पेशेंट कहेगा भाई सोने के बाद तो हमें पता नहीं चलता हम कैसे सो जाते हैं, तो इसके लिए क्या करते हैं कि पेशेंट की जो नाइट वेयर है, नाइट वेयर में ही एक सीव बना देते हैं और उसमें टेनिस बॉल डाल देते हैं। जब भी वो सीधा सोएगा पीठ में चुभेगा तो अल्टीमेटली फिर वह वन साइड सोना शुरू कर देगा। दिस इज द सम टॉपिक। अच्छा, तीसरी चीज कहा जाता है ना कि देयर मस्ट बी गैप बिटवीन स्लीप एंड नाइट मील, यानी 3 से 4 घंटे का अंतर होना चाहिए। लाइट फूड लें एंड अवॉइड द फैटी और डेयरी मिल्क प्रोडक्ट, ये चीजें नहीं लेनी है। अब तीसरी चीज आती है मेडिकल के साथ कि ओएसए पेशेंट में गोल्ड स्टैंडर्ड ऑफ द ट्रीटमेंट कहा जाता है कि सीपैप है, सीपैप वाईपैप, कि ये आपका तुरंत फायदा देता है, तुरंत फायदे देने में, लेकिन उसके साथ प्रॉब्लम भी है। ऐसा नहीं कि देयर इज नो प्रॉब्लम या देयर इज नो साइड इफेक्ट। तो साइड इफेक्ट इज द क्लस्ट्रोफोबिया, एक दिमाग में डर बना हुआ कि हमें तो मास्क लगा के सोना है। देयर इज स्किन इरिटेशन, देयर इज leakage of the air through the mask that causes the skin irritation, nose sore nose is due to pressure of the air that can cause the irritation to the nose, ear leakage, stomach bloating। यदि एयर जो जाता है तो not only goes to the trachea, it will go to the GI also, that can lead to the stomach bloating and chest or lung pain, mouth dryness of the mouth, nasal congestion and eye irritation. These are the common factors which observed by the patient. अब ओरल अप्लायंस की बात आती है कि वाई यू आर यूजिंग द ओरल अप्लायंसेस, कि ये 1992 के पहले ओरल अप्लायंसेस एफडीआई ने अप्रूव नहीं किया था, एफडीए ने, ये उसके बाद अप्रूव हुआ कि हाँ ओरल अप्लायंसेस कैन बी यूज्ड बाय द डेंटिस्ट आल्सो। इसी वजह से लिटरेचर हमारे पास बहुत लॉन्ग हिस्ट्री नहीं है, देयर इज नो रिव्यू बिफोर द 1980s। हालांकि यूज हो रहा है ये सबसे पहले डेंटिस्ट्री से ही। क्या सीपैप इज इफेक्टिव इन रिड्यूसिंग सिम्टम ऑफ सिम्पटम्स एंड इम्प्रूविंग क्वालिटी ऑफ द लाइफ मेजर इन द पीपल विद मॉडरेट टू सीवियर ऑप्टिक स्लीप एप्निया, इट इज मोर इफेक्टिव देन ओरल अप्लायंसेज। ये सीपैप तो है लेकिन ओरल अप्लायंसेज इज आल्सो इफेक्टिव। This is my publication in the Indian Journal of Endocrinology and Nematology. The oral appliances is successful treatment modality for the obstructive sleep apnea in all categories. So, what are the dental appliances used in the dentistry for the OSA? There is a tongue retaining device, palatal lifting device and mandibular repositioning. Most common used device is the mandibular repositioning or mandibular advancement device. अब ये अप्लायंसेज हैं तो कहाँ यूज होना है कि टंग रिटेनिंग डिवाइस, दिस इज द टंग रिटेनिंग, वो मोस्टली यूज इन द चिल्ड्रंस और edentulous patient. There is a no proper dentition or adequate dentition, so you can use the this tongue retaining device कि there is a bulb and after the pressing they create the negative air pressure and hold the tongue in the bulb and tongue will not fall down posteriorly, that will the upper airways will be clear. So, this is the mechanism, but a disadvantage is irritation through the tongue, drooling of the saliva, nasal obstruction is a contraindication. If the patient is a mouth breather, then should not give this appliance. Palatal lifting device, this is the just like a Haley's appliance of the ortho appliance, and there is extension and that part of the appliance will lift up the soft palate. Mandibular advancement device, there is more than 50 types of the mandibular advancement device available in the literature. The mandibular advancement device can be classified again कि prefabricated and custom made. There are some appliances available in the market which are the prefabricated, patient can use with the help of the dentist directly, and customized that can be made by only by the dentist. Again this customized divided into two, one piece or two piece, a single piece, and there is a two piece mandibular and maxillary are two appliances. This mandibular advancement device again further divided into two, adjustable and non-adjustable. We are using mostly adjustable and two piece devices. Why we are using the mandibular advancement devices? Devices how to act? Mandible को जब आगे करते हैं, we are protruding the mandible, there increase the airways here, lumen. The clinically effective mild to moderate OSA relatively inexpensive compared with the cost associated with the other non-surgical and surgical treatment, ready to accessible, non-invasive, while along return compliances are limited. Overall compliance is reported over more than 50 to 70%. अब बात आती है कि मैंडिबुलर एडवांसमेंट डिवाइस को हम कितना प्रोट्रूड कराएं, कि देयर मस्ट बी 50 to 70%. 50% means there is a some overjet, the overjet plus protrusion of the mandible and divided by 2, that will be 50% of the advancement, and if there is no response, then we can increase the movement protrusion of the mandible. How to fabricate? Nutshell में बता दें कि first you have to examine the patient. There should be no TMJ problem, there should be no periodontal problem, sufficient number of the teeth should be present, at least 10 teeth should be present in the oral cavity to get the encourage. If there is no TMJ problem or any MPD syndrome or TMJ disorder, make the impression maxillary and mandibular, again measure the overjet and get the protrusion, calculate, and then again record the bite for the protrusion. So, after the making the cast, you can articulate on the bite mark, taken bite and make a appliance. So, these are the different design can use. This is the all are the mandibular advancement device, adjustable. These are the some name here. हाँ बस हो गया भाई. So, these are the different appliances. This is by cases treated by me. They are the evidence based cephalometry. Here the one piece appliance. There is a and mandibular advancement device adjustable. This is the cephalometric measurement. This is adjustable device which are patented by Indian Patent Office. So, these are the some study related to obstructive sleep apnea and effectiveness of the appliance. And now conclude the topic case. OSA is a severe problem with in the society. This can be a life threatening, but it can be easily treated by the any dentist with the some study, and patient can get a normal life. Thank you. Thank you for patience hearing.
Thank you so much, sir, for wonderful presentation. Now, I would like to invite Dr. Nagaraju, sir. He is the professor and head at Oral and Medicine Radiology Department at Subhati Dental College and Hospital, Meerut.
First. ये माउस में हाँ पॉइंटर ये अटैच किया क्या वहाँ पे नहीं आ रहा है
कर रहा हूँ स्विच कर दो भैया
हो गया आई थिंक आई एम ऑडिबल या सर जब आप लेक्चर ले रहे थे आपने कुछ ड्राउनिंग का भी बताया फिर बाद में आपने हैंगिंग का भी बताया उस टाइम पे मेरे को याद आ रहे थे श्रीदेवी याद आ रही थी और सुशांत सिंह याद आ रहा था दोनों शायद आप वहाँ पे होते और डॉक्टर पूरन सर CBCT must have been there sir one small change so I am Dr. Nagaraju professor and head from Subhadhi Dental College this is the college where I have been working from past 15 years so my presentation is 2D to 3D why we have to go from 2D to 3D and with a emphasis on a cone beam computed tomography so the CBCT why we are going first of all we have to know why an imaging is done imaging is done to reveal a pathology and to reveal the normal anatomic truth so the diagnostic images 2D what are the most disadvantages or limitations of 2D images are they have distortion superimposition inaccurate measures inaccurate anatomical relations and inability to visualize the third dimension like to see the three-dimensional view of a female I have to see from 2 dimensions so I have to focus with 2 lights from the anterior post and from the lateral aspects so that I can visualize the female from top to bottom left to right and anterior to posterior so 2 visions are visible for me but why we have to take a 2 visions when 1 vision can or 1 scan can show you a 3-dimensional object which is there as such it is. So the era has gone from 2-dimensional area. This is the path we have traveled in the dentistry. That is from we started with IOP films, intraoral periapical films. Then we have gone through different OPG films, IOP films. Then we went through the OPG. And then we went through general skull radiographs, then RVG came, then came the game changer, that is CBCT. CBCT was first introduced for the angiography. Then this CBCT came into the existence in dentistry in the year 2000. So CBCT has changed very much and it has transferred like anything and it has showed the image inside out turn around up and down ways. This is the significance of a 3D imaging. So what is this? What is this 3D? What is this CBCT? Cone beam computed tomography. What do you mean by tomo? Tomo is nothing but a slice. It is a technique which is designed to image more clearly the objects in one plane of interest. If suppose I am taking a mandible, if I want to see these mandibular structures more clearly, which are lying in one plane, then the structures which are above like bone structures, which are above like other soft tissue structures like skin, lips, if I don't want to visualize them, I want to visualize only the bone structures. I have to place those bone structures in one area so that those structures which are present in that area can be clearly visualized and the structures which are not present or anterior or posterior that can be blurred. This is the concept of tomography. Tomo means slice by slice. So where did this CBCT come from? CBCT came from computed tomography, that is CT scan. So he was the person, Hounsfield was the person who first invented this computed tomography. Computed is utilization of the computer in creating an image. Utilizing a computer, the bits which the computer utilizes and transforming that bits computer into an image was done by this computed tomography image. That is called as computed tomography.
From that computed tomography, we have gone through the CBCT. See, this is the gantry in which the patient sits or lies down, and then this is the X-ray tube, and these are the scintillating crystals. Now, the source, it moves around the patient in one section and it captures the image layer by layer. So it moves in patient in an axial way. So in a computed tomography, the sections which are taken are axial. Now so these are the sections which are taken in the CT image. From that CT, we have derived one mode called as cone beam computed tomography. In this, the patient is pushed little bit down. Now the source, if you can see clearly, the source was fan shaped. Now the source which was fan shaped, it has converted into a cone shaped. You can clearly visualize that red which is symbolizing there, it has become into the cone shaped. Fan shaped has become cone shaped. Now the scintillating crystals, they were changed with the detectors, flat panel detectors, CMOS. Your mobiles have these CMOS sensors, complementary metal oxide semiconductor sensors. These sensors are utilized in the CBCT to capture an image. So the X-ray which is coming it is in the shape of a cone. That is why it is called as cone beam computed tomography. So the images are captured in the CBCT in a lateral safe manner. All these images, when they are captured in a lateral safe manner, they are assembled each other and then a completely 3D reformatted image is formed. A 3D. Lateral safe 1, 2, 3, 4, 5, 6 sections will be taken. These sections will be assembled together and they will form an image structure. This structure, which is reformatted by the computer and which produces on the computer displays on the image, is called as an image data which has analyzed by the computer in a cone beam machine. This is called as cone beam computed tomography. So what does exactly this each and bit and pieces of this image consist of? So I have maximized the area, like suppose third molar region. I am maximizing it. You can clearly see that what will be the final image in the computer. See, you can see this gray values, different shades of grays. What are these different shades of grays? This is the one image what the computer analyzes. If suppose X-rays are coming through the mandible or through the bone structure or through the soft tissue structure, the bone structure where the X-rays pass, they will be absorbed. So there will be one different level of gray on the computer, and when the X-rays which are passing through the soft tissue, they will be having different gray structure. So these are the different grays which will be visualized on the computer. Now this length by breadth, which we call it as this length by breadth, which we see here, and this length by breadth which we see here, this we call it as pixel. Pixel is the what which your cameras have. Picture elements, 62 megapixel, 126 megapixel, these are called as pixel, picture elements. But in CBCT, these will be stored as voxel. If you have seen a Rubik's cube, it has both length, breadth and depth. This is called as voxel. This is called as volume elements. So every volume elements, they will be analyzed by the computer, and n number of volume elements will be formed by the picture, and it will be reformatted to give a final image. Now most of the students, they have a confusion on what are the different sections of CBCT. For this I usually do use a mnemonic. When I am on a picnic, I use an SLR camera. I use a tab or a bat. If you are a boys, you can use a bat. And I use usually, to become a cool person, you can have a cap. So for an SLR camera or for a sagittal section, it is from left to right. Remember sagittal. SLR is sagittal, left to right. And for tab or a bat, axial means top to bottom or bottom to top. And for a cap, coronal section, anterior to posterior or posterior to anterior. So these are the mnemonics which I use: cap, SLR camera and a tab. प्ले ये जाने रहा है. साउंड ना साउंड नहीं है.
भाई फ्रीज करना, फ्रीज कर दो ना.
Five minutes.
When viewing CBCT scans, we speak in terms of planes or the axis of orientation. When viewing the axial plane, we're moving from the top of the head down to the chin or vice versa. In the sagittal plane, we're moving from ear to ear. And lastly, in the coronal plane, we're moving from the nose to the back of the head or from the back of the head to the nose.
So when we take a CBCT scan, we usually have 4 blocks. One block is 3D image, the other one is axial, the other one is coronal, and the other one is sagittal. So we have 4 blocks on a CBCT scan. So what is the strengths of this cone beam computed tomography? A cone beam imaging has a number of features that make it suitable for the dental applications, but it also has a number of limitations. First advantage is size and the cost, high speed scanning, sub-millimeter resolution. And the interesting fact is, when compared to the CT scan, CBCT has a low patient radiation dose as compared to the CT scan. It is 10 times lesser than a CT scan. So what are the differences between a CBCT and a CT scan? CBCT is, as I earlier said, it has a cone shaped, whereas CT has a fan shaped, and the images which are produced in the CBCT are lateral surface. The point to be noted is the exposures. Exposures are about approximately 70 to 250 microsieverts, whereas in CT scan we have 2000 microsieverts. This is the advantage is why the dentistry is moving towards the CBCT rather than going for the CT scan. And moreover, this CBCT has a cursor-driven measurement algorithms which provides the practitioner with an interactive capability for real-time dimensional. By this CBCT, we can measure the dimensions. What is the length of the bone, what is the breadth of the bone, what is the height of the bone, what is the depth of the bone. So with the computer analysis, we can do each and everything. And with the software, extended functionals like specific applications such as implant simulation, orthodontic analysis, and measurements can also be done in this CBCT. There are usually, when you are prescribing a CT, be careful with the field of view. You have to select whether you are going for a single quadrant or a multiple quadrant. So CBCT has usually 3 FOVs, that is a field of views: large field of view, medium field of view, and focused field of view. Large when you are taking the skull, entire skull. Medium is when you are taking either maxilla or mandible. Focused is when you are taking a quadrant of a mandible. So how did the CBCT in my day-to-day curriculum or day-to-day academic, how did it enhance or how did it? See, these are some of the cases where I found CBCT more helpful in revealing the anatomical and the pathological side. See, usually we think that there will be only one mental foramen. Can I have pointer please? Pointer. So usually, if you can see carefully, you assume that there is only one mental foramen, but there can be multiple mental foramens also. And the canal, you think that there is only one inferior canal and one accessor, but the inferior alveolar canal can have n number of variations. So this in a two-dimensional images, it will not be possible enough as compared to the three-dimensional. Three-dimensional will accurately give the dimensions, the variations which are present. Even when you are planning for a implant in the maxillary sinus, this is the posterior superior alveolar artery. If you can clearly see that it is going through the floor of the maxillary sinus, lateral border of the maxillary sinus. So when you are planning for any maxillary sinus like sinus lift or any other thing, this is the important structure which you have to keep into notice. Along with it, we do have a anterior superior alveolar artery in the anterior region. This is the one. So these are the different variations which I have come across while getting the different scans. This is one interesting case. This patient, 50-year-old patient, she had an RCT done 4 years back. Then we took an IOPA. She had a normal RCT with little bit 1 to 2 mm short of apex. Then we went for a CBCT scan. Now we can clearly see the CBCT scan, what it is showing in the periapical region. You can clearly see the periapical radiolucency. You can clearly see the root resorption which can be present in this. So this was the complaint what the patient had, which we could not elicit on an IOPA. This was the IOPA wherein we could not see any radiolucency which was appreciated on the CBCT scan. Like some more x-rays, patient had an extraction of third molar, there was cervical abrasion, patient was complaining of severe pain, then we went for the CBCT. So we can clearly see the architecture, the changes in the bone when we have undergone from 2D to 3-dimensional. So this was one more patient where she had an RCT done. She was complaining of a pain in an RCT due to tooth. The RCT looked very fine, except there was some delineation in the RCT. Then we took a CBCT scan which clearly demonstrated a fracture. So these are some of the cases which we have dealt in a year span of 3 to 4 years, and we came to know the significance of what a two-dimensional image cannot show and what a three-dimensional image can show. The same thing, mandibular maxillary anterior tooth, you can clearly see the pulp stones which are present here, and you can clearly see the fracture of the buccal cortical plate. One thing we missed was there was even a fracture of the nasal floor also. So these were the advantages of the CBCT over this. And then this is the maxillary molar tooth, where one of the most common variation in the maxillary tooth is MB2 canal, mesiobuccal canal, which can be clearly appreciated on this CBCT scans. Now a patient came, they wanted an implant, they said that there is an impacted tooth. So when we did an implant simulation, we saw that the implant was impinging onto the canine region. This, by taking a normal two-dimensional view, you cannot visualize whether the implant which you have simulated or the implant which you are going to plant, it can damage the underlying structures, or it can block, or it can impinge onto the underlying structure. Otherwise, so this is one more case, a periapical abscess. So the structures which we see in the periapical IOPA radiographs are two-dimensional, only a radiolucency. But as we go to the different cases, we can see the fracture, or we can see the obstruction or delineation of the nasal floor also. This is one more case. Most of the dentists, they think that there is a carious tooth, there is a pathology in the maxillary sinus region, but what a two-dimensional image could not show, a three-dimensional image can see. So we can see a homogeneous radiopaque area in the maxillary sinus which is emerging from the floor. This doesn't have a corticated margin. This is a normal mucus retention cyst, which most of the dentists, they might be thinking of a cyst in a infected tooth. इसका वीडियो 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 हाँ वीडियो वीडियो So these are the software applications which have revolutionized the CBCT in clearly demonstrating the pathological sites, how they are, whether the fracture segments are favorable or non-favorable. This can be directly given to the surgeon, oral surgeon, who can directly see the or visualize the structures, visualize the fractures, whether it is favorable or unfavorable. So in detecting the minute TMJ changes like LE cyst, TMJ arthritis. So one interesting case is she had come from the implant in the mandibular posterior region. When we took the mandibular CBCT scan, you can see the lingual concavities with here. If suppose you are planning an implant, you are more chances of penetrating the implant and passing on through the lingual plate, and then you are causing a pain to the patient. So these images, whichever are seen, this is a stiffness bone cyst or submandibular salivary gland depression, which cannot be clearly seen on a two-dimensional. They can be clearly visualized on a three-dimensional images itself. So along with this, there are some mandibular incisive canals and the hourglass-shaped maxillary anterior bone, which are the structures which can be visualized on the CBCT. Or else, if suppose you are not going for the CBCT, so you are definitely planning to or definitely going to go either into the impinge into the nasal floor or go in a wrong direction, coming out through the labial cortical plate, or your implant can penetrate through the lingual cortical plate, enter into the oral cavity, or you can land up sending an implant into the maxillary sinus region, or you are going to perforate. When this is the perforation which has been done while creating an implant for access for implant planning. So it has perforated the inferior alveolar nerve canal, and the patient will complain of. So he doesn't know the exact length, what is the length he has to go through. So without this CBCT image, the length cannot be accurately determined in a two-dimensional. Only the accurate dimensions can be measured in a three-dimensional radiograph.
मुंह खोल के दिखा मैया को
So that is a dentist perspective of CBCT. हमने CBCT advise कर लिया, इसका मतलब भूमंडल तो नहीं दिखाई देगा. Even it has some limitations also. Okay, cone beam computed tomography has some geometric limitations depending upon the different X-ray attenuations and soft tissue contrast. So it is not a completely 102% diagnostic or anything. because sometimes the diagnosis can also be different because the lesions, they don't read the books. Two such interesting cases. One interesting case was this in the premolar region and one in the premolar other region. These are two different cases mimicking like a fibroosseous lesion. One turned out to be a tuberculous infection and the other one turned out to be a malignancy. So the books, they don't read the lesions, they don't read the books. They can present in any different manner. CBCT is just an excellent diagnostic imaging modality and represents the three-dimensional structures accurately. But when you are prescribing a CBCT, follow the ADA-LADA concept while doing, and it has proved to be highly successful in implant planning. Thank you very much. And I would like to thank Dr. Anmol and Dr. Ashish for giving me this opportunity. Thank you very much.
Thank you so much, sir. It was a wonderful presentation. Now I would like to invite Dr. Abhinav Sharma, sir. He is the Associate Professor at Department of Oral Medicine and Radiology at Subhati Dental College and Hospital.
नहीं मैं हाथ से चल अटवा तो आ नहीं रहा Jai Hind, good evening everyone. Myself Dr. Abhinav Sharma. I am from Subharti Dental College. This is my workplace. So I'll be taking lecture on radiation protection in dental hospital and dental clinic setup. So this is an awareness lecture for people who are going to open their clinics and they are working in dental hospitals. So they are very important things. So don't expect any clinical aspect from from this lecture. So, while planning the layout of dental hospitals and dental clinics, we have always been taken care of some certain things. Yes? So, sorry for the interruption. Yes, so while planning the layout of dental colleges, dental hospitals and dental clinics, we have always been taken care of some certain things like hazard from electrical, we have taken care of fire extinguishers, interiors and exteriors, everything. So there is one thing which is lacking behind, that is the protection from radiation. This is the one thing who's, nobody is taking care of these things. So, we call it lack of awareness. Because of lack of awareness, these are the things which are, happening while opening the dental hospitals and dental clinics. So I have a data which proves there is a lack of awareness. 79% of the dentists are unaware of radiation protection guidelines. Around 50% of the dentists are unaware of principles of radiation protection, guidelines, and 76% of the dentists' behavior regarding oral radiology safety standards are not satisfactory. So I'll be covering this topic under the following headings. Like I have 4 questions for you, from what we need protection, why we need protection, and whom we are going to protect and how we are going to protect. So the first question is what? For what we need protection? So answer is radiation. We need protection from radiation. So what is radiation? Radiation is basically energy traveling waves or particles. So, the unit is sieverts. In, day to daily life, in our daily life, we, encounter with the radiation. This of two types, ionizing and non-ionizing. So non-ionizing will be using in term of visible light, infrared rays. We use microwaves. We use mobile phones. They emit mild source of. They are all source of non-ionizing radiation. Even some certain food, as well as when we spend quality time with our partner, then we also exposed to some radiation. So on ground it is 10 microsieverts, and while traveling in flight it is twice. So in dentistry we use in the form of light cure as well as in the form of lasers, that is non-ionizing. So everywhere we are surrounded by this ionizing radiation, so we require this suit. The answer is no. Non-ionizing radiation is not harmful, term and conditions apply. So the second thing is ionizing radiation. We have gamma rays, X-rays, radioactive elements, nuclear power plants, nuclear weapons. They all use ionizing radiation. And main uses of ionizing radiation is in our medicine, that is diagnosis, treatment and sterilization. In dentistry we use in the form of CBCT, CT scans and multiple OPG, IOPA, different radiographic techniques. So patient exposure per radiograph, you won't believe, if we expose to patient, while doing any RVG, we use sensors. So the dose is 0.65 microsieverts, but it is equivalent to, you are getting exposure from sunlight of 1 hour. And if we do OPG, that is equivalent to 1 day, and CBCT, that is equivalent to 2 weeks, depending on FOVs. So why we need protection? Why we need protection from radiation? So there are multiple case reports, multiple data is there. I have a literature which proves the reported cases are there, that people are getting exposed by this radiation, are getting affected by leukemia, multiple thyroid disorders, especially the children's, the growth disorders. So health effects from exposure to dental diagnostic X-rays. So common occupational hazards are like skin rash, reproductive system failure, cancer later on stages, and immediate patient will see diarrhea, malaise, fever, CNS disturbances. So they are basically slow killers. They won't, अभी आपको radiation से exposure हुआ and अभी आपको problem start हो जाएगी. This is not like that. They are basically slow killers. So I'll brief you little bit about the history part. That is, it is invented by William Conrad Röntgen in 1895, and the first radiograph is taken by Otto Volkoff in 1896. So he took around 25 minutes of exposure, and he reported that he got burn over his face. So this is the first ever radiograph. So Sir Nikola Tesla, after the reporting of this charring, this burn, Sir Nikola Tesla purposefully placed his finger beneath the X-rays, and he reported that this radiation is causing burns. So no one took them seriously, and number of people died from this radiation. So this man, this William Rollins, Sir William Rollins, father of radiation protection, credit goes to this person. This person is responsible for all the guidelines which are working right now in our AERB and ICRB in India, as well as internationally. So the question arises, the third question is, for whom we need protection? There are three people, that is operator, patients and the environment. For these three things we need protection. So ICRP established in 1928, and ICRP is International Commission for Radiation Protection, and they have given some certain guidelines and the principles. These are the justification, optimization and dose limitation. Justification says that you should justify to the patient why you are exposing, why this radiograph is required, why you are exposing the patients. You should have an answer. And second principle is optimization, that is ALARA and ALARA principle. Everyone is aware of this, that is as low as reasonably achievable and as low as diagnostically acceptable. And the third one is the dose limitation, that is for operator, it is 50 millisieverts annually and 1 millisievert for the patient. So how we are going to protect these people? So in India, we have a regulatory board, that is AERB, Atomic Energy Regulatory Board. So protection for operator, how we are going to protect operator? Common mistakes. First, हमें पता होना चाहिए कि हम क्या mistakes कर रहे हैं जिसके लिए हमें protection की ज़रूरत है. So common mistakes operator do. So I have a video. I think that's it. वीडियो चल रहा है पूरा दो. It's working fine. So these are the so mistakes we notice over there. There is no partition between two dental chairs. You know, basically in dental setups, in dental clinics, we don't have partitions, most of them, and unnecessary exposure to the second operator, like you can see in this picture. So wrong techniques while shooting the X-ray, like we hold the X-ray tube as well as holding the radiograph with the help of finger. So basically this is contraindicated. So how to manage these problems? So there are 7 steps of managing these problems. So first one is we have to use protective gears with the wear lead apron and thyroid collar. Use lead gloves, and if it is required to use lead glasses also. Always stand behind the lead barrier and metal shield, and follow the position distance rule. If you don't have these lead barriers and metal shield, follow the position distance rule that indicates that you should stand 6 feet away at an angulation of 90 to 135 degrees. And in OPG and CBCT, manage the patient from control room. Do not hold the film or RVG while shooting intraoral radiograph. Usually most of the practitioners hold the RVG sensor with the help of fingers. So we have snap array holders, we have RVG holders, so use these holders. And while doing RCT, while taking the working length, yes, I agree, that requires, so we have endobite holder, you can use that. So do not hold tube head also, as leakage is there sometimes, so you can use gloves. And we have portable X-ray machine nowadays in our clinics. So yes, guidelines says these are meant for operation theaters and emergency rooms and for the emergency purposes. So right now we are using it, but use it precautionally. So sixth one is use TLD batches as they are self-monitoring devices, thermoluminescent dosimeters, and do not enter in radiology working area in inappropriate attire. So what is the appropriate attire is? So, So follow these guidelines. So next is protection for patients. So common errors operator and patient do. So basically we encounter with these problems movement of the patient without protective gears, operator, patient and parents in the dental clinics. So other common errors are the patient is wearing ornaments while extraoral radiography. This causes ghost images and advising radiograph without proper planning. So first we prescribe intraoral radiographs, then OPG, then CVCT, multiple exposures patient is getting. So that is contraindicated. So how to manage these problems with the help of we have three things: before the exposure, during the exposure and after the exposure. So before the exposure you should educate the patient how we are going to take the radiograph, how to hold the handrails, and no movement should be there, and ask the patient to remove all the ornaments to avoid these type of images. Second is during the exposure you require again for patients as well as for the operator lead aprons, thyroid collars, and use high quality of X-ray films, as well as nowadays we are using the sensors. So they are good and they require less exposure. So patient should not hold the film, use a snap array holders, and like we have seen in the video, the gag reflex. To avoid these gag reflex, use mind diverting technique, ask the patient to breathe from the nose, and movement of the fingers, as well as use of local anesthesia spray. After the exposure, it's our duty to proper film handling and processing and proper reading and interpretation of the radiograph. I'm telling you all these things. These are the DCI, all these things are in the DCI curriculum. So we can't skip anything. Like nowadays we are using sensors, I agree, in our dental clinics, but in dental hospitals, this is in the DCI curriculum that we have to use the old method, that is the develop and fixer method. So guidelines for pediatric patients, it is mandatory to use thyroid collar and avoid multiple unnecessary images, allow parents to hold the child with lead apron. And yes, we can use the alternative diagnostic method, that is ultrasound. Guidelines for pregnant dental patients, it is nowhere written that it is contraindicated, but yes, we should use with proper precautions as well as very minimal dose, and avoid taking vertex occlusal radiograph. And lastly is protection for environment. So 5 steps of environment protection is the layout. The layout of your dental setup, your radiology setup should include that the thickness of the wall must be 9 inches. And ARB approved layout of CBCT room. You have to send the ARB layout, this layout to the ARB center, and then the approval comes, then you can form the CBCT room. Separate section for both, for patient as well as for the operator, and that should be coated with lead. Waiting area should be outside the X-ray room, and radiation warning signs in the intraoral and extraoral radiography. Developer and fixer disposal should be mandatory, as well as the quality assurance is the most important thing, that daily basis, monthly basis and yearly basis should be there. So take home messages, that is time, distance and shielding is the key factor in protection from radiation. So thank you for the patience listening. Jai Hind.
Thank you so much, sir. It's a wonderful presentation. Now I would like to invite Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir on the stage. I would like to invite Dr. Bhaskar Agrawal sir for felicitation. Many congratulations, sir. Now I would like to invite Dr. Lakshmi ma'am on the stage. I would like to invite Dr. Lakshmi ma'am on the stage. Many congratulations, ma'am. Now I would like to invite Dr. Nitin Garg sir on the stage. Many congratulations, sir. Thank you, sir. Thank you, ma'am. I would like to invite Dr. Anupriya ma'am on the stage. Dr. Anupriya Tomar ma'am on the stage. Thank you, sir. Thank you, ma'am. So continue with the lecture. I would like to invite Dr. Rajni Nagpal ma'am. She is the professor at Department of Conservative Dentistry and Endodontics at Kothiwal Dental College and Hospital, Muradabad.
डॉक्टर रजनी नवीन मेरा डॉक्टर रजनी साइनोडेंट लिखा होगा नीचे वाला इससे आगे पीछे वाला कौन सा है
बता रहा हूँ एक मिनट में ये मैं भी आपको ये आगे ये पीछे में ठीक है ये पोडियम आपको ठीक उसमें भी लगा दो डिस्प्ले
Very good evening, everyone. Myself, Dr. Rajni from Kothiwal Dental College, Muradabad. I am here to give a talk on adhesion in direct composite restorations. And before starting with the presentation, I would like to thank the organizing committee of CynoDent for providing such a wonderful platform for sharing knowledge. So here we start with the talk. As we all know that what is the most commonly used direct restorative material? This is dental composite. Earlier it used to be dental amalgam, but now due to patient demands we are commonly placing composite restorations in anteriors as well as posterior teeth. Now on what does the success of composite restoration largely depend? Does it depend on the material which we apply, whether composite or the adhesive, or does it depend on proper isolation or on the proper operator's technique? Rather, it depends on the formation of an effective bond with the tooth structure. We must have encountered failures in our life in composite restorations, whether the patient comes back with secondary caries, or marginal discoloration, or post-operative sensitivity, or even dislodged restoration. So now it is very evident that in order to avoid all these problems, we should have a good seal between the restorative material and the tooth structure. And this good seal relies on efficient and stable bonding. Therefore, we need to know about bonding. So what is the role of a dental adhesive? It must connect two different things. On one side we have dentine, while on the other side we have composite. We have already known that dental adhesion is an exchange process where the minerals are removed during acid etching, and this is followed by infiltration of the adhesive. But whenever we are bonding to the tooth, we are bonding to enamel and dentine as two different bonding substrates. Although we are bonding to a cavity, it contains both enamel as well as dentine. So bonding to enamel is very predictable, as the acid etching technique was introduced by Dr. Michael Bunocore. And what about bonding to dentine? Is that so easy? No. Bonding to dentine is really more complicated and more challenging. And we need to take all the headache while bonding to dentine. So enamel is a homogeneous substrate, whereas dentine is not a homogeneous substrate. Why? Because it contains substantial proportion of organic content and water. And most of the bonding is into dentine, therefore we can say that bonding is really challenging. Dentine is an intrinsically wet tissue, and it is this water which creates problems during bonding. So we are bonding a hydrophobic adhesive to a substrate which is hydrophilic. So due to all these problems of dentinal permeability, bonding to dentine has continued to be a challenge. And sometimes we also encounter bonding to deep dentine as well as superficial dentine. And superficial dentine has more permeability as compared to the deep dentine. And besides this, we have limited procedural times, we have varying polymerization rates, and the degradation also occurs once the patient walks away home. So these problems which are associated with water can lead to problems because water is there as a solvent in the composition of the simplified adhesives which we use nowadays. So in a nutshell, we can say dentine bonding is not so easy. We have to think whether to etch dentine or to not, as we have universal adhesives nowadays. And if we etch, how long do we etch for? And what level of dryness or wetness is optimum for dentine? So there are so many things to consider while bonding to dentine. We have already known what are the components of a dental adhesive system. Etchant, which is the conventional phosphoric acid, which demineralizes dentine. Then we have primers, which have both hydrophilic and hydrophobic components. Then we have the hydrophobic adhesive which penetrates to form resin tags. And in addition to this, we have a solvent which we sometimes do not notice because it is there in the composition of the adhesive or the primer. If we consider the modern adhesive strategies, we have either etch and rinse approach or the self-etch approach. And depending upon the removal of the smear layer, we have always seen that adhesives have been classified as either 4th and 5th generation, that is the total etch adhesives, or the 6th and 7th generation, that is the self-etch adhesives. And after this, the latest generation of adhesives which we have are universal adhesives. That is, in this you will have the choice whether you etch dentine or you don't etch. So in the total etch adhesive, smear layer is completely removed and there is formation of a hybrid layer and formation of resin tags inside the dentinal tubules. This etch and rinse technique is time consuming because we have more number of steps. There may be 3-step system or there may be a 2-step system. And there may be bonding techniques variations depending upon how do we remove water after acid etching. If we air dry, we will say it is a dry bonding technique. If we blot dry, we will say it is a wet bonding technique. Plus, there is a problem of technique sensitivity when we are etching because the dentine surface has exposed collagen which is very fragile, which we cannot see with our naked eyes. So this is prone that to collapse and interfere with the application of the bonding agent. So it is very difficult at how moist the dentine should be. An over-dried surface can also interfere with the penetration of the adhesive, and over-wet surface may contain water which can interfere with polymerization of the adhesive. So all these things lead to non-uniform bonding in different areas of the cavity. Like on pulpal floor you may have over-wet region. In the class 2 proximal box you may have over-dry region. So this is the reason for non-uniform bonding. To solve all these problems, self-etch systems were introduced to simplify the bonding procedure, and self-etch systems have less number of steps. They were two-step system or all-in-one adhesives. So in the two-step system, most successful were the Clearfill SC bond, and all-in-one adhesives are like G bond, Clearfill Tri-S bond, I bond. All these can be applied in just a single step. But all these systems have varying acidity because the phosphoric acid is not used. So you may have milder systems or you may have stronger systems depending upon the pH of the adhesive. Now we have multi-purpose adhesives, that is the universal adhesives. Now what is the advantage of using this? The dentist can use them in either a total etch mode or a self-etch mode, or he can do only selective enamel etching without etching dentine surface. So he can apply the etchant only on the enamel. This reduces chairside time and also reduces the technique sensitivity. Most of these adhesives mainly contain water which plasticizes the polymers. So long-term bonding may be compromised. So to avoid this problem, what should we do? How can we improve the clinical longevity so that the patient does not have any problems and we have happier patients? That is, we can use a correct clinical protocol. Now what is that? See, whenever we are bonding, we should look for enamel in the cavity. Is enamel there? If enamel is there, that is a very good thing, because bonding to enamel is really predictable. So if we are doing a class 1 cavity with enamel margins, it's very good. If we are doing class 2 also with enamel margins, that is really good. And if we are doing veneering, again we have enamel. So enamel likes an aggressive etch, so always use phosphoric acid on enamel, whether you choose a self-etch adhesive or a universal adhesive to work with. Etching is to be avoided only on dentine but not on the enamel. And selective etching is the technique which is recommended with all the contemporary newer adhesives, whether they are universal or they are self-etch systems. And besides this, don't forget the basics, that is isolation is important and curing light matters a lot. You should have correct intensity of the curing light as well. And sometimes we notice a lot of post-operative sensitivity, either immediate or once the patient goes back, and after a long time also he complains of sensitivity. So what are the reasons for that we should be clear of? We should not over etch or over dry the dentine surface. That is the most top-sighted reason. And we should evaporate the solvent in the adhesive. If solvent is there, again it will cause sensitivity. We should cure properly. And material related shrinkage can also lead to post-op sensitivity. So the take home message is that you do selective enamel etching because you must be using the newer contemporary adhesive systems. Don't forget to etch enamel, but forget to etch dentine because dentine likes a self-etch approach. So don't etch dentine and follow the proper application protocol. That is, we should not be in a hurry to light cure the adhesive once we have placed. And post-op sensitivity is also almost equal, whether you are using a self-etch system or a total etch system. So don't be bothered that I am using a total etch and this will cause more of post-operative sensitivity. So whenever you are drying dentine, just do gentle air drying. Neither over etch, neither over dry. You can use multiple coats of the adhesives. And while applying the bonding agent with the applicator tip, you can just scrub the adhesive. Scrubbing will help in deeper penetration of the adhesive. And after scrubbing, air dry the adhesive also to evaporate the solvent. And if you air dry the adhesive and evaporate the solvent, it will result in better penetration. This is the step which we always forget, air drying the adhesive. So do the latest generations are the best? Is that so? No, we still have to be careful while using the latest generation adhesives. We still have to follow the protocols or may need some modifications in the protocols which are even recommended by the manufacturers. That is, we have to perform agitation of the adhesive with the applicator tip. A vigorous application is required. And we have to air dry the solvent. Although 5 seconds is recommended by the manufacturer, we can extend that time to 10 to 15 seconds. Like in G Premier Bond, you can see the third step is light curing. And before light curing, you have to apply, agitate for 10 seconds, and we also have to dry for 5 seconds. And for single bond also, you can see that the application time is 20 seconds and air drying time is again 5 seconds before light curing of the adhesive. So all these things have to be taken care of while using universal adhesives, which are the latest generation. And this study shows that, what does it show? That the retention rates are more if an adhesive is applied with agitation or active application is done. And we have to choose our strategy according to the clinical situation which we are in. The simple rule is, if we have mostly enamel, go for total etch. If we have mostly dentine, go for self etch. And if we have dentine with enamel margins, go for selective etch technique. So don't mishandle adhesives, follow the instructions, don't over dry dentine, don't allow contamination. Know your adhesive system means read the instructions carefully. Isolate the tooth and don't be in a hurry. If isolation is spoiled, repeat your etching and bonding. And if we do the procedures rightly, I think we can avoid a lot of endodontic treatment which needs to be done just due to post-operative sensitivity which the patient comes back with. So we need to have happier patients. And yes, no bonds stay forever. Bonds will degrade. So the best we do initially, it will go slower to degrade and will last much longer in the patient's mouth. So thank you all for your patient listening.
Thank you so much, ma'am, such a wonderful presentation. Now I would like to invite Dr. Naveen Manuja, sir. He is the professor at Department of Periodontics at Kothiwal Dental College and Research Center, Moradabad. Over to you, sir.
इसी में लगा हुआ ना, अभी मैम ने जो लगाई थी. ये वाला CynoDent. Good evening, everyone. I'm Dr. Naveen Manuja, Professor, Kothiwal Dental College. So I am here to give my talk on the topic Current Concepts in Pediatric Rotary Endodontics. So in pediatric dentistry, the procedures or the techniques that take less time are of very much importance, because if we take more time in our treatment, then the patient, which is pediatric patient, will become uncooperative. Manual instrumentation with the hand files is widely used in primary teeth, but they have disadvantages that they are time consuming and they can often lead to the fatigue to the dentist as well as to the pediatric patient. So the disadvantages of using hand cave files are they take more chairside time, the canal abrasions like ledges are very much more, they can lead to operator and the hand fatigue, and they can lead to the apical extrusion of the debris, which will cause the periapical pain, and they change the original canal anatomy of the curved canals. So rotary files, they have the advantages of stainless steel files that they are very much flexible, so maintain original canal anatomy. They reduces the procedural errors like ledges and transportations. They have improved the efficiency and they improve the procedure for the root canal treatment in the curved canals. So in cases of the pediatric endodontics, the use of rotary files, they maintain the funnel shaped canal preparation, which will help in the good irrigation. So debris and all the pulse tissues will be removed, and we will achieve a more predictable obturation, which is done with a resorbable paste. These rotary files in the pediatric patient, they follow the original canal anatomy of the curved canals, so this will minimize the risk of procedural errors in the primary teeth. Now here we'll discuss about the design features of rotary files, their metallurgical improvements, their evolution, reciprocate motions, and failures and clinical safety. Since Vollia first of all, he used the nickel titanium file as a hand file in 1988. Now almost 200 file systems are present commercially. Nowadays, night-eye rotary files have gained extensive popularity among the clinicians because they are super elastic, they are highly flexible, and they have shape memory. This night-eye alloy is present in two stages. One is the austenite stage, which is the parent stage, and it's present at the high temperature. And other is the martensite stage, which is the daughter stage, and it is present at the cooler temperature, and R phase, which is rhomboidal phase, which is the intermediate phase. Now this martensite is highly flexible as compared to austenite. So all the efforts are done to introduce this martensite or the M file into the rotary file formation. So we'll briefly discuss about the night-eye design. First is the taper. Taper is the amount of the file diameter increases with each millimeter length of the file from tip towards the file handle. Now all the hand files, they are present in 2% taper, and the rotary files, they have the extensive taper of 6% or the 10% is given. Radial land is a feature of the initial file system. This was a safety feature that was given. It is a supports the cutting edge, reduces the transportation, and reduces the chances of the screwing of the file into the canal, and the file will less separate. Flute is the groove in the working surface which is used to collect the tissues and the dentinal chips in case of the rotary files. Helical angle is the angle that the cutting edge makes with the long axis of file. So always a variable helical angle is preferred because the files with a constant helical angle will cause the screwing effect of the file into the canal, and the more chances of the file fracture will take place. Pitch is the number of the flutes per unit length of the file. So it is always preferable to have the variable pitch in the file. Rake angle, the positive rake angle will lead to the cutting of the root canal, and the negative rake angle will result in the scraping of the root canals. Now evolution of the night-eye files. This evolution is based on their advancement in their file design, their thermomechanical treatments, and their motions. The first generation files, they had positive cutting radial lengths, fixed taper, so more number of the files was required for the cutting purposes, and they have neutral or slightly negative rake angle. Examples are the Profile, Lightspeed, Quantec, and the greater taper files. Profile has 3 radial lengths, U-shaped flutes, and they had the non-cutting tips. Second generation, they have the improvement of the first generation has that there are the less number of the instruments were used for the file preparation, and the active cutting edges were there. Pro taper is a classical example. Other examples are K3 and the race. Pro taper, as the name suggests, these files have progressive variable taper, they have convex triangular structure, and they have 3 cutting points with no radial ends. These triangular cross section will help in highly cutting efficiency, and variable helix angle will resulting no screwing effect of the file into the canal. So they have shaper and the finisher files. 3 shaping files are there, SX, S1 and S2, and the 3 finishing files were the F1, F2 and F3. So the taper will increase from in the shaper files, and there will be regressive taper, or the taper will decrease in the finishing files. S6 file is a very aggressive file with a 19% taper. It is mainly for the orifice opener. S1 has a taper of 2 to 11, and at the tip diameter is of the 17 number file, and at the 14 it is around 120 number file, K file. S2 has a taper of around same 11% and tip diameter of the 20 number K file, and the for D14 the tip diameter will be of the 120 K file. In the finisher files, they will do the cutting only in the apical region. So they from the D1 to D3 the file diameter will increase, but from the D4 to D14 taper will decrease. So S1 they are mainly used for preparation of the coronal 1/3, S2 for the middle 1/3, and finishing file for the apical 1/3 preparation. K3 they have the taper from 2% till 80%. And they have the positive rake angle, and they have 3rd radial end is given for the keeping the instrument central into the root canal. The 3rd generation, there was significant improvement in the metallurgy of the file were seen. Lots of heat treatment were given. Here we found the gold treated files, then the heat treated and the blue files were coming to the market. So various improvement was done in the phase of M wire, R phase, CM wire, gold treatment, blue heat treatment, and the MEX wire. So classical example was high flex and the twisted files. High flex, they are mainly dependent on the CM wire technology or controlled memory technology. They have the triangular cross section, and they provide around 300 of the file resistance against fracture. Twisted file, these are the only files that will twisted, like the hand files are done with the twisting of the fluids and not by the grinding. So they are mainly depending on the R phase. They have the triangular cross section, no radial ends were there, and they have the safe cutting tips also. 4th generation, in the 4th generation the concept of the reciprocation came. The examples are the wave 1 and the reciproc. Reciprocation is defined as a back and forth movement. Earlier, all the reciprocating files, they have the equal clockwise and the counterclockwise direction. But in 2008, Yared, he identified as the unequal clockwise and counterclockwise angle that will result in the cutting efficiency of the file. So in earlier, the Rowan he used the balance force technique, and they first reported the hand file into the watch winding motion clockwise counterclockwise, and then the hand files were used by the M4 endo, and later on Yared in 2008 he first used pro taper F2 in the reciprocation, and nowadays so many files, they are the single file system are there, they can be used as the reciprocating files. Advantages of using this reciprocation in the pediatric dentistry is that very less number of the instruments are used, the time taken is very less, they will reduce the file fracture into the canal, torsion and the flexure stresses will be reduced, they will be, original canal shape will be maintained, and there will be less cyclic fatigue of the files into the primary teeth. So wave 1, they have the reverse balance force technique, and here the counterclockwise angle and the clockwise angle is not equal. So they have 170 engaging angle and the 50 degree is the disengaging angle. So they are mainly made up of the M-wire technology. This will increase the flexibility, and this will reduce the cyclic fatigue of the files. So we have mainly 3 files. They have the 2 distinct cross sections. For the smaller file canals, we can use yellow, that is 21 number, and for the majority of the files canals, we use 25 number file, and the large for the black one for the large canals. Reciproc is also a reciprocating file that is also made on M-wire technology. So here we have 3 files, 25, 40, and the 50 number files. Again, here the counterclockwise angle is more, that is 150, than the clockwise angle. So benefits of the reciprocation is that they are shorter working time, they are very much simple, they reduces the file fraction to the canal and reduces the number of the file. With only one single file, we can prepare the whole canal. The last generation is the fifth generation. Here the concept of offset design came. If the center of the mass and the center of rotation are not at the same point, it is offset. This reduces the touching of the file into the canal. There will be only 2 point touching of the canal. So this is the 2 point touching of the canal of the file in the canal. So there will be production of the swaggering motion of the canal. So there will be less screwing of the file into the canal and the less separation. So ProTaper next is example of this fifth generation. They have from X1 to X5 files are present, and due to this offset design, swaggering motion is produced of the file into the canal. So this will minimize the contact of the file with the dentine, decrease the screwing effect, and reduces the dangerous taper lock and the torque on the canal. So this is a summary of all the canal systems. Now pediatric rotary file system. Since very long we are using the files that are usually designed for the permanent teeth. They have long taper and their long length. Because the pediatric patient mouth opening is very less, so it is always requirement of a file with a less length and less taper. Because if the taper is more, then they will cut the more dentine, so the perforation will be more. So exclusive pediatric files are available. These are certain commercially available pediatric exclusive files present. So Kido S is the first generation files. They have the 16 millimeter length and with only 12 millimeter cutting blades. They are made up of nickel titanium with triangular cross section and non-cutting tip, and they have the negative rake angle with variable taper. So they have the 3 files, D1, E1 and U1. D1 is usually for the narrower canals like the mesio buccal and the distrobuccal of the maxillary teeth, and the mesio buccal and the mesiolingual of the mandibular teeth. E1 are for the wider canals like the palatal canals of the maxillary teeth and the distal canals of the maxillary teeth, and U1 for the anterior teeth. Second generation are the Kido SG files. They are similar to the Kido S file, except that they have heat treatment has been done and they are based on the M wire technology. Third generation is the Kido SG blue. Here the blue heat treatment is done and the blue titanium oxide layer is formed, and they have greater flexibility and increased resistance to cyclic fatigue. Kido S square is the fourth generation of the Kido files. They have dual cross section in a single file. Apical, they have triangular cross section, and the coronally they have the teardrop cross section. They have 2 files, A1 and the P1, A1 for the anterior teeth and P1 for the posterior teeth. Another file system is Pro F Baby Gold. They are mainly made on the nickel titanium control memory wire, and they have the 17 millimeter length, and they are present in 4 and 6%. Blue Baby files, they have the single file rotary system. They have S-shaped cross section, and they have the comfortable 17 millimeter length. Neo Endo Pedo Flex rotary files, they have 3 files are present. They have 60 millimeter in length, and the taper is 4%. 20, 25 and 30 number files are present. Despite various advantages of these rotary files, their failure of the nickel titanium rotary file occurs in the root canal. That is their separation on the fracture. 2 types of the fracture occurs. One is cyclic fatigue and the torsional fatigue. Cyclic fatigue is that when they continuously force on the file, and the force will bend and ultimately it will fracture. Torsional stress is that if the tip of the file is engaged or screwed into the canal and the shaft is continuously moving, then this will lead to their fracture. Now these are the certain strict guidelines to minimize their file fracture and maximize the file safety. First is that always you should have a glide path before your rotary files. This glide path can be done with the help of a hand K10 file. When you achieve a super loose hand 10K files, then only you can proceed with your rotary files. Second, you should not force your file against pressure. If you find any resistance of the file, just retrieve it back, then again irrigate it, and then use the hand file, and then you again use the rotary files. Recapitulate frequently. Use the hand files or one number less than the file used in between rotary files, and then you use the rotary files. You should always follow good irrigation protocol. You are using sodium hypochlorite or EDTA, and that will be followed by the saline as a final flush. You frequently clean your flutes of the files and frequently inspect the file flutes. If you find any band in the files, then that file should be rejected. And you should use only the files for once, because it is always recommended commercially that these files are for only single use. So to conclude, I would like to say that night eye rotary files are definitely promising in pediatric dentistry because they save time, cause less fatigue to the dentist as well the patient, create conical shape suitable for 3-dimension obturation, and minimize the occurrence of procedural errors. Clinicians need to be aware of that have been the recent advancement in night eye files, what are the changing in design features and metallurgy, so that they can make a wise decision, and thus the teeth which have been endodontically treated should last long into the oral cavity. Thank you. Huh? अच्छा.
Thank you so much, sir, for wonderful presentation. We have to wait for a few minutes due to some technical issue.
दबाना देखो
So, our next speaker, Dr. Siyok Sawant sir. He is the head at Department of Public Health Dentistry at Bharati Vidyapit Dental College and Hospital, Navi Mumbai. I welcome you, sir.
Good evening, everyone. Today I'm here to present on qualitative study. Thank you for having a full audience. I'm the head of the Department of Public Health Dentistry, and I'm here to present you a topic on qualitative study. Well, when we talk about the qualitative study, it's something somewhat different than the studies that we normally conduct. Most of us are involved in randomized control designs, the quantitative studies, the crossover designs. But this study is somewhat different from it because of certain reasons. Now, this study is not based on any empirical data or literature search or anything like that, but it starts from the scratch. So the modules of the qualitative study are, first one is the participant observation, the second one is the in-depth interviews, third one is the focused depth discussions, and finally the data documentation and management. So what does qualitative research deals with? It basically deals with the values, opinions, behaviors, and the social context of the people or the subjects whom we are trying to investigate. It helps us or seeks to find out the perspectives or even what the conclusions that the people draw of certain situations. So what is qualitative research? It is a type of research or the scientific study in which the investigator tries to seek the answers. It uses a predefined set of procedures to answer the question, and it collects the evidence. It produces the findings, and finally the findings at the end of the thing are compiled into a data form. So first one is the descriptive part, in which the certain situations, settings and processes and relationships are discussed. Interpretation, which helps us to gain new insights about the problems. The verification or validation of the facts is done about the assumption, theories, and the claims within the certain real-world context. And finally, the evaluation, in which they try to find out the effectiveness of the particular findings of the people. So what are the uses of qualitative research? It basically deals with the complex textual descriptions, The second one are they deal with the contradictory behaviors, beliefs, opinions, emotions, and the relationships of the individuals. And the third one are the social norms, socioeconomic status of the people, the gender roles, the ethnicity, and the religion, how they influence the study. So the types of qualitative research, the first part is the participant observation, in which the investigator or the person who's trying to investigate the cause is just a silent observer. The second one are the in-depth interviews that are conducted along with the people who are participating in the study with one-on-one. And the third one are the focus group discussions. The forms in which the qualitative data are collected are in the types of field notes, the audio or video recordings, the transcripts have been made or they're recorded, written down, and they are segregated into the different domains. So what are the differences between the qualitative and quantitative research? First one is the qualitative and quantitative focus. Qualitative study deals with some of the features which cannot be measured in numerical forms. The methodology is observation of the individual or the observation of the participating people. The third one is understanding the goals of the study and the objectives. The design is flexible and it is not structured or predetermined like it takes place in clinical trials or randomized controlled trials. The sample size is small and purposeful only for the reason because it becomes a very tedious process to go on with the maximum population. Fourth one, the data collection is in the form of interviews, observation, documentation of the facts, as otherwise in quantitative study, it's about the questionnaire tests, scales, and inventories. The analysis is done by the researcher in qualitative study, while in quantitative study, statistical tests are applied. Finally, the findings are detailed explanation of the transcripts in which the answers are divided into different domains. And finally, the researcher draws to a conclusion as it takes place in quantitative study. So in case of sampling in the qualitative research, three types of sampling are mostly conducted. One is the purposive sampling. Purposive sampling is selecting the population in where you want to proceed with the study, whether subjects are in a position to answer your questions. Quota sampling is something division of the groups of or collecting, selecting a certain type of population in which characteristics of the people are predefined so that they'll be able to answer the questions. And the finally is the snowball sampling, in which we ask one participant and he gives us the reference of the other participant. When we talk about the ethical guidelines in the qualitative research, informed consent is taken from the participants. It has to be kept confidential. Then it should be in a language which the participants do understand, and it possibly takes place in front of the witness or the observer. Second one is the module 2, which is the first step of qualitative research. It is a condition in which the participant observation is done. So basically the objectives and perceptions of the study have been determined. Just by observation, we tend to understand what are the social norms, custom, traditions of the people, how they approach the problem, and we are being just a simple observer in the study. What we observe during the participant observation are the appearances, verbal behavior, interaction of the people, the physical behavior and the gestures, personal space, the people who come in and out of the study, and finally people who stand out for. The reason we do participant observation is just to know the know-how, because only for the reason that when we start with the qualitative study, we do not refer to the empirical data. The study has been started out from a scratch. We do not have any literature knowledge about the study. So that is the main reason the participant observation has been done. What it includes is the field book, the notes have been recorded, informal conversation and interactions are recorded, and use of mass media such as radio or television has been done. What are the advantages? It helps us to understand the participant perceptives and objectives, understanding the behaviors of the people and the activities of the people. The forms of collection of data is with the help of field notes, maps, and numerical data. The tips for taking the field notes are, we record the date, time, place, and type of data collection event. We leave no space on the page. We take the note strategically. We use the shorthand basically to record the notes, and we have a range of observations. In the third part, that is done is the in-depth interviews. In in-depth interviews, a vivid picture of the participants' perspectives has been recorded. It takes place in one-on-one condition, and about the person is interviewed for around 30 to 45 minutes. The perspectives of the individuals are recorded. The effective qualitative method for getting the people to talk about their personal feelings, opinions, and experiences are gained. Recruitment, the responsibilities of the primary investigator. They help to recruit the participants who are willing to give the consent or who have the knowledge about the study. They set up the recording equipments and physical space where the interviews have been conducted. Finally, the knowledge about the person is, or the subject is recorded. The informed consent is obtained, the open-ended questions are asked, and the interviews is recorded. The notes are basically drawn from it, which are very important ones, so that the conclusions or the domains of the study can be drawn. And points to remember for the in-depth interviews are we outlined the policies and the strategies. Only one investigator is allowed to conduct the interview. Open-ended questions are again asked. Half an hour is the time that has been allotted to the investigator, half an hour to 45 minutes. In case where the interruption occurs, the tape recorder has been stopped, the transcripts have been stopped, and again the interview has been recorded. People who choose not to complete an interview, they can be discarded, and the transcripts are discarded, and in such a case, the investigator is made to destroy the tape, interview guide, and any notes that have been taken. People who are excluded are again with the people who have less knowledge. Documentation of the interview is made by making tape recordings or writing field notes, and if the recording equipment fails, the notes have to be re-recorded or backup has to be drawn. So what are the types of questions that are needed to be asked? Are unbiased questions. Do not ask leading or direct questions. Ask one question at a time. Ask open-ended questions and verify the unclear responses of the participants. The questions that are not to be asked are the leading questions, closed-ended questions, and multiple questions at a time. The fourth module consists of the focus groups. In this focus groups, we come to know about the perspectives or the thinking or the social norms of the community or the subgroups, as well as the range of perspectives that are to be drawn. Focus groups are often used to determine what service or product a particular population wants to have, such as in marketing studies. Focus group discussions helps us to know the group opinions. Several participants are recorded in which when the focus group is conducted, about 10 to 12 participants maximum participate in the study. The sessions are usually recorded. The researcher is the person who asks the questions, and there's a person who records the entire interview. The users are the questions they need to go back where they need to complete more information. During the debriefing sessions with other field staff and investigators, they might come out with the new perspectives or the answers from the people who are participating. And during transcription of the focus group recordings, clarification of certain thought processes of the people can be done. The functions of the people who are recruited are the facilitators who control the population, the moderators, who is the one who goes on with the investigation. The third one is he's the one who should act as a learner, and he moves the entire discussion in a proper manner. There are also note takers who take out the transcripts or write down the notes, or the detailed recording of the notes have been taken. The logistics of the participants' arrival and departures, such as the early withdrawal or dropouts, are maintained by the note takers. Some of the other functions are the recruiting the participants, answering any questions which the subjects have in advance, and being reliable. The points to remember are 8 to 10 people or a maximum of 12 people can participate. Individual participants should be identified in the notes by means of some convention, and focus groups should be conducted in a location affording a maximum degree of privacy to the participants. What are the remarks, manner of speaking, and body language of the people? It has to be recorded, and usually the focus group discussions last for about 45 minutes. Participants who do not choose to answer can be excluded. Participants who do not have any knowledge and just came for the sake of participation have to be dropped out. And if a focus group discussion is interrupted, any steps have to be taken in order to protect the confidentiality of the participants of the study. So, some of the small things which open with a general comment, invite a wide range of commentary, use silence to your advantage, limit your own participation and ask the subjects to speak more on the topic. So these are the ones which focus on the focus group discussions. And finally comes the data documentation and management. So whatever the thoughts and the experiences or whatever the differences that the subjects have, they have issues regarding that or the perception is regarding a certain topic. Everything has to be documented with the help of recordings. The recordings have to be transcribed on the transcripts. After we reach a point where maximum, of course, we use the primary source of data and secondary source of data to record the responses. But once, after the action is taken, evaluation is done. How the evaluation is done, whatever the tapes or the transcripts or the recordings that we have, we divide it in different categories. And once we divide it in different categories, once we start getting the same amount of answers and the responses in repetition, we stop our study and then we basically draw to the conclusion of the study. Now this is one of the example in which archival things are done, where site of the study, the data collector's name, the date of collection of data, how the method was used, transcriber, translator, the names of the people are recorded, and the data of the computer data entry is being made. So basically the raw data that we see goes into the organization, then pursual is done, in which overall sense of the study has been is found out, the classification or the domains are done, the synthesis or the evaluation of the study is done, and finally the report has been made along with the drawn conclusions. So basically steps what we should do after collection of the data is the data is parked in the centralizing data or kept all together in one place. One large heavy duty archival envelope per event with archival information sheet is placed. Backup of the copies of the study is important to be kept, and that's how the study is conducted. Thank you so much.
Thank you so much, sir. Now I would like to invite Dr. Tanvi Saraf ma'am. She is the reader at Department of Pediatric Dentistry at Bharati Vidyapit Dental College and Hospital, Navi Mumbai. Over to you, ma'am.
A very good evening to one and all. So today I'll be talking about a very important aspect of pediatric dentistry, which I consider the backbone of pediatric dentistry, which is the application of the basics of psychology and behavioral learning theories to the pediatric dental practice. Now, in the 9 years of my experience in academics, I've seen that students are very scared of pediatric dentistry only because they're unable to predict the nature and the behavior of the child. Now, in adult dentistry, you develop your skills. In pediatric dentistry as well, you need to develop your dental skills. But at the same time, if you can't get the patient to cooperate with you, what happens is that even if you're very skillful, you cannot accomplish a good treatment plan. All right, so it's very important for you to understand what is going on in the child's mind, and so that you can render your treatment as according to what's he thinking, what's he going on. Hence, in pediatric dentistry, it's very important to understand what is going on in his mind. All right, so in this presentation, I'll be looking at a few questions that arise in your mind when you start your pediatric posting. All right. So the first question is that why is my pediatric patient fearful for me in the first appointment? So probably this patient is seeing you for the very first time. He's coming to the dental clinic for the very first time, but he's very scared. So you wonder what is the reason. So the reason could be simple as fear of the unknown. So the dental clinic, the environment, the smell, the sight, everything is very new to the child, so he doesn't know what to expect. So he could be afraid because of the fear of the unknown. So what's the solution for this? We have non-pharmacological behavior management techniques like Tell-Show-Do. So basically in Tell-Show-Do, you will familiarize the child with the dental environment, the instruments. You will show him the instruments, get him involved, all right? And there is a slight modification to this Tell-Show-Do, which is Ask, Tell, Ask, where you can ask children what they feel about dentistry, what are their doubts, and then you can solve those doubts. So this goes on until the child gets completely familiarized with the dental environment. So, see, understand that the mother plays a very pivotal role in the life of a child. So, say if the mother of the child has been through an adverse dental, experience. So, what happens is that even if the child himself has not been to the dentist, he has probably heard his mother talk about her traumatic experience. So, what happens is now the child is automatically afraid of the dental experience. So, what's the solution for this? Is that even before the actual appointment happens, what you can do is, send certain emails or WhatsApps, giving a certain preview of what's going to happen in the appointment. And basically, your idea is that the mother should be stress-free. She should feel that my child is in good, trustworthy hands. So you can engage in, sending emails, WhatsApp messages, something of that sort beforehand, okay, before the actual treatment happens. Then another reason for the pediatric patient to be afraid is the white coat phenomena, which was given by Ivan Pavlov from the classical conditioning theory way back in 1927. So what is the white coat phenomena? So you have to understand that the child visits the hospital or visits his pediatrician before he visits you, the pediatric dentist, right? So probably he went to the hospital just because, he had to get some shots or, immunization, and he was unwell. So the child has now associated that pain associated with the shot, or, the illness or the fever that happened after the immunization with the white coat. So when he sees you wearing a white coat, he associates that fear with you, okay, even when he's seeing you for the very first time. So the reason could be as simple as your white coat being the problem. So what is the solution for this? So what you can do is that when the child comes to you, you can engage in sort of, meditation, deep breathing, muscle relaxation, and slowly talk to the patient about the dental treatment that's going to happen. But this is a little impractical because you don't have so many appointments, on the dental chair. You can't have a patient sitting and, meditating. So that's a little impractical. So a little modification to that is preventive desensitization, wherein what you do is that I'll explain with the help of an example. If the child comes to you with a deep carious lesion and there is pain, so what you do is that first, obviously, you give him medication to relieve the pain. Then, immediately you don't start the invasive treatment. Like you don't start giving LA and, extraction or pulpectomy. You don't do that. What you do is that after giving him pain medication, probably take x-rays, probably do a small GIC restoration with hand instruments, slowly introduce the air rotor, or just do scaling, okay? And then probably in the third appointment, now you address this issue of the chief complaint of, giving LA, doing pulpectomy or extraction, okay? So slowly you can move on to the intensity of the treatment. So basically the idea behind this is that let the child trust you and let him develop a bond with you, and let him not feel that, he's just come into the dental clinic, as a punishment to get some work done, all right? So the next modification could be like, as I told you, the child visits the hospital before he visits you in the dental. All right, so let's continue. So as I told you, the child visits the hospital before he visits you in the dental clinic. So what you can do is that, so that the child doesn't associate all his, fearful experiences of the hospital with your dental clinic, you can make your dental clinic not look like a hospital. So this is how our department in Bharati Vidyapeeth, the Department of Pediatric Dentistry looks. So it's colorful, there are a lot of cartoons, there are toys for the child to play with. So this in no way looks like a hospital. Then the dentist attire. As we've seen, the white coat is what the child associates the fear with. So what you can do is that, as you can see in this picture, I'm not wearing a white coat, I'm wearing a pink color coat. In the next image, you can see all our PGs working, wearing lavender color or pink color scrubs instead of the usual white coat. So the next question that would come to your mind is that, how do I make my child patient trust that this dental treatment is nothing to be afraid of? See, sometimes a child comes in with a small GIC restoration, you know that it's like a 5-minute procedure, but the child is so afraid, okay? So now how do you make this child understand that it's, nothing to be scared of? So the answer lies in the social learning theory, which is given by Albert Bandura. So what does Bandura state? He says that we are constantly learning. So even when we are not taught by someone in a lecture probably, we are constantly learning because we are observing the environment, the society around us. The society is teaching us something or the other all the time, whether we know it or not. All right, so this is what is a social learning theory. So I'll give you a few examples from our everyday life. So you must have seen such hoardings which are put up by the traffic police, okay? So when you look at this hoarding, immediately you understand that, we must not talk on the mobile phone while we are driving, because it could be very fatal. So immediately when you see this hoarding, you don't look at the phone, okay? So this is like a positive teaching that is given to you by the society and the environment around you. Then again, you also have certain advertisements like, like these popular cold drinks which say that dar ke aage jeet hai. So you just have a Mountain Dew and you just go jump off the cliff and everything is going to be fine. So if you have this mentality and if you go for your exam unprepared, okay, and you have a Mountain Dew that everything is going to be fine, so let me tell you, it's not going to be fine. So a lot of messages are there in the outside world around us, and we are constantly learning, but we have to make sure that we are learning the right thing, okay, not something like that. So how is it adapted into dentistry? What you can do is a behavior management technique called as modeling, okay? So maybe you have a patient who is not so cooperative and you have a patient who is cooperative. So maybe let your non-cooperative patient observe this cooperative patient, okay? So you're not telling the child what is right, what is wrong, nothing. He's just passively observing. So he's going to understand that, it's nothing to be scared of, okay? So this is his application in dentistry. So your next question that comes to your mind is that my patient is cooperative today, okay? How do I make sure that tomorrow and the next appointment he's going to be cooperative, okay? What do I do? So now the answer lies in the operant conditioning theory, which is given by B.F. Skinner. So now this theory, understand, has two components, okay? Reinforcement and punishment. So what is reinforcement? See, now understand that reinforcement means like there is a particular kind of behavior and that behavior remains the same, doesn't change. In fact, it could even become better and stronger, okay? So that is reinforcement. So there are two types of reinforcements, positive and negative. So what's positive reinforcement? See, now if there is a behavior, say a good behavior, and there is an event which occurs after it, what does the person understand? That because, I had a good behavior, that is why, this good event happened, so I'm going to continue with my good behavior, okay? So I'll explain this with the help of an example. Say a child has studied well in his exam, so he fares well, he gets an A+, and then he is rewarded by the teacher or the parent, okay? So that is positive reinforcement. But don't confuse this with bribery. If a child is told that, you study well and only then I will, give you a mobile phone or a PlayStation and things like that, and if he studies well, then he's given a PlayStation. No, that's bribery. That's not positive reinforcement. That's not allowed. Okay, you have to engage in positive reinforcement, wherein you are not telling beforehand what rewards are you going to give to the child. Let the child behave well, do well, and then you reward the child. So he automatically understands that now if I behave well, all is going to be good. So what is negative reinforcement? So you need to understand that if there is a good behavior and something bad is removed, then what you understand that I must maintain this good behavior. So again, I'll explain with the help of an example. Like you have a child who comes to you with pain, okay? He sits on the dental chair, completes the treatment, and the pain goes off, okay? There's no pain, he's comfortable. And you tell him that, look, because you behave well, see, the bad pain that was affecting you went away, okay? So now what does he understand? He understands that because I behave well, that bad event went away. So this is negative reinforcement. Now don't confuse this with positive reinforcement. Here, if the child was rewarded after that good behavior, then it would have been positive reinforcement, okay? So that is that. Then also negative reinforcement is that when there is a bad behavior and say the child is allowed to escape or avoid the consequence, then he understands that, I'll continue with the bad behavior. So again, I explain with this with an example. Look, if there's a child who's throwing a tantrum in the dental clinic, okay, and you get frustrated, your tolerance level has reached and you let the child go. So now you feel you'll do the work in the next appointment. So what happens in the next appointment, the child understands that, okay, I threw a tantrum last time, so now this time I'm going to do the same thing and I'm going to run away. She's going to let me go away, okay? So now what happened? The previous behavior was strengthened. Why? Because you let him avoid the consequence, okay? So that is negative reinforcement. So what's the solution for this? Don't let the child run away. So even if you have planned a pulpectomy, at least do a simple GIC restoration, do some work. Let the child understand that, there is no escape. All right. So again, if we go back, reinforcement is something which, an event which strengthens the current behavior, okay? Now the exact opposite of it is punishment. Punishment is when your actual behavior, the previous behavior stops or doesn't continue, okay? Something that happens because of which you understand that my previous behavior should not continue. So that is again of two types, positive and negative. So what's positive punishment? See, if there's a bad behavior and a bad event is added, something bad happens after it. So you understand that I must not continue with that behavior, okay? Again, explaining with an example, if a child is, throwing a tantrum in the clinic and you scold him, okay, you yell at him, and now the child gets really scared and he understands that, oh, she shouted at me because I was behaving badly. So next time I will not behave badly, okay? So again, let me tell you, this is prohibited, okay? This is not a behavior management technique. It's completely prohibited. Scolding the child, insulting the child, comparing the child with another child, okay? So all that is prohibited. However, you need to understand so that you don't make that mistake.
I request all the delegates, please stay because we will start with felicitation. We have one more lecture. I would like to invite Dr. Priyanka Singh ma'am. She is the additional professor at Department of Oral Pathology and Microbiology at KGMC Lucknow.
Good evening, everyone. First of all, I would like to thank the organizing committee for inviting me as a keynote speaker. The topic of my presentation is Detection of Early Oral Cancer and Update. As we all know that oral cancer occupies the 6th position in the overall incidence among the 10 most common cancer sites in the world, and it is 3rd in the developing countries. And now it has become so disastrous that in India, approximately 75,000 to 80,000 new cases are occurring every year. And in India, one person is dying of oral cancer every 7 minutes. Now, there are various clinical examinations that can be done, but a clinician must have a keen observation on the diagnosis of early oral cancer and precancerous lesions so that it can be detected early, because early detection of oral cancer leads to early treatment of the lesion. There are various tests, among which first is clinical oral examination. There is recognition of varied clinical presentations of pre-malignant and malignant lesions, but there are some limitations with this procedure. That is, it can give the false positive results and usually it is overdiagnosed. To overrule this, we can do the vital staining on the tissues. It is done on the vital tissues to differentiate between the normal and abnormal epithelium. And this can be done with the help of toluidine blue, Lugol's iodine, methylene blue, and many more vital stains are there. And the principle behind the use of toluidine blue stain is that in the dysplastic epithelium, what happens? There is more of mitosis, so more of deoxyribonucleic acid. And as it is acid in nature, and the toluidine blue is a basic dye, so there occurs an acid-base reaction. And because of this, the dysplastic tissues take more of the blue stain in comparison to the normal cells. Similarly, the normal epithelial cells have got more of glycogen content, as we all know. The Lugol's iodine has got the affinity towards the glycogen, so it stains more of normal epithelium in comparison to the dysplastic or atypical cells. So, the Lugol's iodine, it marks the borders and denotes a preferred area for the biopsy. And this technique is sensitive, simple, non-invasive, and very cost-effective technique. 18 to 20 minutes. That's all. Another non-invasive technique is use of salivary biomarkers. We know that more than 100 salivary biomarkers are present, like alpha amylase, interleukin 8, tumor necrosis alpha, statrin, and many more. But there are some limitations with this test also, that there is absence of calibration for saliva collection, and also there is variability in processing and storing in different labs. Next non-invasive technique can be elastic scattering spectroscopy. This generates a spectrum dependent upon the wavelength. As we can see in the picture also, it shows changes in the structure and morphology of the tissues at scattering centers like chromatin, nucleus, lipids, etc. But again, the limitations are that it lacks of tumor margin detection is there, and also this process is time consuming. Next, Visilite is very much used in clinics nowadays. This uses a non-toxic chemiluminescent light, which is when shined in the mouth, abnormal tissue glows differently from that of the normal tissue. And the physics behind the Visilite technology is that normal epithelium absorbs Visilite and so appears dark, and abnormal epithelium reflects Visilite, so appears white in color. Next technique is photodiagnosis. In photodiagnosis, there is natural autofluorescence of the background of the concerned tissue is being used, and there is distribution of fluorescence from the fluorochromes which are already present in the normal tissues. Advantages of this technique are that high quality digital images can be obtained, and also it quantifies the fluorescence intensity of the diseased tissue. Another method is surface enhanced Raman spectroscopy. As we can see in the picture also, that the incident light is focused on the tissues and light is absorbed by the certain molecules in the tissue, and then it is scattered back. And this scattered back incident reflected light is then captured by the detector, and then it is analyzed by the computer system. This technique is sensitive. It has got high specificity, but again, it requires expensive equipments, and also there is lack of spatial information. So it is mainly used in the higher centers only because of its cost. Next technique is optical coherence tomography. It uses near infrared light to capture the micro-resolution, three-dimensional images from within the optical scattering media, like the tissue specimen. Cross-sectional subsurface tissue images are obtained. It has got high resolution, and it is a minimally invasive technique. Next is the use of bio-nanochip. This is used in the molecular diagnosis, and this principle is based upon the pharmacogenetics, pharmacogenomics, and pharmacoproteomics. It includes quantum dots, carbon nanotubes, paramagnetic nanoparticles, and also gold nanoparticles can also be used. This emits light and are applied in cancer imaging studies. It has got high sensitivity, but has got high cost, and there is low biocompatibility with the normal host tissues. A slightly invasive technique is oral exfoliative cytology. This is a microscopic examination of the shed cells from an epithelial surface, and the diagnosis must be confirmed by the biopsy and not solely by the oral exfoliative cytology. Its application as a diagnostic technique has been limited because of occurrence of false negative results. Because of thickened keratinized surface, as we know, it mainly occurs in the dysplastic lesions. When we see under the microscope, it gives results which are categorized into normal, atypical, indeterminate, suggestive of cancer, and positive for cancer. Next, slightly invasive technique is oral CDX test or oral CDX system or the brush biopsy. It is a highly specialized computer-assisted analysis of an oral tissues, and it is so specific and so sensitive that it can detect as few as 2 abnormal oral epithelial cells scattered among more than 100,000 normal cells on a biopsy specimen. Next technique is liquid-based cytology. The tissues or the cells which we obtain from the cytological smears or the brush biopsy, these sample is poured into the liquid solution, that is usually a polymer solution. Then this whole solution is centrifuged and a layer of separated epithelial cells on a glass slide are obtained, and then these are processed, stained, and examined. This provides uniform smear thickness as it usually occurs from a liquid solution. It is a simple technique used in screening programs. But in this expensive automated devices and materials are being used, which increases the processing cost, and that is a slight limitation of this technique. Next is confocal in vivo reflectance microscopy, which is also very slightly invasive, or we can say non-invasive also. It consists of a light source, condenser, objective lens, and a detector. In this, detailed images of the tissue structure and cellular morphology are obtained by the mechanism of backscattering. There is a focused beam of light passes into a small spot at chosen depth, which is usually uninterrupted, and natural differences in the refractive index of the different structures are obtained, but the limitation is that it examines only a very small area. Next, the hallmark of the diagnostic test is a biopsy. It is a controlled and deliberate removal of the tissue from a living organism for the purpose of microscopic examination. And this is usually, most of the times, it is a confirmative test for detecting the altered cells. An adjunct to biopsy is the immunohistochemistry. If we don't get the results in H&E sections, we can do the immunohistochemistry in this. This identifies the cellular or tissue components using antigen-antibody interactions, and there is direct labeling of the antibody, or by secondary labeling of the antibody can also be done. This is usually compatible with the conventional fixation processing and embedding procedures that we usually do in the laboratories. Next, further adjunct to this is polymerase chain reaction. This formulates thousands and thousands of copies of a particular DNA sequence. Like suppose if we get a very small tissue, and then also we get a very small DNA particle or molecule also, then that can be replicated to thousands and thousands of times unless it gets detectable. Okay? And this process is usually used for DNA sequencing, functional analysis of genes, identification of molecular markers, etc. Like in this picture also we can see a very small molecule of DNA is getting replicated many times unless it gets detectable. Next technique is flow cytometry. It measures physical and chemical characteristics of cells as they pass one by one into a fluid stream by a beam of light. And scattered and fluorescent light is directed to a set of photomultipliers, and the intensity is then measured by electrical equipment. This can be done for assessing DNA aneuploidy, in assessing the number of abnormal cell lines, cell cycle fractions, and also in detecting the loss of heterozygosity. But this method is expensive and it requires high current levels. So this is also usually done in the higher centers. Next is DNA polyploidy analysis. This is also a hallmark for the targeted treatment of cancer and precancerous lesions. This is a genetic alteration that refers to change in the chromosomal number, predicts the character of the premalignant lesion, avoids intra and inter-observer variability in grading of dysplasia. This is the benefit of this. And also directs the targeted treatment of the lesion, because exactly we know the genetic molecule where the mutation has occurred. Next technique is microarray. There is quantitative study of messenger RNA. In this, expression of multiple genes can be done at the same time. This is two-dimensional array on a solid substrate. It detects pre-cancer and cancer, helps in performing guided biopsies, deciding drug dosage during chemotherapy, and many more functions are there. Next is photoacoustic imaging. It uses optical illumination and ultrasonic detection, produces images of deep tissues depending upon their light absorbing capacity. It is enhanced by contrast containing gold nanoparticles, which can be conjugated to monoclonal antibody also. Next hallmark, as we all know, that it is tumor markers. Tumor markers are defined as the biochemical substances which are synthesized or released by the cancer cells, or these are produced by the host in response to the cancerous substances and are used to monitor or identify the presence of a cancerous growth. These can be present in blood circulation, body cavity fluids, cell membranes, and cell cytoplasm, and this can be of value in predicting the lesion behavior. And this is very much in use nowadays. Next recent technique is use of artificial intelligence. That is, it approaches to enhance the image-based diagnosis. It has got two types, deep learning and machine learning. Deep learning networks rely on the layers of artificial neural networks to generate their own categories, and the machine learning networks typically demand an accurately categorized data input. Efficiency of automated cancer diagnosis has significantly increased with the use of artificial intelligence owing to invention and improvement of the convolutional neural network. This can assess complicated images quickly and offer assistance on decision making. So these were the conventional diagnostic techniques for the detection of early oral cancer and precancerous lesions. There are some future perspectives and future diagnostic tests also that are in the panel at present that we can expect in future. This is use of chip laboratory. In this, microfluids, micrototal analysis systems, or lab on a chip process involves incorporating the steps typically performed in an analytical laboratory onto a single device or a chip, and then automating and miniaturing the whole procedure. By this, the oral precancerous lesions and dysplastic cells may be identified with this chip by the expression of membrane-associated cell proteins, which are mainly present on the cell membranes of the cells. Next, which is also in the panel, is nuclear magnetic resonance microscopy that we can expect in the future. And through this cutting-edge diagnostic tool, a pathologist may investigate the tissue's cellular architecture, examine individual cells for mutations in the genes and that regulate their development and function, and identify the disease-related biomarkers. And this procedure will make it possible to see individual cells in live tissue in 3 dimensions without harming the normal tissues. Next procedure that is yet to come is a dried blood spot. It is at present it is being used in the intestinal tissues and all in surgeries, but it is to be used in the oral tissues. This is a dried blood spot is used as a specimen for the test, and this process involves breaking down this protein into smaller building blocks called peptides, which are subsequently measured by a mass spectrometer for diagnostic purposes. And this taking a blood sample is easy and quick. That is why it can be very much used in future. Dried blood spot specimens may be used in genetic testing and molecular diagnostic assays. So to conclude, I request every clinician to be very observant in diagnosing the oral precancer and cancerous lesions, as many of the times what we see may only be the tip of the iceberg and not the whole of the iceberg. Thank you so much.
Hello.
So it's time for the felicitation of our guest speakers, and after that we'll commence with the activities of the evening. I would request Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to come on stage for the felicitation of the speakers. First one. First, I would like to call upon Dr. Suyog Sawant sir. I would like to request Dr. D.N. Kapoor sir to please join Anmol ma'am and Ashish sir on stage. I would like to request Dr. Pavitra Rastogi sir to join sir and ma'am on stage. Next, I would like to call upon Dr. Shravan Kumar Singh sir, then Dr. Anupriya Tomar ma'am, Dr. Anupriya Tomar ma'am, please come on stage. Then I would like to request Dr. Priyanka Singh ma'am to please come on stage. Next, I would like to call upon Dr. Tanvi Saraf ma'am. Dr. Tanvi Saraf ma'am on stage. Thank you, respected dignitaries on stage. After 10 minutes, we'll be starting with the cultural events and the other events of the evening. I would request you all to take the break of 10 minutes.
Good evening, everyone. And so the most awaited time of the day is here, and we've been waiting for it for the whole day, being tired, doing paper presentations and poster presentations. But finally, we're here to the end of the function. And I'd like to state that here we have Himeshwari Raghuvanshi, intern from BDS, who is going to perform in front of us the Saraswati Vandana. So kindly, ma'am, I'd like to have you on stage for the Saraswati Vandana.
So we are starting with our cultural events, that is the Dento Utsav. I would request the cultural coordinators to please come on stage and start with the program.
We're definitely sorry for the delay. We're starting with our poetry competition, and I'd like to call upon the stage Rashi for her poetry presentation here.
नमस्कार, आप सबके सामने मैं एक कविता प्रस्तुत करने जा रही हूँ जिसका कि शीर्षक है चुप रहना नहीं। किसी के डराने से डरना नहीं, कभी पीछे हटना नहीं, लगे कुछ भी गलत अगर आवाज़ उठाना, चुप रहना नहीं। ऐसे बहुत देखे होंगे जो बेटा बिटिया कहकर पास आते होंगे, बेचैनी सी सताती होगी, बातों में उनकी नियत भी झलक जाती होगी। उनसे तुम डरना नहीं, कभी पीछे हटना नहीं, लगे कुछ भी गलत अगर आवाज़ उठाना, चुप रहना नहीं। अच्छा, हमने छोटे बच्चों को देखा है कि बहुत हिचकिचाते हैं, डरते हैं, तो सिंस मेरी पोइट्री उसी पर है, चाइल्ड अब्यूज़ पर है, तो उनके लिए मैंने लिखा है, अगर अकेले हिम्मत नहीं जुटा पा रहे हो, किसी अपने से भी कहने में हिचकिचा रहे हो, तो उठाओ फ़ायदा सरकार की हेल्पलाइन का, क्यों नहीं 1098 पर फ़ोन घुमा रहे हो। फ़ोन लगाने से डरना नहीं, कभी पीछे हटना नहीं, लगे कुछ भी गलत अगर आवाज़ उठाना, चुप रहना नहीं। अब देखिए, हम अपने बच्चों को ये तो बोलते हैं कि घर के बाहर बहुत केयरफुल रहना है, स्ट्रेंजर से एक डिस्टेंस मेंटेन करना है, बट क्या हम घर के अंदर भी उन्हें सेम सीख देते हैं? घर के बाहर आंखें खोले रखना, घर के बाहर आंखें खोले रखना, बाहर वालों को ज़रा ठीक से परखना, लेकिन कभी कभी घर के अंदर वाला भी चोट पहुंचा सकता है, तो अपने करीबी को भी ज़रा करीब से देखना। कोशिश करना लोगों को समझने में, गलती करना नहीं, कभी पीछे हटना नहीं, लगे कुछ भी गलत अगर आवाज़ उठाना, चुप रहना नहीं। ये बातें हमेशा याद रखना, बहादुर हो तुम, खुद पर भरोसा रखना। कुछ भी हो बस डरना नहीं, कभी पीछे हटना नहीं, लगे कुछ भी गलत अगर आवाज़ उठाना, चुप रहना नहीं, चुप रहना नहीं। धन्यवाद।
Next, I'd like to call upon the stage Shimal Goyal from Subharti Dental College. She's a first-year student who's going to be presenting her poetry in front of us.
The name of my poetry is My Dentist. My dentist knows my mouth intimately. And like any man who recognizes a lover across a crowded room merely by her stance or the way she tosses her hair, my dentist recognizes me by the composite fillings and the caps on my teeth. Reclined under the veil of Novocaine, I listen to his and a dental assistant's either as he wails his drill, meticulous and finely tuned, with gloved hands explores every nook and cranny of my gapped mouth. Reclined there, I wonder if it's true what they say. That's a dentist's first impression is based on your smile, the degree of whiteness, how big the gap is between my mouth and your teeth. At the end of his day, does he take our teeth home with him? Each extraction and filling a story to be tossed over salad as he dines with his family. an example to his children as the reason as to why they should always brush their teeth. Does he dream our teeth at night? The decayed ones surfacing in nightmares to mock him, in which he runs aimlessly through forest, fog, or the dead of night, searching in vain for a dental tool that will extinguish them, while the healthy teeth shimmer in pleasant dreams, lined up like rows of sailors standing at attention in their dress whites, each saluting as he pauses before them. The words, excellent, brilliant, beautiful, rolling off his tongue. Thank you.
Thank you, Shimal, for that wonderful poem. It was really motivating for each of us dentists to hear that up. Up next, we have Abu Bakr from Career Dental College, and I'd like to invite him for his poem competition.
गुड इवनिंग रिस्पेक्टेड टीचर्स एंड एवरीवन प्रेजेंट हियर। तो फिर मेरा नाम है अबू बकर और आज मैं आपके सामने अपने ज़िंदगी की एक दास्तां पेश करने वाला हूँ। तो फिर मैंने ज़िंदगी की दास्तान को एक गज़ल के रूप में पेश किया है और गज़ल का नाम है ज़माने हाल। तो फिर शुरू करते हैं। वो सफ़र भी बड़ा तवील था, वो वक्त भी बड़ा अजीब था। शुरुआत हुई मेरी बीमारी से, शुरू करते हैं अपनी कहानी से। तो फिर जैसा आप लोग को समझ में आ गया होगा, मैं बचपन में काफ़ी बीमार रहा करता था। ये भी कह सकते हैं कि बचपन मेरा बीमारी में गुजरा है और मेरे माँ बाप मेरे बहुत सहारे के रूप में आए थे उस टाइम पे। शुरुआत हुई मेरी बीमारी से, शुरू करते हैं अपनी कहानी से। जब मैं उठा इस ज़माने में, ज़माना भी बोला तू हट इस ज़माने से। मैं घिर गया था दुनियावी ख्यालों से, हिम्मत थी मेरी मेरे माँ बाप के सहारों से। छोटी चीज़ें मुझे डराया करती थी, मेरी हिम्मत मुझे हराया करती थी। मैं लड़ रहा था अपने ज़िंदगी के लिए, पर वो ज़िंदगी मुझे सताया करती थी। तो फिर सबकी ज़िंदगी में थोड़ा बहुत होता है, अप्स एंड डाउन्स होते रहते हैं, मगर वक्त सबका बदलता है। वो वक्त बदल गया जिसमें ज़माने लग गए हैं, यारों को लगता है हम अपने गम गाने लग गए हैं। अब बहुत दर्दनाक सफ़र था ये हमारा। अब चलिए इसको बदलते हैं थोड़ा। अब थोड़ा आते हैं आगे ज़िंदगी के दूसरे पार्ट पे। तो फिर कहानी रुख बदलना चाहती है, नए किरदार आने लग गए हैं। और अब आते हैं दास्तान मोहब्बत पे। वो क्या खूब कहा है किसी शायर ने कि मेरे दास्तान हसरत वो सुना सुना के रोए, मेरे आज़माने वाले मुझे आज़मा के रोए। कोई ऐसा अहले दिल हो जो फसाना है मोहब्बत, मैं उसे सुना के रोऊं, वो मुझे सुना के रोए। तो फिर इब्तिदा होती है, इंट्रोडक्शन होता है। इब्तिदाए इश्क है रोता है क्या, आगे आगे देखिए जनाब होता है क्या। तो शुरू वैसे हुआ जैसे सबका शुरू होता है, पहले जान पहचान और फिर अनजान। हमारा भी वैसे ही शुरू हुआ। हम पहले दोस्त बने, फिर एक हादसा हुआ और हमने कह दिया कि आँखों की चमक पलकों की शान हो तुम, आँखों की चमक पलकों की शान हो तुम, चेहरे की हंसी लबों की मुस्कान हो तुम। धड़कता है दिल सिर्फ तुम्हारे आरज़ू में, तो कैसे ना कहूँ कि मेरी जान हो तुम। तो फिर शुरुआत हुई आपके अल्फाज में, ख़त्म करेंगे हम अपने अंदाज में। हादसा हुआ था, हमने कह दिया और फिर ये ख़त्म भी हो गया। ख़त्म ऐसे हुआ, वो था ज़माना गुज़र गया कब का, वो था दीवाना मर गया कब का। अपना जो दर्द है वो वही जाने, अपना तो जख्म भर गया कब का। तो फिर कुछ हादसात हुए, कुछ हादसात मुझे बहुत कुछ सिखा दिए, कुछ हादसात मुझे बहुत कुछ सिखा दिए। मोहब्बत का दर्जा अलग है, मोहब्बत का दर्जा अलग है, हमारी नज़रों में मोहब्बत गिरा दिए। सिहाई ख़त्म होने को है, अल्फाज नहीं रुक रहे, सिहाई ख़त्म होने को है, अल्फाज नहीं रुक रहे, इश्क ने मुझे दोबारा जिला दिया। मैं कलम से दिल की आवाज़ लिखता हूँ, मैं कलम से दिल की आवाज़ लिखता हूँ, गम और जुदाई के अंदाज में मैं बयान लिखता हूँ। रुकते नहीं मेरे आँखों से आंसू, रुकते नहीं मेरे आँखों से आंसू, जब भी उसके याद में मैं अल्फाज लिखता हूँ। अब 2 लाइन में मैं अपनी बात ख़त्म कर देता हूँ, आप लोग का बहुत टाइम ले लिया मैंने। सोचा कि अब तेरे सिवा कुछ सोचूं, सोचा कि अब तेरे सिवा कुछ सोचूं, अब तक इसी सोच में हूँ कि और क्या सोचूं। थैंक यू।
To make the evening more mesmerizing, Evelyn Raj is here to present a beautiful song.
Well, you have to see me one more time. So it will be great. Maybe it's the way you say my name. Maybe it's the way you say my name. So good, I've never dreamed anybody like you. So good, I've never known anybody like you. And I've heard a love that comes once in a lifetime. And I'm pretty sure that you are that love of mine. 'Cause I'm in the field of dandelions, wishing on everyone that you be mine. Mine. And I see forever in your eyes, and I feel okay when I see you smile. Smile. Wishing on dandelions all of the time, praying to God that one day you'll be mine. Wishing on dandelions all of the time, all of the time. Dandelion into the wind you go, won't you let my darling know? And dandelion into the wind you go, won't you let my darling know? And I'm in the field of dandelions, wishing on everyone that you be mine. Mine. And I see forever in your eyes, I feel okay when I see you smile. Smile. Thank you.
Wow, what a beautiful song it was. Now we are having Upasna Patel here to present a very beautiful song. Can we have a big round of applause?
That was a melodious performance. Coming next is Gaurish Batra from Subhati Dental College, Meerut. He's gonna rock the floor with his guitar.
आगे 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 सर
जब तेरे पास मैं आया एक सुकून मिला जिससे मैं था भूलता वो वजूद मिला जब आए मौसम गम के तुझे याद किया जब सहमे तन्हापन से तुझे याद किया संभल जा जरा मोहब्बत करने चला तू यही रुके जा जरा मोहब्बत करने चला तू जिस राह पे तेरा अक्सर वहाँ से था मैं तुम्हारा शायद यही दिल मेरा तू मुझको मिल जाए क्या पता क्या है ये सिलसिला जानू ना मैं जानू ना हो दिल करने चला यही रुके जैसा मोहब्बत करने चला
Wow, what a beautiful song it was. Now, to make the evening more energetic, mesmerizing, Spandan Mukherjee is here to present the song.
हेलो हेलो
मेरी
That indeed was a splendid performance. Thank you, Spandan, for enlightening us today in the evening here. Well, now I'd like to invite Dr. M. Vishnuvardhan for his next performance here.
हेलो हेलो
सर वो ना जब बोलूँगा तब चालू करेगा और वॉल्यूम वॉल्यूम एडजस्ट कर लीजिएगा
हेलो
ये बीच में हूँ
हेलो 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 हेलो
Good evening everyone. Myself Dr. M. Vishnuvardhan and today I am going to sing a song which name is Chand Sifarish.
चांद सिफारिश जो तेरे का हमारी देता वो तुमको बता शर्म हया के पर्दे गिरा के करनी है हमको खता खुद है अब तो है खुद को मिटाना होना है तुझ में फना हो चांद सिफारिश जो करता हमारी देता वो तुमको बता शर्म हया के पर्दे गिरा के करनी है हमको खता भी है झोंके वाली छुप गुजर जाने दे तेरी लचक है कि जैसे डाली दिल में उतर जाने दे आजा बाहों में चढ़ के बहाना होना है तुझ में फना हो चांद सिफारिश जो करता हमारी देता वो तुमको बता शर्म हया के वो पर्दे गिरा के करनी है हमको खता थैंक यू
It's time for us to seek blessings of God, and we would again have to call Dr. Himanshwani Raghuvanshi for her Saraswati Vandana presentation.
तस्मै श्री गुरवे नमः।
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि।
Up next we have Kamar Raza for his singing presentation. I'd like to have you here on stage, sir.
गुड इवनिंग एवरीवन। तो मैंने एक रैप लिखा है जिसका नाम आजमाइशें है और ये एक रिलेशनशिप की पूरी कहानी है। तो बताइएगा कैसा लगता है और थोड़ी हुटिंग वगैरह हो तो और अच्छा लगेगा।
चला मगर रास्ता ना मिला, मैं उन्हें लगा मगर आसमान ना दिखा। मैं कहता रहा पर ना हुआ कुछ बयां, मैं हंसने लगा मगर गम ही गम था भरा। आते जाते पूछते हैं तेरा काम क्या है, सालों बाद उससे मिला उसने पूछा तेरा नाम क्या है। लाजवाब हो गया और पूछा सवाल क्या है,
किताब खाली मेरे दिल में ये मजाक क्या है, जिंदगी बेजार तो निगम से क्यों टिके हैं, किताबों पे नाम मिटा तो खत ही क्यों लिखे हैं, तेरे इंतजार में जिंदगी ये बीत गई, फैक्ट फिर मैं हार गया, मोहब्बत जीत गई, जिस्म का सुरूर तू अब मेरा सिर्फ एक बाजू है, तू मेरे पास हो साथ तो जाना तुझे आरज़ू, तारीफ भी क्या करूँ तेरी नजरों में जादू है, पहले तू पर बेकाबू है, सितारे तोड़ूंगा नहीं वो खुद आएंगे, हम दोनों ही सितारे थे सितारे हमें बुलाएंगे, तू जी जी के भुगती मैं घुट घुट के जीता हूँ, तुझे पता है मैं ऐसे नहीं पीता हूँ, यादें आती तो यादें भुला देता, ज्यादा याद आए तो खत ही जला देता, वो खत नहीं हालत दिले और गम, नए रिश्ते क्यों कायम करे हम, बिछड़ लो तुम ऐसे ही झगड़ा क्यों करे हम, अपने जाने की वजह तो बताती जाता कि सारे गम तो हम करे कम, उदास बैठे दोस्त है पूछ यार यू हैविंग फन, नुक्स है कुछ मेरे हर बयान में, क्या मैंने लिखे थे मेरे गानों के बोल अभी भी है तेरी जबान पे, क्या प्यार का मैं खेल खेल रहा पता नहीं इनाम में क्या, इफ आई डाई मेरी कब्र पे ना आना तुम, और अगर आ गए तो रोए बिना ना जाना तुम, नशे में हम खास थे तेरे वो आसरे, जो लिया मुझसे वादा उसे ठीक से निभाना तुम, मैं जिए चला मगर रास्ता ना मिला, मैं उन्हें लगा मगर आसमान ना दिखा, मैं कहता रहा पर ना हुआ कुछ बना, मैं हंसने लगा मगर गम ही गम था भरा,
Thank you so much, Dr. Kamar Raza. It was very nice to hear you. And since we've been listening to a lot of solo songs, so it's time for a musical performance, right? Let's have on stage a group performance, a group singing performance by Subharti Dental College. And I'd like to call upon Dr. Devansh Bhatnagar sir, Samriddhi ma'am, Spandan, Gaurish, Aditya, and Rupali Pandey on stage to have a group singing performance.
दोस्ती हम नहीं तोड़ेंगे, तोड़ेंगे हम मगर तेरा साथ ना छोड़ेंगे, ये दोस्ती हम नहीं तोड़ेंगे, तोड़ेंगे हम मगर तेरा साथ ना छोड़ेंगे। हसीनों ने बुलाया, गले से भी लगाया, बहुत समझाया यही ना समझा। हसीनों ने बुलाया, गले से भी लगाया, बहुत समझाया यही ना समझा। बहुत भोला है बेचारा, न जाने किस पे आएगा, है अपना दिल तो आवारा, न जाने किस पे आएगा।
That was quite a mesmerizing performance. I must say, back-to-back mesmerizing performances from Subhati Dental College, Meerut. So, coming next is Vidushi Mishra with her solo singing.
आज जाने की जिद ना करो, आज जाने की जिद ना करो, आज जाने की जिद ना करो। हाय मर जाएंगे हम तो लुट जाएंगे, ऐसी बातें किया ना करो, आज जाने की जिद ना करो। तुम ही सोचो जरा क्यों ना रोके तुम्हें, जान जाती है जब उठ के जाते हो तुम, तुमको अपनी कसम जाने जा उम्र भर ना तरसती रहो, आज जाने की जिद ना करो। जिंदगी है मगर चंद घड़ियाँ यही है जो आजाद है। इनको खो के मेरी जाने जा उम्र भर ना तरसती रहो। आज जाने की जिद ना करो। आज जाने की जिद ना करो।
What a beautiful performance it was. Now, with his beautiful skills and a beautiful voice, Aryan Sekho is here to present himself.
हेलो, थोड़ा बेस दे, थोड़ा बेस चाहिए माइक में। बढ़ाना। हेलो 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 हेलो। Good evening to one and all present here. Myself Aryan Sekho from SGRD Dental College, Amritsar. My father was from the same college. He was from the pioneer batch. After 30 years, I am from the same college, studying BDS over there. I feel proud and blessed at the same time to represent my college at this such a big platform. Today I am performing, so एक गीत है, थोड़ा सूफी में गाऊंगा। हो सकता है आप लोगों को मेरी लैंग्वेज समझ ना आए, बट वेयर एज आई फील म्यूजिक की कोई लैंग्वेज नहीं है. इट इज जस्ट एनर्जी एंड वाइब ट्रांसफरिंग फ्रॉम वन सोल टू अनदर. ਅਲਫਿਓਸ ਤਰਿੰਜਣ ਵਿੱਚ ਕੱਤਣਾ ਕੀ ਜਿੱਥੋਂ ਨਾਲ ਦੀਆਂ ਚਰਖੇ ਚੁੱਕ ਗਈਆਂ. ਅਲਫਿਓਸ ਤਰਿੰਜਣ ਵਿੱਚ ਕੱਤਣਾ ਕੀ ਜਿੱਥੋਂ ਨਾਲ ਦੀਆਂ ਚਰਖੇ ਚੁੱਕ ਗਈਆਂ. ਹੋ ਗਈਆਂ ਤੇ ਬਾਗ ਬਰਬਾਦ ਹੋ ਗਏ. ਉਹ ਪੱਤੇ ਟੁੱਟ ਗਏ, ਸ਼ਾਖਾਂ ਸੁੱਕ ਗਈਆਂ. ਵੇ ਮਾਇਆ ਤੇਰੇ ਵੇਖਣ ਨੂੰ, ਵੇ ਮਾਇਆ ਤੇਰੇ ਵੇਖਣ ਨੂੰ, ਵੇ ਮਾਇਆ ਵੇ ਮਾਇਆ ਵੇ ਮਾਇਆ ਤੇਰੇ ਵੇਖਣ ਨੂੰ, ਵੇ ਮਾਇਆ ਤੇਰੇ ਵੇਖਣ ਨੂੰ ਚੁੱਕ ਚਰਖਾ ਗਲੀ ਦੇ ਵਿੱਚ ਡਾਵਾਂ. ਵੇ ਮਾਇਆ ਤੇਰੇ ਵੇਖਣ ਨੂੰ ਚੁੱਕ ਚਰਖਾ ਗਲੀ ਦੇ ਵਿੱਚ ਡਾਵਾਂ ਵੇ ਲੋਕਾਂ ਪਾਣੇ ਮੈਂ ਕੱਤਦੀ ਤੰਦ ਤੇਰੀਆਂ ਯਾਦਾਂ ਦੇ ਪਾਵਾਂ ਵੇ ਲੋਕਾਂ ਪਾਣੇ ਮੈਂ ਕੱਤਦੀ ਤੰਦ ਤੇਰੀਆਂ ਯਾਦਾਂ ਦੇ ਪਾਵਾਂ ਵੇ ਮਾਇਆ ਤੇਰੇ ਵੇਖਣ ਨੂੰ ਓ ਚਰਖੇ ਦੀ ਕੂ ਕਰਦੇ ਓਲੇ ਚਰਖੇ ਦੀ ਕੂ ਕਰਦੇ ਓਲੇ ਯਾਦ ਤੇਰੀ ਦਾ ਤੂੰਬਾ ਬੋਲੇ ਯਾਦ ਤੇਰੀ ਦਾ ਤੂੰਬਾ ਬੋਲੇ तेरा तूंबा बोले तेरा तूंबा बोले तेरा तूंबा बोले वे तेरा तूंबा बोले वे हो अखियां उड़ीक दियां दिल वाजा मारदा अखियां उड़ीक दियां दिल वाजा मारदा आजा परदेसिया आजा परदेसिया आजा परदेसिया वास्ता ही प्यार दा आजा तेनू अखियां उड़ीक दियां डोलना तेनू अखियां उड़ीक दियां आजा 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 तेनू अखियां उड़ीक दियां आजा डोलना तेनू अखियां उड़ीक दियां आजा मेहरमा तेनू अखियां उड़ीक दियां
Graceful, mesmerizing, flawless are some beautiful words that a dancer would love to hear. For the same words, our next participant, Riddhi Mittal from Subhati Dental College, is here to present a beautiful performance. Wow, What a beautiful performance that back-to-back Subharti Dental College participants are giving here. Now again for a beautiful song, Samriddhi Singh is here to present her performance.
जाने कैसे बांधी तूने जाने कैसे बांधी तूने अखियों के डोर मन मेरा खिंचा चलाया तेरी ओर मेरे चेहरे की सुबह जुल्फों की शाम मेरा सब कुछ है पिया अब से तेरे नाम नजरों ने तेरी छुआ तो है ये जादू हुआ होने लगी हूँ मैं हंसी आफरी 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 आफरी
Be a slave, I wanna be.
Every day is a fashion show and the world is your runway. Today, Syed Sahiba is here to present herself in a fashion show.
I wanna be a slave, I wanna be a master. I wanna make your heart beat round like roller coasters. I wanna be a good boy, I wanna be a gangster. Cause you could be the beauty and I could be the monster. I love you since this morning, now just move as nothing. I wanna touch your body so fucking electric. I know you're scared of
With a very beautiful voice, South Subhan is here to present a song.
Hello. Hi everyone, this is South Subhan from KGMU College and I'm here to represent my college by singing one solo song. Start. तो क्या हुआ जो टूटा आज सपना ये तेरा तो क्या हुआ जो आज कोई अपना ना मिला कभी तो पूरा होगा ये चाहतों का घर कभी तो मिल ही जाएगा तुझको हम सफर तुझ में ना कमी कोई है बस तेरा ये दिन बुरा वक्त की ये बात है इसे गुजर जाने दो तो क्या हुआ जो टूटा आज सपना ये तेरा, तो क्या हुआ जो आज कोई अपना ना मिला। कभी तो पूरा होगा ये चाहतों का घर, कभी तो मिल ही जाएगा तुझको हम सफर। तुझ में ना कमी कोई है बस तेरा ये दिन बुरा, वक्त के ये बातें हैं इसे गुजर जाने दो। मुस्कुराना चाहे तो डरने लगता है, कहीं नजर तेरी खुशी को ना लगे। किसी पे आना चाहे तो कैसे आए दिल, ये फिर से टूटने के ख्याल से डरे डरे। थैंक यू।
Fashion has always been repetition of ideas, but what makes it new is the way you put it on together. So, the team of Subharti is here to present a fashion show on a very creative theme, that is cartoons as Gen Z. So please put your hands together and make a huge round of applause for them.
पहाड़ों के ऊपर जंगल के पार देखो कौन अपने शहर आया यार, निंजा हथौड़ी अपने घर आया यार। बड़ी बड़ी आंखें और मुंह है छोटा सा, सिर पे है टोपी और काल मोटा सा। तेजी का इसकी नहीं कोई ठिकाना, कितना है पक्का देखो इसका निशाना।
It's the Mickey Mouse Clubhouse. Come inside, it's fun inside. It's the Mickey Mouse Clubhouse. Come inside.
A whole new world, a new fantastic point of view. No one to tell us no, or where to go, or say we're only dreaming.
A whole new world, a dazzling place I never knew. But when I'm way up here, it's crystal clear that now I'm in a whole new world with you.
Now I'm in a whole new world with you.
जिंदगी सवार दो, एक नई बहार दो,
After these wonderful and power-packed performances, it's time to continue the evening and proceed to the award ceremony. But before proceeding to the award ceremony, I would like to invite Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir on stage for the felicitation of our guest speakers, of the remaining guest speakers. I would also like to request Dr. Pavitra Rastogi sir to join sir and ma'am on stage. And also Dr. R.K. Patil sir, Dean Faculty of Dental Sciences. Dr. Pavitra Rastogi sir and Dr. Patil sir. The first one to be felicitated is Dr. Nandalal sir. I would request Dr. Nandalal sir to please come on stage. Now I would request Dr. A.P. Tikku sir to please come on stage. Dr. Balasundari S. Dr. Balasundari S. ma'am. Thank you, sir and ma'am. I would request you all to please proceed to your respective seats. Before starting with the award ceremony, first, we will be starting with our fellowship felicitation. After the Northwest University examination, we are releasing the fellowship today. I would request Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to please come on stage and start with our fellowship felicitation. I would also request Dr. R.K. Patil sir to accompany sir and ma'am on stage. We are releasing the fellowship today. First one is Dr. Pavitra Rastogi sir. Please give a round of applause for sir. Dr. Nandalal sir. Dr. Amit Agarwal, sir. So this was our fellowship felicitation. Thank you, sir and ma'am. Once again, I, Dr. Anam Siddiqui, your Master of Ceremony for the conference, welcome you all to this extravagant evening of the International Dentist Awards, recognizing and honoring legends of dentistry across the globe. It will be later on followed by cultural DJ musical night, and all this will wrap up the day 3rd of our International Dentist Convention and 8th World Dental Sciences and Oral Health Conference by CynoDent International and Indian Society of Dentistry in collaboration with Department of Periodontology and Implantology, Faculty of Dental Sciences, King George's Medical University, Lucknow, and King George's Society of Periodontology. Along with academics, there is need of appreciation, acknowledgement, and that is why this evening is all about fun and appreciation, and for acknowledgement, we have initiated with International Dentist Awards organized in order to recognize and honor respected fraternities and the associated people of dentistry, and this ceremony is initiated and organized by none other than CynoDent International and Indian Society of Dentistry. It is with the divine grace of Almighty that we have been able to come this far today. I congratulate Dr. Anmol Bagaria, ma'am, CEO, CynoDent International and President, Indian Society of Dentistry, along with Dr. Ashish Chandra sir, Director, CynoDent International and Vice President, Indian Society of Dentistry for this grand success. Let's congratulate sir and ma'am and CynoDent with a round of applause, ladies and gentlemen. Along with ma'am and sir, we feel immensely honored to have amongst us this charismatic array of dignitaries amongst us and our dear delegates. It's a pleasure for CynoDent International and Indian Society of Dentistry to host everyone present here today. Today we have gathered here to honor the exemplary and the very inspirational personalities of our dental fraternity who work day in and day out at the very ground level and have done some amazing work in our field. It is a proud moment not only for them but for all of us who are present here, because these are the people taking our fraternity and our profession forward and contributing in its excellence and beyond, and also uplifting our honorable profession of dentistry. As it is said, appreciation can change a day. It can even change a life, but your willingness to put it into words is all that's necessary. This award show is CynoDent's small initiative to acknowledge and honor the hard-working dental fraternity on the whole. We have various categories nominating dental students, clinicians, academicians, and of course, the foundation stone of every dentist education, the Dental College of India. Before starting with the award ceremony, I would like to again invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. A.P. Tikku sir, Dr. D.N. Kapoor sir, and Dr. R.K. Patil sir on stage to commence with the award ceremony. Also Dr. Pavitra Rastogi sir. Dr. D.N. Kapoor sir, Dr. A.P. Tikku sir, Dr. Pavitra Rastogi sir, Dr. R.K. Patil sir, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir. I'll announce category by category. So, the first award is Best Private Dental College of UP, and it goes to Subharti Dental College and Hospital. Please give a round of applause for all the awardees. I request all the Subhartians to please come on stage, gather around the stage and collect your award. Next award is for the Magnificent Oral Medicine and Radiologist of the Year, and the award goes to Dr. Sumit Goyal sir. Next award is the Emerging Dental Clinic of the Year, and it goes to Gentle Dental Clinic. I would request Nitin sir to please collect the award. Please give a round of applause for sir. Next award is for the Female Dental Leadership Award, and it goes to Dr. Neeta Mishra ma'am. Dr. Neeta Mishra ma'am as the Female Dental Leadership Award. Next award is the Forensic Odontologist of the Year, and it goes to Dr. Jayasankar P. Pillai sir. Next award is for the Emerging Public Health Dentist, and it goes to Dr. Shweta Singh ma'am. Dr. Shweta Singh ma'am for the Emerging Public Health Dentist. Next is the Magnificent Periodontist of the Year, and the award goes to Dr. Gunjan Yadav ma'am. Dr. Gunjan Yadav ma'am, Magnificent Periodontist of the Year. The award for the Forensic Odontologist of the Year goes to Dr. Jayasankar P. Pillai, sir. Dr. Jayasankar P. Pillai, sir, Forensic Odontologist of the Year. Please give a round of applause for sir. Budding Dentist of the Year goes to Dr. Abhay Pratap Singh. Budding Dentist of the Year, Dr. Abhay Pratap Singh. Next one is Magnificent Orthodontist of the Year. It goes to Dr. N. Padmapriya, ma'am. Magnificent Orthodontist of the Year, Dr. N. Padmapriya, ma'am. Emerging Dental Administrator of the Year, and the award goes to Dr. Akhil Manoka. Dr. Akhil Manoka, sir, as the Emerging Dental Administrator of the Year. Dental Creator of the Year, and the award goes to Dr. Misbah Kadri. Dr. Misbah Kadri, Dental Creator of the Year. Another female to get the award in the same category, Dental Talent of the Year, it goes to Dr. Priyanka Khinchi. Dr. Priyanka Khinchi. Dental Talent of the Year. Dental Talent of the Year. Female. Dental Talent of the Year, male, it goes to Dr. Shubham Bharti. Dr. Shubham Bharti, Dental Talent of the Year. Now the award for the research in the field of oral pathology, it goes to Dr. Neha Upadhyay. Dr. Neha Upadhyay, ma'am, for the research in the field of oral pathology. Please give a round of applause for ma'am. Now the Student of the Year, PG, PEDO, goes to Dr. Avni Ramesh. Dr. Avni Ramesh, Student of the Year, PG, in the Department of Periodontics. Magnificent Dean of the Year, and the award goes to Dr. Ranjit Patel, sir. Patel, sir. Dr. Ranjit Patel, sir, who is already present on the stage with us. Magnificent Dean of the Year, Dr. Ranjit Patel, sir. Now the best academician of the year, it goes to Dr. Nandlal sir. The best academician of the year, Dr. Nandlal sir. I would request Dr. Nandlal sir to stay back on the stage and continue with the award ceremony along with respected sir and ma'am. Thank you, sir. Now, the next category is the budding dentist of the year, and it goes to Dr. Ashutosh Kumar. Dr. Ashutosh Kumar, the budding dentist of the year. Next is student of the year PG, Perio department, and it goes to Dr. Ahad ul Haq. Dr. Ahad ul Haq, student of the year PG Pedo, Perio. Dental talent of the year UG goes to Dr. Khushi. Dr. Khushi, dental talent of the year UG. Intern of the year, and the award goes to Dr. Akshita Gupta. Dr. Akshita Gupta, intern of the year. Magnificent oral pathologist of the year, and it goes to Dr. Priyanka Singh ma'am. Dr. Priyanka Singh ma'am, magnificent oral pathologist of the year. Outstanding dentist of the year, and it goes to Dr. Shalu Rai ma'am. Dr. Shalu Rai ma'am, outstanding dentist of the year. And we congratulate you ma'am for the new joining in Agartala Dental College as the dean. Emerging implantologist of the year, it goes to Dr. Vinayak sir. Dr. Vinayak sir, the emerging implantologist of the year. Best Academician of the Year Female, Dr. Balasundari S. Ma'am. Dr. Balasundari S. Ma'am, Best Academician of the Year. Best Overseas Dentist of the Year is Dr. Raghu Dhanpal Sir. Best Overseas Dentist, Dr. Raghu Sir. Budding Practitioner of the Year, and the award goes to Dr. Nauman Sheikh. Budding Practitioner of the Year, Dr. Nauman Sheikh. Now the award for the Passionate Dentist of the Year goes to Dr. Puran Chand Sir. Dr. Puran Chand Sir as the Passionate Dentist of the Year. Emerging Orthodontist of the Year, and the award goes to Dr. Anupriya Tomar Ma'am. Emerging Orthodontist of the Year. Please give a round of applause for all the awardees. It will boost the Dr. Anupriya Tomar Ma'am as the Emerging Orthodontist of the Year. The Innovative Dentist of the Year, Dr. Chinmay Hazarika. Budding Dentist of the Year, Dr. Riddhi. The next award is Budding Dentist of the Year, and it goes to Dr. Riddhi. Please give a round of applause. Magnificent Periodontist of the Year, Dr. Sanjeev Kumar Salaria Sir. Best Dental Laboratory in UP, ESD Dental Lab. ESD Dental Lab, Best Dental Laboratory in UP. Next is the Best Dental Group Award, and it also goes to ESD Dental Group. The Best Dental Group, ESD Dental Group. the best government dental college, and it goes to none other than Faculty of Dental Sciences, KGMU. The best government dental college, Faculty of Dental Sciences, KGMU. I would request everyone to accompany Sir and Ma'am on stage. I would request Dr. Ashutosh Kumar sir to please collect his award for Budding Dentist of the Year. Dr. Ashutosh Kumar sir, Budding Dentist of the Year. Dr. Ashutosh Kumar for Budding Dentist of the Year. Dr. Ashutosh Srivastav for the Budding Dentist of the Year. Intern of the Year male goes to Dr. Devansh Bhatnagar. Dr. Devansh Bhatnagar, Intern of the Year. Intern of the Year female goes to Dr. Sakshi Varshine. Intern of the Year female, Dr. Sakshi Varshine. Magnificent Periodontist of the Year, Dr. Manish Khatri sir. Dr. Manish Khatri sir, Magnificent Periodontist of the Year. Dr. Pinky Mathur sir, Pinky Mathur ma'am as the Magnificent Prosthodontics of the Year. Dr. Pinky Mathur ma'am, the Magnificent Prosthodontics of the Year. The Student Friendly Dental College Award goes to SGRD Dental College. Student Friendly Dental College, SGRD Dental College. All the ones who are present here from SGRD Dental College can come to the stage and collect award on behalf of your college.
Now the prestigious Dental Diva of the Year award goes to the gorgeous, beautiful, multi-talented girl in the house, Dr. Anam Siddiqui ma'am. The next award goes to Outstanding Researcher of the Year to Dr. Shalini Gupta ma'am.
I would request Ahad sir to please come backstage. I would request Dr. D.N. Kapoor sir and Dr. Nandlal sir to please move back to their respective seats. Dr. D.N. Kapoor sir. Next is the most prestigious award of the evening and our award ceremony, the Lifetime Achievement Award. And with great pleasure, I, on behalf of CynoDent International, feel extremely grateful for the presence of two honorable dignitaries with us this evening who will grace this award tonight. These two people have dedicated their life and soul for uplifting the faculty of dental science and contributed in making KGMU the brand it is today. It's our honor to host both these eminent personalities with the Lifetime Achievement Award. But before moving on to the award, I would request Dr. Ahad sir to please come on stage.
ठीक है।
Think, write, and spread the light of knowledge as you speak. Be a guiding star to the lands which are dark, which are bleak. One such guiding star amongst the Faculty of Dental Sciences is Professor Nandlal sir. I would like to call him on stage to felicitate our Lifetime Achievement Award winners. It takes care to be a leader. It takes wisdom to be a guide. It takes a soul to be a teacher, the one who guides you through a tide. Having guided several scholars, students, and budding dentists to the heights they aspire to reach, Dr. A.P. Tikku sir and Dr. D.N. Kapoor sir have proven to be mentors par excellence. Tonight, we would like to honor both with Lifetime Achievement Awards. I would like to request Dr. A.P. Tikku sir to please come on stage.
One thing I want to tell him, one thing I want to tell you, I want to say one couplet for Professor Asim Prakash Tikku sir. कहते हैं कि सूरज को दिया दिखाया नहीं करते और चांद के आगे तारे बोला नहीं करते. We all know that he dedicated his more than 40 years to the King George's Medical University. Sir is a complete man in all his aspects, not only in all the aspects of dentistry, all the aspects of life. He is a mentor, he is a guide, he is a teacher, teacher of teachers, but also he is a very good friend also to all these students. One thing I want to say, we love you, sir.
I would request everyone to please stand for the honor of this award and the awardee. Dr. A.P. Tikku sir. Please give a round of applause for sir. It's a pleasure for all of us to have you here, sir.
Sorry to take your place. Thank you. I want to thank you all, the organizers, especially Dr. Anmol, Dr. Ashish, Dr. Pavitra Stogi, and all the people associated with this organization. I've been watching Dr. Anmol for the last 5 years, and I've seen her grow tremendously, and I've seen this platform grow in these 5 years, and it's a lot of credit to her. A big round of applause to Dr. Anmol and her team. I've been here in this campus, for the last 45 years, and these, all my students, now professors and heads, they are very, very dear to me, and all of them have given me tremendous respect and affection and adulation, and what I have been, all what I have achieved in my life is this only what I have got from my students in all these years. I have received some of the awards, previously many awards have come my way, and this Lifetime Achievement Award today. I was destined to come here today because actually, ladies and gentlemen, I was scheduled to be in Helsinki today. But I got the bout of fever just a day before I had to travel, and I had to cancel in Helsinki. So here I am, God's wish, and thank you everybody for this. And I will also tell you this, that though I have received many awards in the, previously, but this time, for the first time, my entire family is here with me. My wife, Tripti, Dr. Tripti, my daughter Pari, my daughter-in-law Aishwarya, and my son Arnav, they are all here with me. So, हमसे आज बोले कि हम लोग सब चलेंगे आपके साथ. तो हम मन में सोच रहे होंगे सरऊ रिटायर होने जा रहे हैं, इसके बाद शायद मिले ना कुछ इनको. तो अब चलो इनके लिए ताली बजा दी जाए. Thank you everybody, and thank you for your presence here. I would also like just to invite my daughter, Pari, and my daughter-in-law, Aishwarya, up on stage to have a photograph with me. Please come quickly.
I would request Tikku sir's family to please come on stage. The whole family. And Tripti ma'am as well. I would also request Dr. Tripti ma'am. I would request please come on the dais and say a few words. Please come on stage. I would request Dr. Tripti ma'am to please come on the dais and say a few words.
I would really like to thank you all for this great honor which you have bestowed on him, which is really well deserved. And I'm saying this not because I'm his wife, but also an alumni of KGMC. And I've seen how much he has done for this institution. Thank you.
Thank you, ma'am. Thank you, sir. It's an honor to have you all here amongst us today. Now, the next, I would like to call Dr. D.N. Kapoor, sir, for the Lifetime Achievement Award. I would request everyone to please stand up in honor of sir and the award. Please give a round of applause for Dr. D.N. Kapoor, sir,